such cases, a visual field loss of the contralateral normal eye was present. There are some case reports where a complete transaction happened till the chiasma, or there has been a fracture line running across the optic canal where there was a visual field loss. However, there has been no case, even not even a single case reported of a visual field loss of the other eye. Why did we get such a finding? Because we generally tend to do visual field of the other contralateral eye in all cases of trauma in our wards. So it was
So Sahil,
Normally, I've seen many cases the luxation has occurred, but it gone into maxillary sinus.
right, sir.
I've seen many cases the eyeball is subluxated into the maxillary sinus. Even after doing, I've seen many blast injuries from Afghanistan and other places and
So
trauma. So MRI shown that eyeball is there, but clinically we see that something has happened. I don't know what happened. The eye is not present.
okay, sir.
So it's a good collection of cases and it is a good presentation.
Thank you so much, sir.
Dr. Shalini,
Dr.
Dr. Samriti, you want to say
Yeah,
something?
Dr. Sahil, I wanted to ask that in all trauma cases, as a routine, you guys are getting this visual field done.
Ma'am, as far as possible, if the cases are reported early in the day, if at all they are late in the evening, because the visual field areas of our clinical areas get closed after 5 o'clock. Generally, those cases which are reporting before 2 or 3, we generally get it done, ma'am.
Because as far as I understood, there was no complaint from the patient's side.
There was no, ma'am. There was no complaint from the patient at all.
So what was the sign to suspect, or what was the reason behind in your mind to check the other eye?
I wanted to ask
So
that.
again, as said, that it was a mere luck. We were just going through the visual fields,
Okay.
and then we found that definitely was there. And then we set back to see out what the hypothesis could be, because in 3 of the cases where there was transaction, where there was no transaction, there was quadrantenopia. But in the case with complete transaction, there was no quadrantenopia.
Okay.
Even after
Okay.
that,
Thank
this
you.
was a case. This was we have seen two more. Thank you so much, sir.
Okay. Okay. Samriti, you take on.
Yeah, just a moment. So I would like to invite Dr. Dipanjali to present the second paper. Dr. Dipanjali, are you there?
She has not joined in participants.
So we
So
can
all
skip
the
her.
next, yeah.
Yeah, we can invite Dr. Namita to present her paper.
I think she also not there.
Dr. Namita messaged me that she has joined, sir. I'll just
She
see.
is not visible here in the participants.
Exactly. Dr. Salil, are you there?
Salil.
Hello?
Yeah, Dr. Salil?
Yes. Hello?
He's there. Okay, we can hear. Yeah, you carry on.
Yeah, Dr. Salil, please continue with your free paper.
First slide. First slide. Respect judges and my colleagues. And the topic is surgical outcomes on joint reconstruction and novel Whitnell's ligament approach. No financial interest. The incidence of Marcus Ganjon winking syndrome is approximately 5%. The wink reflex consists of a momentary upper eyelid retraction followed by equal uplift of the lid to the equal or higher level than the normal fellow eye. Eyelids stimulation under ipsilateral pterygoid muscle and sometimes the masseter and temporis muscle. This response is followed by rapid return to the lower position. And this is basically aberrant connection between the motor branches of the trigeminal nerves innervating the external pterygoid muscle and the fibers of the superior division of the oculomotor nerve which supply the LPS muscle. The aim of the study to evaluate the surgical function and cosmetic outcome in a moderate to severe Marcus Ganjon doses to evaluate the recurrence of the disease after correction of the spatial emphasis on the pediatric age group and long-term follow-up, and to evaluate the mental status. So comes the institutional ethical committee clearance with informed written consent was obtained. The study is a prospective intervention of clinical study over a period of 3 years. and the sample size is 30. Inclusion criteria: moderate to severe Marcus Ganjovic kinetosis, age 4 to 40, ingartatosis, good Bell's phenomenon, patient who has given a valid written consent. Exclusion criteria: negligible Marcus Gun, patient having poor Bell's phenomenon, patient having cross Quinton deviations, corneal anesthesia, myasthenia gravis. So the results are the majority of the study age group is 18.32, 18.32 with standard deviation. The post-operative vertical palpebral pressure height is preoperative 5.5 to post-operative 9.3 after the after 1 year follow-up. Preoperative MRD1 value in affected eye mean value is 1.8 to post-operative after 1 year 3.96, and unaffected eye is 4 millimeter. Preoperative flickering, the affected eye mean value is 6.12. Post-operative 0.43. The value of the PFH, MRD1, and flickering were followed up to first month, 6 months, and 1 year. So this is a table and a progression of MRD1 below vertical palpebral fashion and flickering. Now this is a video. If the video is on, you can tell me. Can you see the video? Can you see the video? This is a Marcus Gun.
No, not right now, sir.
Marcus Gun skin incision made it directly approach to the Whitnell's ligament. Whitnell's ligament is detached from the LPS is detached from the Whitnell's ligament with dragging with 2 to 3 millimeter below the Whitnell's ligament, and all the attachment is cut, and it is cut from the superior border of the tarsal plate. Make the superior supratarsal complex, muscle complex is intact, and after that the tarsal
Video is not visible. Yeah,
it's not visible. Okay,
it's not visible, but your cursor is moving, but the video is not visible. I can't see. Can you see, Amriti?
I saw at the last moment, at the last time I saw the video. Okay.
Okay.
Age of the presentation is 10 to 20 years. Gender distribution is females. Right eye mostly involved, visual, and mean MRD is statistically significant, and flickering is no post-operative flickering. So MGA is a variant of congenital ptosis with a significant joint bilateral levator excision with fossillata. Is the surgery of choice. But we perform a novel surgical approach, that is Whitnell's ligament approach. The success rate is improved dramatically, especially in children. At first, the lead incisions made directly approach the Whitnell's ligament, 1 to 2 millimeters below the Whitnell's ligament, and then dissected. And part of the removal of Whitnell's ligament, LPS is meticulously dissected from the conjunctiva and reflected up to the superior about the tarsal, not to disturb the skin muscle complex. And 20 to 25 millimeter LPS appliance exercise make a wide gap between the tarsal plate and the Whitnell's ligament. Dissecting LPS appliance from the tarsal plate is surgically difficult. LPS already thinned out the fibrous intermediate of the conjunctiva, causes damage, and incomplete disinsertion, causes missing fibers or more. Especially patient under GA and children, the command of jaw movements, which is not possible. As the supratarsal skin muscle complex is undisturbed, introducing silicone rod is easier. It maintains the chip anchoring system and the lead contour as well. Due to minimal surgical manipulation, the post-operative lead healing and rehabilitation is much quicker. There is no chance of slippage of the silicone rod, revision surgery, and fixation of the silicone rod over the tarsal plate. So comes to a conclusion, overall anatomic function and cosmetic outcome is much better. The single-step short duration surgery, the risk of extensive bilateral surgical procedure is avoided. 1 year follow-up, there's no recurrence. None of the patients required a second surgical site. The novel surgical approach, the Whitnell's ligament approach, revolutionized the concept of MGJWS syndrome and surgical correction, and enormously improved the success rate. Video. Now let's start the video. This is a Marcus Gun. Can you see the video?
Yeah. Now it's available.
Yes. Now, yes, the skin incision is made similar to the opposite eye. Now, directly goes to the Whitnell's ligament, and the LPS is detached first from the Whitnell's ligament, not from the tarsal plate. And 20 to 25 millimeter LPS is dissected meticulously, and from the superior part of the tarsal plate, it is removed And here the supratarsal skin muscle complex is intact. So the anchoring system with the silicon rod by Fox pentagon muscle is much more efficient and no chance of slippage of this rod, and the lead contour is well maintained. And after that, the patient, after 1 week, there's no flickering. Operatively, we check the flickering, and after 1 week, there is no flickering of this patient. Okay.
Okay, Mandal, it's a good video, and the results that we have shown is quite remarkable. What complications or side effects you have seen after the surgery in your series?
Actually, when I special emphasis on Marcus gun on children, because we start a dissection from the tarsal plate to the vitreous ligament, and most of the time we just missing fiber. Now we change the direction from vitreous ligament to tarsal plate. When we change the direction, actually in the vitreous ligament, the LPS muscle is a little bit bulkier. And in respect to tarsal plate, it is thinner and intimately adhered to the conjunctiva. When you dissect, when there is command, where the command just move your jaw, it is not possible on the children under GA. So in adult, you can successfully when you approach from tarsal plate to vitreous ligament, but in children, when you approach it, most of the time you fail it because there is more chance of missing fiber when you dissect from the tarsal plate up to vitreous ligament. But if you dissect from vitreous ligament to tarsal plate, 100% maximum fiber is you should be excised, and the result is also. And moreover that the supratarsal skin muscle complex, when this structure is intact, your anchoring system is well, and you can do easily ptosis.
You are using in all cases this silicone rod, or you have used facial ETA?
No, I am using, this is a study, the inclusion is all the patient will study with the silicone rod. Silicone rod is now the choice of ptosis surgery, is much more easier and is available. There is no side of second side surgery like tarsal plate.
No, you require sometimes second surgery to tighten or lift the lid.
No. In this study,
it comes down.
If you, in this study, none of the slightly undercorrection is there, but it is cosmetically acceptable. The most of the preferable is the flick. The flick is completely abolished after this procedure. Mild undercorrection is there, the patient is cosmetically acceptable.
Any special precaution you have taken in cases under GA to ensure that all LPS is removed?
Actually,
how can we check?
One thing is that every meticulous dissection from the vitreous ligament, the LPS should be fanning out. All the attachments should be removed gradually. Sometimes your conjunctiva may be damaged, but I personally feel my surgical experience that when you remove from tarsal plate to vitreous ligament, the chances of fibers is missing. But that is why I changed the direction from vitreous ligament to tarsal plate, and 100% the chance of missing fiber is less. That is why I chose this procedure. And this paper is accepted in South Korea and presented in ARVO also in this year. And they decide why you are doing for posterior. So I approach is somewhat different. It's a vitreous ligament approach, not the posterior approach. Some say conjunctival approach, they are doing a Marcus, but that is very difficult. We go through skin route, but detach from the vitreous ligament. You can do it, whether I am wrong or right, you can make it. This is my experience. I have doing lots of things. When I go from tarsal plate in children, I have failed lots of time. And now I change this procedure from vitreous ligament to tarsal plate.
Okay. Dr. Samriti?
Yes, so Dr. Salil, just a single question. There was a study where levator extirpation with frontalis, a similar study which you have presented, but obviously the route was different, which you have taken from vitreous ligament and they were doing from the tarsals. So do you think that your results and their results are different? Because in that study also they have somewhere around a good success rate of 90% in which they removed.
I'm telling you, those who are dissecting from the tarsal plate, but this is my experience that the most of the time in pediatric, in adult no problem. You can command, hey, move your jaw, and you can detect the fiber operatively. But in pediatrics, when in GA, you cannot understand which fibers you are missing. That is the advantage. That from the that I have studied here in the LPS is a little bit bulkier near to the Whitnell's ligament, but it is much more thinner in the tarsal plate, and it is intimately adhered to the conjunctiva. That is I have observed, and lots of cases I have failed in pediatric age group, but after that I changed the direction, and it is 100% success, and people is not believe me. That is I am very sorry for that, because I am doing a study because I am telling from my medical college. Till now I am in COVID hospital and on COVID duty. Calcutta Medical College is one of the dedicated COVID hospital. I am doing surgery in COVID situation. You understand?
You try to hook the muscle with muscle hook.
Yes,
at
yes.
the Whitnell level.
Actually,
that
first
gives a
identify the
better
Whitnell's ligament and try to
anchoring of the
hook
muscle.
the muscle with the muscle hook. And now we fan the muscle. Fanning the muscle is the most important. And then you cut the Whitnell's ligament, and part of the Whitnell's ligament is also cut. Otherwise, the chances of maybe a complication.
Thank you. Thank you. Thank you. Thank you. Thank you.
Sir, I think Dr. Namita has also joined, so we can start with her. Or maybe we can take her at the last.
Good morning, everyone.
Okay. Carry on, Samriti.
Share the screen and please carry on with it.
My screen is visible, ma'am?
Yes, Namita, now your screen is visible. Okay.
So, very good morning to everyone. I am presenting my paper, Evolution of Punctal Parameters using ASOCT in the patients on anti-glaucoma medications for over 3 years. As we know that topical anti-glaucoma medication are known to cause the lacrimal punctum and the canalicular stenosis. In 2014, Kozinski et al. Have the first time shown that high-resolution images of the normal punctum and the vertical canalicular anatomy can be acquired by ASOCT, which is a non-invasive technique. In the past, studies have been done for creating a normative database in the general population using this modality for the renal system. And this can be used to track the changes in the punctum in patients who have been started on the AGM. So the rationale behind this our study is that no study has evaluated the changes in the anatomy of the lacrimal punctum in the patients who are AGM using ASOCT, and which helps in the evaluating the changes in the punctal anatomy, and it's helping in the planning early intervention to prevent the lacrimal system obstruction. So it's a cross-sectional studies, and we have included 30 in the both groups. Coming to the inclusion criteria, all the glaucoma patients who have been receiving at least one topical AGM for last 3 years and given the consent for imaging, and all the patients will included in the inclusions, all the patients who had a previous lead surgery, any history of the ocular or periocular trauma, radiation therapy, chemotherapy, any epiphora prior to the treatment of the anti-glaucoma medications, and long-term use of other topical medications were excluded. So coming to the methodology, there's two group. One is the case group, another control group. Case group and control group is the age gender matched patient who are not in any topical medication. So the anti-segment OCT of lower punctum was performed, and the measurement of the punctum parameter was on the best image out of 3 was done by a single independent observer. And the statistical analysis was performed in the both groups by comparing the punctal parameters using t-test. So this is a cross-sectional image of the right punctum in a glaucoma group showing all the 3 punctum parameters. The MPD is a maximum punctal diameter, that is a tangential line joining the both edges of the punctum, and one is the vertical canalicular height, that is the midway of the tangential line to the lower visual end of the canaliculus, and MCD is the mid canalicular diameter, taken at the mid-bay of the vertical canalicular height. This is the similar pictures of the right punctum in the control group, showing the all three punctum parameters. So coming to the results, we have 18 patients of mean age of 58 years, and in which we have the 7 patients on the topical beta blockers, 7 on multiple AGM, and 4 on the prostaglandins. In control group, we have the 33 patients having the normal punctum, 3 patients having the punctal stenosis grade 2, and in glaucoma group, we have 19 patients showing the grade 2 punctal stenosis. This is a bar diagram showing the comparison of the puncta parameters in glaucoma and control group, in which you can see that the vertical canalicular height is around 826 in the control group compared to the glaucoma group, that is the 593, and it is a significant. Similarly, the maximum punctal diameter is 364 in control group, and 302 is in control glaucoma group, and it's showing just a borderline significant. However, we did not get any significant for the mid-level canalicular diameter. So in the past, the similar studies for the normal punctum imaging has been done, and our control group has shown the same punctum parameters like them. Recently, in 2019, the Rahman et al. Has published the punctal stenosis puncta parameters, and they have compared it with control group, and they also found that all the puncta parameters were significantly reduced in that compared to the control group. So coming to the discussion, we see that vertical canalicular height seems to be significantly reduced in glaucoma group compared to the case group, and MPD shows the borderline significant. So the future prospective studies in the glaucoma patients of adequate sample size will also helpful to know which drugs cause maximum punctal stenosis and in what duration of time. And it can be also used as a tool for a patient for objectively grading of the punctal stenosis over a period of time. So the limitation of our study is the pilot study with a small sample size. We could not perform the subgroup analysis for the different AGM because of small sample size. However, we have seen the trend, the beta blockers causing the more punctal stenosis compared to the other drug. And upper punctum imaging is not possible with ASOCT, that is the inherent limitation. Coming to the conclusion, anti-segment OCT can be used as a tool in glaucoma patient for objectively grading of the punctal stenosis over a period of time, and timely intervention can be planned accordingly, and that to prevent the complete punctal stenosis. Thank you.
Namita?
Yes, sir.
It's well known that that many other drugs also can cause punctal stenosis and canalicular stenosis.
Yes,
But
sir.
definitely, this is a very good tool to detect the early onset of punctal stenosis, and you can do routinely to know which patients are going to get stenosed and which are not getting stenosed. But
Yes, sir.
whether this tool has guided you to change any your medical management of these patients, those who are going to get stenosed?
Like we don't have the much, just like only recently we have got a in the punctal stenosis patient, because we not have the ASOCT data of the objective grading of the data. So like that's why it's just a pilot study. We wanted to see that AGM, it's a known fact that AGM causing punctal stenosis, but that is that's subjective. That is the slit lamp method that we used to. So it's not any objective grading. And we also not know in the what duration of time and which drugs causes the maximum punctal stenosis. So before planning a prospective study, we thought to first see that that we can pick up that changes that AGM causes on the punctal stenosis. So that
What exactly is your plan otherwise? In other, suppose in future.
So like we planned for a prospective study, but because it's for the prospective study, you have to enroll the all new glaucoma patients, and then you have to closely monitor at every 2 to 3 months, and then it's the long.
Okay.
So the first weeks wanted to see it. Yes, sir.
Okay. Samriti?
Yeah, so probably a prospective study is required first to find out which AGM will cause punctal stenosis. Secondly, in these patients, if we are having some amount of punctal stenosis, probably an early intervention like a canalicular trephination with a mini Manoka can further prevent that damage. So Namita, you probably have to say this when you are presenting a paper, that
Yeah.
what a patient will also benefit out of this study.
Yes. And we have done
Technically, we'll be getting to know that which glaucoma medicine causes the maximum thing, but AGMs are essential for those patients who are a glaucoma patient, right? So, from a plastic perspective, you have to mention that we can prevent or we can actually intervene early so that patient doesn't have those side effects of anti-glaucoma medication, which patient
Yeah.
generally has.
Like there is a study like punctal plugging has been done in patients, those who are more prone to get or canalicular or mini Manoka. All these you have to classify accordingly that which drug, which patient are getting this stenosis. And
Exactly.
you have anyway. This is a very early thing. In future, this can be planned accordingly. No? Thank you.
Yes.
Thank you.
Thank you, sir.
Do we have Shivani right now? Shivani. Or Akshit. Akshit is there. Akshit is there.
Good morning, sir.
Akshit? Ah, okay. Akshita, sorry. Okay, Akshita, you can carry on.
Thank you, sir. Is my screen visible?
Yeah.
Thank you. Good morning, everyone. I am Dr. Akshita Agarwal from University College of Medical Sciences and GTB Hospital, Delhi. Today, I'll be discussing about the effects of debulking surgery in neurofibromatosis in relieving the mechanical ptosis, functional and cosmetic outcome. I have no financial interest. Introduction. Neurofibromatosis 1 is an autosomal dominant disorder with irregular penetrance and variable expressivity. The cutaneous manifestation is plexiform neurofibroma, which is a S-shaped deformity of the upper lid with contiguous involvement of multiple superficial nerves. Case 1. A 32-year-old female presented with plexiform neurofibroma involving the right upper lid extending to the temporal area, along with mechanical blepharoptosis and inability to open her eyes. The surgical management was planned in a staged manner, in which stage 1 of debulking the mass and stage 2 further debulking of the leftover mass to relieve the mechanical ptosis, and stage 3 the ptosis surgery was planned. Stage 1 debulking surgery was done to remove as much neurofibromatosis tissue from temporal area and lateral aspect of the upper lid as possible. Post-op result after stage 1 showed good cosmetic outcome other than the mechanical ptosis due to still persisting neurofibromatosis tissue. Stage 2 debulking was done after 12 weeks on the upper lid under microscope to remove the leftover neurofibroma and to relieve the mechanical ptosis. Post-op result after stage 2 showed a good cosmetic appearance. Mild elevation of the upper lid was also noted, but on post-op assessment, there was no LPS action found. Stage 3 ptosis surgery was performed with upper lid silicone rod sling surgery to lift the upper lid for about 2 mm so that the pupillary axis remains clear. Post-operatively, following two-stage debulking and sling surgery showed excellent cosmetic result along with lifting of the eyelid. The visual acuity improved due to the correction of the mechanical ptosis and possible corneal astigmatism. Case 2. A 55-year-old male presented with neurofibroma involving the whole of the left upper lid with mechanical blepharoptosis. Debulking was done to remove neurofibromatosis tissue from the upper lid with all the precautions to salvage the LPS muscle and orbital septum. Post-operatively, good functional and cosmetic appearance was achieved. Neurofibromatosis involving the upper lid resulting in complete eyelid closure because of the unilateral mechanical ptosis. Debulking surgery showed excellent cosmetic and functional results. Conclusion: neurofibromatosis is a chronic progressive lesion which is causing bilateral ptosis, which can be due to mechanical or due to the damage to the LPS muscle. Surgery has to be planned on the individual basis. Stage 1 to debulk the mass and then decide next step to best get the cosmetic and the functional outcome. In both the cases, careful debulking and, if required, subsequent silicone rod sling surgery resulted in a good functional and cosmetic results. Thank you.
So, Dr. Akshita, what I felt is that this is the management which we all do for patients who present with neurofibromatosis. I think Dr. Hardeep would agree to me that is the plan of action, and it is since long that people are doing this. So what do you think that a new intervention or something other than what has been described in literature you have done?
Ma'am, careful debulking only, trying to salvage the LPS action and the orbital septum as much as we could to prevent the ptosis.
So Dr. Akshita, there was a paper like somewhere around 25-30 years back in which they have already tried to salvage the levator, separating that from the neurofibroma, and they have actually attached levator to the tarsal plate where probably they didn't need even a sling surgery after that. So that was a nice presentation, no doubt, but I felt that nothing new has been done in this. This is a conventional method of treating neurofibromatosis of the lid if it presents to any one of us.
Anyway, okay, thank you.
Thank you.
I think we go to the next speaker. I think Shalin Shah is there. Shalin Shah.
Yeah.
Yes, sir.
Okay. Shalin Shah, you can continue with your presentation.
Yes.
You're from where?
Sir, Guru Nanak Eye Center.
Okay.
So, good morning, everyone. I'm Dr. Shalin Shah. I'll be presenting a case report on a post-traumatic orbital aspergilloma, a rare presentation of not so rare disease. So in our OPD, we received a 37-year-old patient from North India with complaints of swelling over his left lower eyelid since the last 6 months. The swelling was insidious in onset following history of a blunt trauma, which was a physical assault to the left side of his face 6 months back, and it has been increasing progressively since then without any associated pain. No history of vision loss, diplopia, or proptosis. No history of bleeding from the lower eyelid, pus or past surgeries. No history of asthma, recurrent respiratory infections, fever episodes, or immunocompromised status such as diabetes, long-term chronic illness, or high-risk sexual behavior. The general physical examination and systemic examination were normal. As shown, we can see that on local examination, we saw a lesion on the left lower eyelid. It was non-tender, non-pulsatile, and lobulated firm mass, measuring around 3 centimeters by 2 centimeters, with the posterior margins not felt. It was not associated with changes on Valsalva or changes in posture. The best corrected visual acuity of the patient was 6/6 in both eyes, no proptosis. A vertical dystropia was noted of 4 millimeters, displacing the left globe superiorly. Anterior segment examination, extraocular movements, pupil reactions, fundoscopy was unremarkable in this case. On lab workup, the hematological workup was unremarkable. Sugars were well controlled. Patient was HIV negative, and the systemic parameters were normal. We performed a CT scan for the patient. On the non-contrast image seen in image A, we can see a lesion in the left orbit along the medial wall and the floor of the orbit, measuring around 3.3 to 3 centimeters, which is a homogeneous mass and hyperdense. On contrast, we can see it is a homogeneously enhancing lesion. The tissue extended along the left maxillary sinus with a fracture of the roof of the maxillary sinus and the medial wall, as we can see in images C and D. So we made a provisional diagnosis of an inflammatory or an infective pathology extending from the sinus into the orbit, and the patient was planned for an excision biopsy. On table, we found a well-circumscribed firm lobulated mass measuring around 2.2 centimeters by 1.5 centimeters by 1.3 centimeters. On slicing the tissue, it was yellowish in color with a gritty consistency. We sent the tissue for histopathology. It showed a granulomatous tissue reaction on H&E staining with lots of fibrosis. On 100x magnification, we could see fungal filaments. On PAS staining, we could see septate fungal hyphae, and on gomerymethamine staining, we could see some form of branching in this patient. So we also sent the patient for mucosal biopsy of the left maxillary sinus in the ENT department, which confirmed the presence of Aspergillus fumigatus. So our final diagnosis was a post-traumatic orbital aspergilloma. So we performed a repeat CT scan after the biopsy, which showed some residual lesion in the orbit measuring around 1.5 centimeters by 1.3 centimeters. And there was involvement of the left maxillary sinus mucosa also. So the patient was sent back to the ENT department for a endoscopy-assisted left maxillary sinus debridement surgery, and the residual lesion was treated by oral antifungals for 14 days. Here we can see the post-treatment CT scan, which shows complete resolution of the orbital mass and healing along the maxillary sinuses where a previous fracture was noted. The patient has been on regular follow-up for the past 1 year. No recurrence has been observed in the orbit or the sinuses. This is the recent clinical picture with a normal lid contour and a good cosmetic outcome for the patient. So aspergillosis is one of the most common fungal infections of the orbit. It has been classically described as an invasive pathology. There have been case reports of aspergillosis presenting in the Indian population in the immunocompetent patients at a younger age, probably due to increasing work in the construction sites and the agriculture. The most common presentation is fullness of the eyelids and proptosis, noted in up to 50% of the reported cases. And associated paranasal sinus involvement is also seen in up to 90% of the cases. So orbital aspergillosis, as we see here, is a non-invasive infection presenting as an allergic aspergilloma. It could also become invasive in immunocompetent patients involving the bone. And the classical invasive form, which is the fulminant case, is seen in immunocompromised cases. Patterns of tissue involvement involve simple SOL, a muscle-involving pathology causing strabismus and diplopia, a SOL in the intracorneal compartment causing a compressive optic neuropathy, or a nasolacrimal duct obstruction. So in any case of suspected orbital aspergillosis or an aspergilloma, as we saw here, we need to rule out non-specific orbital inflammatory disease, ocular adnexial lymphomas, lacrimal gland tumors, and soft tissue sarcomas. A multi-specialty investigation of the ENT, chest and respiratory medicine, and neurology is needed to rule out systemic involvement. A standalone medical management has been described previously with intravenous antifungals for 14 days, followed by oral antifungals for up to 6 months. Complete surgical excision is a recent trend for aspergillomas, where no systemic antifungal is needed if a complete surgical excision with no recurrence is noted. In cases of intracorneal lesions, where a debulking surgery can be done, or in cases of recurrence, oral antifungals for 2 weeks have been described. So, just summarizing the management, for an extracorneal mass, a complete biopsy would be curative with associated ENT management. For an intracorneal mass, an incision biopsy or a debulking surgery followed by systemic antifungals and an ENT management is essential. Now, we had a post-traumatic case with a 6-month history with a well-circumscribed mass, and we treated the patient early. In case the diagnosis was missed, it could have led to severe orbital or systemic complications, which would be potentially sight-threatening or life-threatening. So my take-home message today is an allergic aspergilloma or a fungal ball is a rare presentation in the orbit, but we need a high index of suspicion when we are dealing with a well-defined homogeneous orbital mass on imaging. Immunocompetent young individuals are affected by aspergilloma, and early intervention would save the eye of the patient, save the sight of the patient, and save the life of the patient. And surgical excision with adjuvant antifungals is the cornerstone of management with little to no recurrence. Thank you.
Samriti,
Yes, sir. So,
you asked first.
yeah, Shaleen, it was definitely a nice case. And you have rightly said that for aspergilloma, excision biopsy or maybe a debulking surgery is necessary. I just wanted to know that since when the first imaging was done, maxillary sinus was already involved. So don't you think we should have first gone endoscopically to the maxillary sinus, just taking an incision biopsy and confirming the diagnosis first rather than going it round the way? That's my personal thing.
Actually, we sent the patient for an ENT clearance before we took up the patient since he had a history of maxillary sinus trauma. But the ENT specialists probably said that it's just a sinusitis. So he was given a warm steam inhalation for 14 days and referred to us for an excision biopsy. After we confirmed the diagnosis of a fungal involvement, we had a hypothesis that it would be a sino-orbital inflammation. And so we sent the patient for a FES-assisted mucosal biopsy of the maxillary sinus.
Yeah, that you had after your excision biopsy, right?
Yes, ma'am.
Okay.
The excision biopsy showed a fungal pathology, so we were looking for the primary. His systemic evaluation as CECT chest was also performed to look for bronchopulmonary aspergillosis, but it was negative.
You see, the maxillary sinus and the eye condition was in continuous on CT scan. So sinusitis cannot be ruled out then. Then something else is there because it is in continuity with the lesion is in continuity with the orbit and with the sinus. So how do you ensure complete excision in case you know that it is a aspergilloma, and will you give treatment after if you ensure that it is a complete excision?
Sir, in case we have a well-circumscribed mass with well-defined margins on the CT scan, and in the post-treatment CT scan, we have no residual mass, we can...
You will do CT scan after that, post-operatively?
Yes, sir, because there have been reports that few foci, I mean, when there are diffuse margins, not well-defined margins, few foci may be left, which may recur after 6 to 12 months. And so a follow-up CT scan is essential.
And in that cases, where you very much sure, will you give antifungal or not?
Sir, in case there is no recurrence or in case we have a well-defined lesion which we have excised completely, we won't be giving systemic.
In cases of immediate post-operative cases, immediate post-operative.
So the case reports are not to give systemic antifungals because they have their own side effects if we have a total excision achieved on table.
So I would, I think, differ because immediate post-op will have some inflammation and all, so you won't be able to completely recognize or basically on
whether it is.
Yeah, exactly, right, sir. You are right, actually. So probably a 2-week course of antifungal would be required. Whether
I would have given. I would
agree with you, sir.
Because aspergilloma gives more devastating condition if we compare the antifungal drugs. On the safer side, we have to give. Yeah, okay, thank you, Shaleen. I don't see any other participant.
I also don't see, sir. Dr. Dipanjali has not joined, and the other one, Shivani has also not joined.
So shall we now sum up the session?
Right, sir.
Now, how to upload the marks? Can you tell me?
Hello.
I think contestants or the participants can leave, and me and Dr. Hardeep can decide on this.
And how to upload online?
Sir, we have a Google Sheet they have sent us.
Okay. From there we add and share.
we add and share
Okay.
with them.
Okay. Hello, Shalin. Nice meeting. Shivani, Samriti.
Yes, sir, definitely
Okay.
a nice meeting.
Nice to see you. Okay.
Yeah.
Thank you. Thanks very much to all our participants, and their all presentation was good. We hope in future you will do much better than right today.
Thank you so
Okay?
much, sir.
Thank you everybody.
Okay, thank you everyone.
Okay. Bye.
VFI का मैसेज भी आ गया VFI में बैठ के।
क्या है?
ग्रेडिंग।
हाँ? Hello, Mr. Darshan. ये admit हो गई।
Dr. Vinita? Dr. Vinita?
Yes, I can hear you.
Yeah. So can you just switch on your camera from your laptop?
Yes, wait a second. It says you cannot start your video because the host has stopped it. Hello.
Just a moment, just a moment. You must got a pop-up on your laptop.
Yes, I've got it.
Okay?
Yes.
Yeah, perfect. So you can share your screen
Is my
from it.
voice audible? Is it audible?
Yeah, it's audible, it's audible.
Okay, thank you.
Okay?
Yes.
Okay.
Thank you so much.
If you want, you can just stop your camera for the time being.
Okay, fine.
Yeah.
That person will later in, then she will come. That now different person will come.
I have joined.
Hello. She'll come only. They'll not let her in. If they are doing something, after that she will come. I have to wait for some time. She'll come now. They let her in. Okay, bye.
Dr. Tanvi, are you there?
Yes, I'm there.
Okay, please start your presentation. We will be recording your presentation and it will be judged later. So please start your presentation.
Okay, shall I? Acha, okay, just a second. Is my screen visible?
Yes, your screen is visible.
What about the timer?
Yes, your screen is visible, and the moment your session starts, the timer will be shown on the screen. Okay.
Okay, thank you. So shall I start?
You have to.
Good morning, I am Dr. Gautam. I am joining. So, is the meeting on progress?
Yes, sir. Dr. Tanvi will be starting her presentation. She is the second speaker.
Okay. First already done.
No, sir. First presenter has not shown up yet. So we are starting with the second presenter.
Okay.
Dr. Tanvi, please start your presentation.
Yes. Very good morning to one and all. My name is Dr. Tanvi, and I would be presenting a case of unusual presentation of orbital tuberculosis. So, a 12-year-old healthy girl presented to us in the OPD with complaints of painful swelling around the right eye and protrusion of the right eyeball for 15 days. So, she had no history of trauma, no history of decreased vision or limitation of eye movements. There was no history of double vision, no history of redness or watering, and no history of fever or weight loss. Her past history, she had no history of similar complaints in the past or no history of tuberculosis. Her family history was negative for tuberculosis, and on general examination, she was afebrile with vitals normal. There was no lymphadenopathy, and the neurological examination was within normal limits, including the cranial nerve examination. On ocular examination, her uncorrected visual acuity was 6/6. There was an upper lid edema which was extending till the forehead, as seen here. There was a skin discoloration present with an S-shaped deformity of the lid, which is seen here, and the eyeball was pushed downwards and medially. On palpation, there was a local rise of temperature. There was a tender swelling present in the superotemporal part of the orbit, and the margins were very poorly defined, and the posterior extent was not palpable. There was a proptosis of 3 mm with a vertical and horizontal dystopia of 2 mm, and there was mild limitation of abduction. The left eye examination was within normal limits. The anterior segment examination in both the eyes was within normal limits. And the posterior segment examination was also within normal limits in both the eyes. We investigated the patient further and we found that the ESR was raised. It was 62 mm at the end of first hour and her MAN2 was strongly positive. That was 18 by 24 mm in duration. Her peripheral smear was within normal limits with no evidence of malignant cells, and her chest X-ray was within normal limits. So we asked for an MRI brain and orbit in the patient to rule out any mass lesion. In the meantime, the patient was started on an oral course of Augmentin for 5 days. So following the course of 5 days, we noticed that the upper lid edema and erythema had gone down, but the swelling still persisted in the superotemporal part of the orbit. So an MRI brain and orbit report showed that this was a T2 weighted MRI in the coronal section and a T1 weighted in axial section. And it showed a multiloculated, mildly hyperintense lesion, which was seen in the lateral part of the right orbit. It was seen to extend to the frontal scalp region. It had also eroded through the lateral wall of the orbit and the greater wing of the sphenoid and had displaced the right globe medially along with the lateral rectus muscle. And this mass was also extending extradurally into the right temporal lobe. So we did an FNAC of the mass from the orbit. So that showed necrosis and degenerated pus cells, and the stain for acid-fast bacilli was positive. So in view of the high ESR, a strongly positive MAN2 test, and acid-fast bacilli seen on FNAC of the mass, we came to a final diagnosis of tubercular abscess with intracranial extension. So the patient was started on a course of anti-tubercular therapy for 12 months. So at the end of 6 months, her proptosis had completely decreased and the ocular motility had improved. So this was her presentation. This was at 2 months of anti-tubercular therapy and this was at 6 months. Now, as we can see at the end of 6 months, her proptosis had completely gone down, the mass had disappeared and the motility had improved. Now, the patient just recently completed her 12-month course of ATT. So post the ATT, her MRI is still awaited. So orbital involvement in TB can occur either because of a hematogenous spread from a distant site, or it can occur because of a direct extension from the adjacent sinus, lacrimal gland, or lacrimal sac. So it can manifest either as periostitis of the orbital margin, it can manifest as a tuberculoma or a cold abscess, or it can present as a dacroadenitis. So most of the time, the patients present with progressive unilateral proptosis, a painful or painless eyelid swelling, limited ocular motility, sinus formation, a decrease in the visual acuity, or with intracranial extension. Our case had 4 of these 6 clinical features. A review article by Madge et al., which was done in 2008, showed that there were 91 documented patients with orbital TB in English literature, out of which 56 patients were from India. A PubMed search showed that there were 8 other authors who have reported intracranial extension, such as reported in our patient. So diagnosis of orbital TB can be made either indirectly or directly. Now, indirect evidence includes evidence of systemic active or inactive TB, which can be in the form of a positive history, a positive examination of cervical lymphadenopathy, cold abscess or sinus, or in the form of positive investigations like a high ESR or chest X-ray or MAN2 test. Few of these indirect evidences were positive in our patient. Of course, the direct evidence is histopathological confirmation on FNAC or biopsy, which was positive in our patient. Here, I would like to highlight that an FNAC may not always be positive, even if the patient has tuberculosis, because the yield of organisms from such lesions is usually poor. Therefore, a negative FNAC doesn't always rule out tuberculosis. Hence, more than direct evidence, it is a strong suspicion which is important for orbital tuberculosis in a country like ours, which is so very endemic to this infection. So I would like to conclude that orbital tuberculosis, even though it is a less common form of extrapulmonary TB and its intracranial extension is relatively rare, it has the potential to cause very serious complication, which demands immediate and aggressive action. So an early diagnosis would show some response to medical therapy and it would obviate the need for an orbitotomy. And again, I would like to stress on the point that a high index of suspicion is required when we deal with an orbital mass in an endemic region like India. Thank you.
It's a nice presentation. So,
thank you, sir.
Is there any comment from Dr. Anita? Is there?
Sir, Dr. Anita is not here. Only you are here among judges.
I am here. Okay. So, can you suppose that the FNAC is negative, and the means next step is the biopsy, tissue biopsy, and but can you name any other test which recently has developed? It can help with a very high sensitivity and specificity in developing the tuberculosis in such a doubtful cases where something is masquerading?
So interferon gamma assays are PCR analysis, and interferon gamma assays are the upcoming tests for tuberculosis.
Okay, I'm talking about some nucleic acid.
It's a PCR polymerase chain reaction analysis.
Yeah, but some more advancement in that area. So there is one test that is known as CBNAT. Okay, if you can go and read about the CBNAT test, that is catalyst-based nucleic acid amplification test. That is very useful in such cases of tuberculosis. Okay?
Thank you, sir.
Okay, thank you. The next presenter, please proceed.
Yes, sir. Our next presenter is Dr. Sonali. She will be discussing surgical outcome of levator resection in congenital ptosis with poor levator action. Dr. Sonali, please start your presentation.
Is my slide visible?
Yes, it is visible.
Okay. Okay, very good morning to all of you. I'm Dr. Sonali, posted as an associate prof at Army Hospital Research and Referral. And I would like to thank DOS for giving me this opportunity to present my work. The title of the study which we did at our center is Surgical Outcomes of Levator Resection in Congenital Ptosis with Poor Levator Action. So as all of us know, treatment of congenital ptosis is very challenging as results are unpredictable. The ideal surgical technique which gives optimal cosmetic outcome without complication is still evolving, and tarsofrontal sling operation is the preferred standard of care when levator action is poor. But most of the time it has a very high rate of complications like sling expulsion, infection, brow scar, and sometimes it can cause cosmetic disfigurement also. So supramaximal levator resection has been advocated over the past 2 decades as an alternative treatment modality. So this study was conducted at our center to assess the effectiveness of supramaximal levator resection in patients with unilateral congenital ptosis having poor levator action. So this study was conducted at Army Hospital Research and Referral, and it was a prospective interventional study which was conducted over a period of 6 months. Congenital ptosis with poor levator action was included in this study, whereas patients with Marcus gun jaw winking phenomena and acquired ptosis were excluded from this study. All patients underwent supramaximal levator resection under GA. And what we did in surgical technique, like the resection was done in the suborbicularis plane to expose the tarsal plate. And then the undersurface of the levator muscle was dissected from the underlying conjunctiva and the molar muscles. The septum was incised to expose the levator muscle till Whitnall's ligament. And then suture was passed, partial thickness suture was passed through the upper 2/3 of the tarsus, and which was retrieved through the levator muscle just below the Whitnall's ligament. So all patients were evaluated on day 1, 1 week, 3 and 6 months after surgery. And surgical outcome measures were change in margin reflex distance, vertebral palpebral fissure height, and inter-eyelid difference of margin reflex distance. The success was defined as a margin reflex distance, either 3 or more than 3 mm, and inter-eyelid difference of MRD was between 0.5 to 1 mm. So a total of 15 patients with congenital ptosis underwent supramaximal levator resection, and in that there were 9 females and 6 males. The mean age group at the time of surgery was 5.73, and the range was from 3 to 11 years. So we could achieve good surgical outcome in 12 patients, whereas in 2 patients we noticed undercorrection and 1 patient developed upper lid swelling. So the pre-operative finding, basically the MRD, vertebral palpebral fissure height, and inter-eyelid MRD was compared with the post-operative findings. And what we have found in our study that MRD increased from a mean of 0.26 to 3.26, which remained same even after 6 months of surgery. Vertebral palpebral fissure height also increased from a mean of 5.2 to 8.5, which was statistically significant. and it also remained same even after 6 months of surgery. Inter-eyelid MRD1 difference decreased from 3.73 to 0.75. So these are few photographs of congenital ptosis which underwent surgery at our center, and all these patients, they underwent supramaximal levator resection, and it showed a good outcome. So levator resection results in better cosmesis, such as the presence of dynamic blink and preservation of eyelid counter, and there is a lack of dependency on the frontalis action, muscle action for opening eyes. So all patients with poor levator action underwent levator resection instead of tarsofrontalis sling in our study. And we could achieve good surgical outcome in 80% of cases, as post-operative MRD was found to be 3 mm. So this patient had an excellent reduction in ptosis with a clear visual axis, and which reduced the risk of amblyopia. In some patients, like 2 patients, we noticed undercorrection. However, visual axis was clear, so observation was advised in these 2 cases. Post-operatively, patient had lag of ophthalmos and lid lag in all the cases, which become less visible after 3 months. So we could achieve good surgical outcome in 80% of our study population, and which is comparable with other studies like Cruz et al., Met et al., and Anderson, which also reported a success rate of 70 to 90% in their study group. However, Park et al. Reported success rate only in 2 patients out of 7, and Park et al. Reported a good surgical outcome in 35 patients out of 65 patients. So the limitation of the study is that the surgical outcome of supramaxillary levator resection was not compared with the tarsofrontalis sling operation. And the other limitation includes a small sample size and a short follow-up. So to conclude, levator resection is an effective alternative for tarsofrontalis sling operation, as it leads to good surgical outcome in patient diagnosed with congenital ptosis. It allows normal physiological use of levator action despite its poor function, which yields good result by avoiding all the complications which are associated with tarsofrontalis sling operation. Thank you.
Thank you, Dr. Sonali. It was very nice work. You are shifting from the sling to this levator surgery. So can you please tell me what was your cutoff for levator action?
Like the age group was between 3 to 11 years. So like in small children, we couldn't measure the levator action because they were not following our instruction. However, in children more than 5 years and 6-7 years who were cooperative, so the cutoff was levator action was 4 mm. So below 4 mm, we subjected all the patient to supramaxillary levator resection in our study.
And below 4 mm is means a wide range from 0 to 4. So up to what LPS action, what amount of LPS action below which you would not like to recommend for this resection, or would you like to even in those cases also?
Even if the patient what we have come to the conclusion, even if the patient has 2 mm of levator resection, if we could measure in these children, ideally we are advocating that we should initially perform maximal resection, because like in other set, like we have been doing tarsofrontalis sling operation, and like in 10% of the cases they are coming with a suture granuloma and this suture abscess, and sometimes the exposure also. So we have to intervene again in this 10% of cases who have undergone tarsofrontalis sling operation. So ideally, even if the patient has 2 mm of levator action, we should initially we should advise supramaximal levator resection. Like if we go and expose the levator muscle till Wittnern's ligament and put a suture either through the Wittnern's or just below the Wittnern's ligament, also most of the time it gives a good outcome.
Okay, actually we have a sort of time, so But this work should be expanded for more sample size.
Yeah. Only limitation are like we didn't because we included only 15 patient and the follow-up period was for 7 months. Maybe in future we'll include more patient and then we'll see how the result come up in that sub. Like if the study population is more.
Okay. Thank you very much. And next presenter, please proceed.
Sir, our next presenter is Dr. Swati Agarwal.
Yes,
She will
ma'am.
be
Good morning, ma'am.
discussing a modified frontalis sling surgery. Dr. Swati, over to you.
Yes, ma'am. Good morning. Is it visible, ma'am?
Yes, yes, it is visible.
Should I start?
Yes, please start.
Okay. Good morning, everyone. I'm a trained ocular plastic surgeon, and I'll be talking about a modified frontalis sling procedure with silicone rod but an open method. So the purpose of this study was to compare the results of the modified frontalis sling procedure with the conventional frontalis sling which we do for the correction of a severe ptosis. So it is a prospective interventional case series where patients were divided into two groups. Group A had 10 patients who underwent modified frontalis sling via an open method, whereas Group B had 10 patients who underwent closed method frontalis sling procedure, which is the conventional technique. So the patients with severe ptosis and poor LVS action and congenital ptosis were included in the study, whereas patients with good levator action or a milder or acquired or variable ptosis were excluded.
Dr. Swati, your voice
Pardon,
is
sir?
breaking. Please adjust your mic or come close to mic. Your voice is breaking from on my side.
Okay, sir.
So can you please
Okay,
correct
sir.
it?
Now is it okay, sir?
It is still breaking.
I guess it will be better, right?
Yeah, it's a little bit better. Carry on. On your slide.
Now is it okay, sir? Should I continue?
It's not audible.
Can you hear me?
Now it is clear.
बाद में बात करते हैं.
Okay. So all the surgeries are performed by a single ocular plastic surgeon using silicone rod. So this is a short video of the technique. The ptosis correction by the modified sling. A patient with a severe congenital ptosis was taken. The lid crease incision were marked as per Fox pentagon. And the markings were incised and a prefrontal pocket was created wherein we'll incorporate the sleeve later on in the surgery. Lid crease incision was made with a 15-degree blade after putting a traction suture to the lid. The orbicularis was dissected and a suborbicularis plane was entered. After achieving hemostasis, the tarsal plate was identified and so was the dysgenetic LBS identified. The sling was entered from the prefrontal incision to the suprabrow incision at point B and then through the open lid crease incision. From here, it was again reinserted at the suprabrow incision at point C, leaving a loop of the sling at the lid crease incision. From here, the pre-designated tarsal plate area, vical sutures were anchored with a sling keeping in mind that they are not full thickness incision. So the sling was anchored to the tarsal plate at the 2 points, being a more physiological anchoring. The lid height was adjusted to the desired level, and the lid crease incision was sutured with the Vicryl suture. I prefer closing the lid crease with the absorbable suture so that I don't have to remove it in the post-operative period, thus altering the lid height. And the upper suprabrow and the frontal incisions, I prefer closing them with non-absorbable nylon. So after achieving the lid height, the vascular sleeve was inserted into both the slings, and the slings will lock back to the desired place. So this is Vicryl, and I'm closing the lid crease incision and the intraocular sutures. So this also forms a lid crease, was to incorporate orbicularis tarsal as part of this incision. So it creates a scar and causes a more natural lid crease to form. And the rest closure is what we do in the conventional technique. So females predominated in the study with a mean follow-up period of 8.2 months plus minus 4.7. Although there was no significant difference in the post-op lid height, which was measured by palpebral fissure height, but definitely a post-op lid crease symmetry was seen better in the group A patients. Now here are some pre and post-operative photographs of the patients who were in group B who underwent conventional frontalis sling. As you can see, they have a very good palpebral fissure height, almost comparable. But when we see about the lid crease, they do not have that great lid crease. When we compare them to the patients who underwent modified frontalis sling, they not only have a symmetrical palpebral fissure height, but they also have a very nice lid crease. So modified frontalis sling can be thought of as a good alternative to conventional surgery, as it not only provides a better lid crease symmetry by being a more physiological route to the sling, but will also reduce the chances of post-operative sling slippage. But definitely longer follow-up studies will be needed with more subjects to establish its importance and its role over the conventional sling surgery. Thank you.
Dr. Swati, this was
Yes,
a nice
sir.
presentation. So
Thank you, sir.
Very good outcome, and the cosmesis was very nice. Did you get through the literature
Yes, sir.
search on this procedure?
Definitely, sir. There is a mention of this technique in literature, but it is still not known to many ophthalmic surgeons and obviously many oculoplastic surgeons also. I did a similar technique under my mentor at Shrivanektralaya, Chennai, and I learned from her, but I have improvised my own few modifications, which I showed in the video. But this technique is definitely worth trying. It will just take a couple of minutes, but you will be able to achieve a very good lid height. And also with the cases of sling, we see a lot of sling slippages happening, say after a few years, which might not happen with this technique.
Actually, my internet connection was interrupting. Can you please tell
Yes.
me how did you fix the sling material to the tarsus?
Yes, sir. Sir, like when we passed it through the open decrease incision, we left a loop, and then we took Vicryl, that is a non-absorbable, that is the absorbable suture. We anchored it to the proposed tarsal area. So, like you do a LPS resection and you anchor the remnant LPS to the tarsal area. Likewise, we passed the anchoring sutures to the tarsal plate, and we anchored the sling to it, so that it is.
You have anchored the sling with the Vicryl, that is absorbable suture. So
Yes,
why?
sir. Sir, first thing that we did not remove it, and the second thing, the Vicryl along with the preorbicularis tissue forms a sheath around the sling, and thus it helps in anchoring and forming the adhesions, so it doesn't slip. So this technique has been very widely tried by the plastic surgeons, but is not well known to the oculoplastic surgeons of the ophthalmologist.
Okay, if it holds for a long time, it's good. But in my personal opinion, this should be done with a non-absorbable suture because it's a buried.
Yes, Prolene sutures have been tried. People do it with the Prolene sutures, but there are case reports of getting suture granulomas with them.
You can
So
use
yes, but
suture, instead
with
of
the
Prolene.
yes, definitely we should try that.
Okay, thank you very much.
Okay, thank
Next
you, sir.
presenter, please.
Okay, so next presenter is Dr. Ravi. He will be discussing flapless external DCR. Dr. Ravi, please share your presentation.
Yeah. Is my slide visible? Is my slide visible?
No, sorry,
No,
it's not
sir.
visible to me, Dr. Ravi.
Yes, sir. Now your slides are visible.
Morning, everybody. My topic is flapless external DCR. Is it time to say goodbye, flaps? No financial interest to disclose. Personal communication with many ophthalmologists reveal that failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. As a result, DCR is ignored by many eye surgeons and lacrimal surgery is increasingly being undertaken by ENT surgeons. Or in an era when other specialties are always looking to widen their surgical spectrum, we must not lose this patient to ENT surgeons. And to overcome the problem, I started a no flap technique in DCR, which is less time consuming, easy to perform, result at par. And total number included in this study is 2768. Inclusion criteria were constant complaint of epiphora and discharge more than 6 months duration, age more than 18 years. And exclusion criteria were common clavicular obstruction, history of nasal or orbital trauma, patient with any nasal pathology causing epiphora other than dacryocystitis, patient with uncontrolled diabetes, hypertension, and coronary artery diseases. Methylene blue is used to irrigate lacrimal sac to delineate during dissections. Curvilinear skin incision was made 2 to 3 mm from the medial canthi. Medial 3/4 of the sac and upper portion of the nasolacrimal duct were removed so that the lateral part of the sac remains as a disc with punctum in its middle, similar to that of Curtis DCR surgery. And this is the remaining sac after removal of the medial 3/4 of the lacrimal sac. 10 mm Aruga's bone trephine was used to make ostium in lacrimal bone and passages nasal mucosa. And this is Aruga's bone trephine. And this is ostium, whatever I have removed from anterior lateral part of the lacrimal sac. That is, remaining sac was stuck with subcutaneous tissue of the middle side adjacent to the newly formed ostium by non-observable 6/0 silk thread. Medial palpebral ligament and rest of the incision is sutured. On 5th post-operative day, syringing with 1 ml of 0.4 milligram per ml mitomycin was done in newly formed passes and near bone ostium. And there was no major complication during surgery. Changes I made were medial part of the lacrimal sac was removed. Aru was refined used to make ostium in nasal bone adjacent to the lacrimal sac and nasal mucosa. Mitomycin C is used on the 5th day for syringing in the newly formed passes near ostium and nasal mucosa. The patient were followed up for 1 year, and a functional success was defined as absence of tearing assessed using Monk's score. And anatomical success was defined as patient when no significant reflux on syringing. Ostium size changes measured on 7th day, 15th day, 1 month, 2 months, 3 months, 6 months, and 1 year by nasal endoscope. And this is nasal endoscoping. Endoscopic view after 7 days. This is endoscopic view after 15 days, after 1 month, after 3 months, after 6 months, and that is after 1 year. And ostium size shrinkage was marked in the first 3 months. After that, it is nearly stable and found 4 to 5 mm oval round in shape at 1 year. And the results at the end of follow-up period is that is 12-month period. 13% complained of epiphora of grade 2 or more and more. At the end of mean follow-up period, that is 12 months, despite successful syringing and patent newly formed nasal ostium, and 16 patients failed in syringing during the follow-up period. Thus, in our study, anatomical success is that is 99.26%, and functional success is 98.6%. In accordance with the intranasal DCR, which has high success rate without flaps, I have obtained the idea of why not doing the external DCR without flap also. So the procedure of the external DCR was designed to be done with neither anterior nor posterior flaps. Furthermore, the technically difficult flap making and suturing, especially the posterior flap, was overcome using the modified technique. I postulate that osteotomy done without flaps has a much less incidence of adhesion and synechia that may lead to failure of the DCR. And again, why mitomycin is used here? Because it is known antifibroblastic. It has known antifibroblastic properties. And these are the many studies. And it was found that the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram per ml to 0.4 milligram per ml. That's why I have used here. And in the present study, syringing of 0.4 milligram per ml mitomycin C in the newly formed lacrimal passage of increases the incidence of postoperative adhesion more significantly because it is not diluted by bleeding from major better concise to early stage of tissue injury. That is the stage of fibroblast migration and proliferation in the wound. And the success rate in this study was 98.6%, and the success rate among published research varied from 70 to 100%. And the sample size of the studies published also ranged from 19 to 176. And the sample size of this study was 2,165 patients. And the success rate of this study is significantly better than the previously published report due to the large sample size of the large sample size. Thank you.
Thank you, Dr. Ravi. This was an innovative idea. So, can you please tell me what was the size of bone refine you used for this refining?
8 to 10 mm. In children, I have used 8 mm. And in adults, preferably 10 mm.
Okay. And how frequently you used this mitomycin for irrigation post-surgery?
Once on 5th post-operative day. I have used, in the most of the cases, I have used only once.
Okay. So, have you compared this method with the flap technique, 1 flap or 2 flap technique?
Actually, I am a private practitioner and never take risk in comparing or anything else because my results are very good. That's why I am doing this surgery by this technique only.
Okay. Okay, thank you.
Data are published and results are published by many authors, any flaps and anything else. You can get it on net. That's why I have never compared this.
Thank you. We will see in future for on more people, more patients, so that then we can quantify this.
Actually, I have done more than 3,000 persons by these methods now, because I'm doing this since 12 or 14 years.
Okay. So
I first published it in 2012. That time there were only 150 patients, and now the more and more patients are adding to this study.
Okay, thank you, Dr. Ravi. We think we should proceed to the next presenter. Next presenter, please.
The next presenter is Dr. Ruju Unatkad. I think he has not joined. Dr. Ruju, are you there? Okay, then we can move to next presenter, Dr. Ayushi. She will be comparing evaluation of peribulbar triamcinolone acetonide and intravenous methylprednisolone in thyroid eye disease. Dr. Ayushi.
Yes, ma'am.
Hello. Please share your presentation.
Should I start?
Yes, please start.
1 second. Is my screen visible, ma'am?
Yes, your screen is visible.
Okay, so ma'am, I'll start. Good morning, everyone. I'm Dr. Ayushi Agarwal, final year resident from Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi, and I'm going to talk regarding comparative evaluation of intravenous methylprednisolone versus peribulbar steroid therapy in thyroid eye disease. It's not. Corticosteroid therapy is the first line of treatment for patients with moderate to severe active thyroid eye disease. The various routes of steroid administration are the intravenous route, that is the most common one, the oral route, and the local routes like retrobulbar, subtenon, subconjunctival, peribulbar, and phonician. While there have been encouraging results with the use of peribulbar steroids, none of them have compared it with the intravenous methylprednisolone pulse therapy in active thyroid eye disease. So we are going to talk about the comparison between peribulbar triamcinolone acetonide and intravenous methylprednisolone therapy in moderate to severe active DED. This was a randomized controlled trial with a follow-up period of 6 months. 20 adult patients diagnosed with moderate to severe active thyroid eye disease as per the UGOGO guidelines were randomly divided into 2 groups, Group A and Group B. Group A received 4 2-weekly injections of peribulbar triamcinolone acetonide, 20 mg in each orbit at the supranasal and infralateral site. And the Group B patients received 12 weekly infusions of IVMP, 500 mg for 6 weeks and 250 mg for another 6 weeks. Patients diagnosed with tuberculosis, diabetes mellitus, uncontrolled hypertension, optic neuropathy, pregnancy, and psychosis were excluded from our study. These are the various parameters that we monitored. This is a line diagram showing the trend and change of clinical activity score over 6 months in Group A and Group B. So in Group A, clinical activity score of 4.9 significantly decreased to 2.1. And in Group B, from 5, it significantly reduced to 1.7. The difference between the 2 groups was statistically not significant. Improvement in clinical activity score by at least 2 points. That is an outstanding therapeutic response described by UGOGO, was seen in 80% cases in Group A and 70% cases in Group B. This is a clinical picture. The above picture, pre-treatment and post-treatment clinical picture showing improvement in CAS at 6 months in Group A that received peribulbar therapy. And this is the clinical picture showing improvement in clinical activity score following the IVMP therapy. Total, there were 34 affected eyes, out of which 18 belonged to Group A and 16 belonged to Group B. Lateral rectus was not enlarged in any of our patients. The incidence of affection of inferior rectus was equal to the superior rectus followed by medial rectus. This can be explained by the reported findings that have identified a strong correlation between lid retraction and the enlarged LPS-SR complex, implying this muscle to be the most commonly targeted muscle in thyroid eye disease. So we did find a significant mean decrease in the thickness of IR, SR, and MR in both the groups, and the difference between the two groups was statistically not significant. This is a this is a NCCT coronal view showing. This is the pre-treatment image and this is the post-treatment image. In the pre-treatment image, the MR and IR of both the orbits are enlarged, and which have significantly reduced post-treatment after receiving peribulbar triamcinolone acetonide. This is another graph showing trend and change in exophthalmos in group A and B. As we can see in the peribulbar group, the exophthalmometry measured by Hertels reduced from 25.33 to 23.39 at 6 months. And in the IVMP group, 25.12 to 23.06 at 6 months. The intra-group change was significant and the intergroup change was not statistically significant. We did not find any local or systemic complications with the peribulbar triamcinolone acetonide, whereas side effects such as pedal edema, amenorrhea, and gastritis were observed in the IVMP group, and none of the patients in our study experienced life-threatening complications. The use of peribulbar steroids was first demonstrated in 2004, where a significant change in binocular vision area and extraocular muscle size on CT scan was seen. However, they did not find any change in exophthalmos, unlike our study where we found a significant change in proptosis as well. Then previous studies have shown previous studies on peribulbar triamcinolone acetonide have shown significant reduction in clinical activity score. However, side effects such as transient rise in IOP, which was controlled on topical medications in both the studies, lid hematoma, ptosis, site-related hyperpigmentation was seen with the peribulbar steroids. However, none of these side effects was seen in our group. Another study that compared peribulbar with the systemic steroids found weight gain, hyperglycemia, and gastritis as a side effects with the oral steroids, whereas in our study, pedal edema, amenorrhea, and gastritis was seen with the intravenous group, and no recurrence was found in our study. So to conclude, peribulbar steroids are as efficacious as IVMP in terms of change in CAS, EOM thickness, exophthalmos in active, moderate to severe thyroid eye disease, and has a better safety profile. So we propose that peribulbar steroids can be used as a safe, viable alternative in presence of systemic conditions where IVMP is contraindicated. Thank you.
Thank you, Dr. Ayushi. This was a nice presentation. So, what other drugs can you try? Can you have you searched about some other drug which are used or which has been used in this similar clinical condition?
Sir, peribulbar or any other form?
Yeah, peribulbar, some other drug.
Sir, one study by Bagheri et al. Compared combined triamcinolone with dexamethasone. And it was in that study that they found site-related hyperpigmentation, lid hematoma, and ptosis as side effects. So people have also used dexamethasone solely for peribulbar use.
There are certain non-steroidal because you have stressed on the IOP rays in some studies. So there are some non-steroidal drugs. You can try it. And you can compare it with some peribulbar steroid in the next study. That would be more advantageous. Okay, here you compare the systemic versus local. So why not to compare local between local? Thank you very much. Next presenter, please.
So, Sir, Dr. Ruju has joined us. So, he will be presenting clinical ocular manifestation in myasthenia gravis patient. Dr. Ruju. Yes, sir, your slides are visible.
Good morning, everyone. Good morning, everyone. Myself, Dr. Ruju Unadkar, third year resident from MNG Institute of Ophthalmology. I'll be presenting a study of ocular presentation in patients with myasthenia gravis, which was conducted under guidance of Professor and Head of Oculoplasty Unit, Dr. Swati Ravani. Myasthenia gravis is an autoimmune disorder affecting neuromuscular junction due to acetylcholine receptor antibodies. It is a generalized disorder often manifests initially as a focal weakness. Most common focal presentation is ocular musculature and it is termed as ocular myasthenia gravis, often referred as OMG. No definitive diagnostic tests are available for the diagnosis of OMG. Single fiber electromyoneurography is very useful in diagnosis of OMG, but it is technically demanding. It requires an experienced person who can do it accurately. So the clinical signs and symptoms are very important in the diagnosis of OMG in developing countries like India. We do not have enough literature on the OMG from India. Hence, our objective is to look at the clinical and epidemiological profile of OMG and its short-term prognosis. Ocular myasthenia gravis is characterized by fatigable weakness involving extraocular muscles, levator or orbicularis oculi muscle. It can be presented with ptosis and or diplopia. Generalization will occur in 90% within the first 2 years after ocular symptoms begin. OMG remains restricted to ocular muscles beyond 1 year, with 50% being seropositive for acetylcholine receptor antibodies. Our aim was to study in detail about various ocular presentations of patients with myasthenia gravis. Materials and methods. It was a prospective observational study which was carried out on 40 patients at a tertiary care center over a period of 2 years. After informed written consent for participation was obtained from each subject, detailed patient evaluation was done, including detailed history, complete ocular examination, best corrected visual acuity, torch light examination with special emphasis on leads for ptosis, extraocular movements, slit lamp examination, Kogan's slit twitch test, slip test, eye spec test, morning evening comparison test, fatigue test, and electrophysiological test. Based on this, observations and results were plotted on a graph and they were compared with the similar studies. As we can see, maximum patients were seen from age group 21 to 30 years with a mean age of 23.5 years. Similar study of Dr. Chitra had a mean age of 42.69 years and Dr. Cooper's study had 48.4 years. Our study had typical female preponderance suggestive of 52.5%, which was comparable with Dr. Chitra's study. Our study suggested that 7% of patients had no eyelid features, 25% had unilateral right eye ptosis, 25% had unilateral left eye ptosis, bilateral asymmetrical ptosis was found in 32% and 10% had bilateral symmetrical ptosis. Our study suggested that 37.5% patient had diplopia present. 32 patients improved on rest and 30 patients had aggravated symptoms at night. Unilateral ptosis was present in 20 cases, bilateral ptosis in 17 cases, Kogan lead twitch test was positive in 23 cases, slip test was positive in 31 cases, morning evening comparison test was positive in 35 cases, fatigue test was positive in 24 cases, and eye spec test was positive in all the 40 cases. 10% patient had unilateral restriction of ocular movement, 5% had bilateral restriction of ocular movement, and 10% had squint present. Particularly, diurnal variation was seen in 75% patient and improvement after 30 minutes of sleep was seen in 80% of patient. In Dr. Devaradi's study, it was 85% for each. Eric Schelkingen suggested that specificity of Kogan's lead twitch test was diagnostic sign for myasthenia gravis in 99% cases, while its sensitivity was 75% cases. In our study, it was positive in 57.5% of cases. RNS study was found positive in 37% of cases, whereas in Dr. Chitra's study, it was positive in 31.3% of cases. After treatment with tablet pyridostigmine, 80% cases improved. In our study, 27.5% cases was just managed with pyridostigmine alone, and 20% cases given both steroid and pyridostigmine. Only 2 cases needed azathioprine. To summarize, diagnosis of OMG should be considered in a patient with variable and fatigable ptosis, diplopia with diurnal variation, shifting ptosis, enhanced ptosis sign, and Cogan's lid twitch sign are rarely seen but diagnostic of AMG. Acetylcholine esterase inhibitor is the initial treatment in all cases of OMG. Immunomodulation has a pivotal role in OMG with diplopia, and only short-term steroids are required. Limitations of my study was a small sample size. Only 8 patients didn't came for follow-up after few initial consultations. In 20% patients, RNS study could not be conducted. Take-home message would be every patient presenting with ptosis, restricted extraocular movements, diplopia should be evaluated completely before proceeding for the surgery. Early diagnosis and management of OMG can improve systemic outcome of generalized myasthenia gravis. Thank you.
Thank you, Dr. Ruju. It was a nice study. And I think the take-home message is to evaluate every cases of ptosis before shifting the patient to operation theater.
Yes,
because there are some conditions where the surgery is not the first choice. So,
yes, sir.
Very nice. And in how many cases you have you done this neostigmine test?
Neostigmine tests were performed in 8 cases only, sir, as it requires an anesthetist team to be there. So we conducted in 8 cases.
Okay. In all cases, it was conclusive, or it was some cases it was equivocal results?
In sir 7 cases, it was conclusive.
Okay. How did you know that it is the positive?
Sir, it improved within 10 minutes. Ptosis improved within 10 minutes of the test.
Okay. Okay. Thank you.
Thank you, sir.
Next presenter, please.
So our next presenter is Dr. Shantanu Das, and I think he has also not joined. So I think Dr. Krishna Amin can present. Dr. Krishna will be presenting ocular trauma profile at Tertiary Care Center. Dr. Krishna, please share your presentation.
Yes, ma'am. Just a minute. Hello. Am I
Yes,
audible?
Dr. Krishna, you are. Yes, yes.
Hello.
Yes,
Hello.
you are audible, Dr. Krishna.
Is my
Hello.
slide visible?
No, your slides are not visible.
Can I get the meeting ID? I'm sorry. Can I just get the meeting ID? Hello. 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 Hello.
Hello.
Hello. Can I get the meeting ID, ma'am?
Dr. Krishna. Okay, I will
Hello.
get message you the meeting ID.
Yes, ma'am. Kindly message me the meeting ID, ma'am.
Okay.
Is there any presenter who is ready for the presentation? Who was left?
Okay, so we can.
Or those number 1 and I think number 1 and number 8 were absent.
Yes, sir.
And
Dr. Vinita is here. I think she can present.
Okay. Just
Dr. Vinita, she will be presenting on mucormycosis in a case of lid ptosis and total external ophthalmoplegia.
Yes,
Dr.
ma'am. Can you
Vinita,
hear my
can
voice,
share your
ma'am?
presentation?
Can you hear your voice,
Yes,
ma'am?
yes, I can hear you.
Okay. I'll just share my
Yes,
screen.
we can hear your voice.
Yes, ma'am.
Okay.
So good morning, everyone. I'm Dr. Vinitha Yadav. I'm a second-year resident in Mahatma Gandhi Institute of Medical Sciences, Sevagram. So my case for today is mucormycosis in a case of litosis and external ophthalmoplegia. As we all know, mucormycosis is a fulminant invasive opportunistic fungal infection caused by organisms of the family Mucorrhaceae, which includes Mucor, Ebsidia, and Rhizopus. The incidence is 1.7 cases per 10 lakh population, which is very low. The infection occurs in the immunocompromised state, most common of which is uncontrolled diabetes. The fungus is found in soil and on decaying vegetation, and its spores are inhaled through mouth and nose, and therefore the infection is most commonly seen in the sinuses and lungs. From the paranasal sinus mucosa, it may spread directly to the orbital area and presents most commonly as proptosis, ophthalmoplegia, or bony erosions. So the case that I'm going to present is of a 66-year-old male who was a known diabetic for 15 years, presented with chief complaints of drooping of the right eye upper lid since 1 month, associated with pain, loss of vision, headache, and inability to move the right eye. The presenting visual acuity was perception of light in the right eye with inaccurate PR, and 6/24 vision in the left eye with accurate PR. A mass of 5.5 centimeter into 5 centimeter was seen over the right upper eyelid with ill-defined margins and severe litosis with relatively
Dr. Meeta, your voice is not audible to me. Please unmute your mic.
Sir, it is. Can you hear my voice now, sir?
Yeah. Yes. Now.
Oh, I'm really. Yes, sir. I'm really sorry. Should I start it from the beginning, sir? Then.
Start from the previous 2 slides.
Okay. So I'll start from the case summary. The case. So this case was of a 66-year-old male who was a known diabetic since 15 years and presented with chief complaints of drooping of the right eye upper lid since 1 month, associated with pain, loss of vision, headache, and inability to move the right eye. The presenting visual acuity was perception of light with inaccurate.
Next slide, please, Dr. Meeta. We have already.
Okay. Yes, sir. Yes, sir. So this is the photograph of the patient. We can see the severe litosis in this eye. Importantly, now the fundus evaluation in the right eye showed primary optic disc atrophy with well-defined disc margins and microaneurysms, dot blood hemorrhages, and cotton wool spots in one quadrant, which was suggestive of mild non-proliferative diabetic retinopathy. Similarly, in the left eye, we could also see mild non-proliferative diabetic retinopathy, but there was no evidence of primary disc optic atrophy. So how did we go about the management of the patient? So the laboratory investigations play a very important role in such cases. We did a hemoglobin, which was 11.6 grams. The patient had high blood urea nitrogen of 92 mg per deciliter, high serum creatinine of 2 mg per deciliter, blood sugar of as high as 300 microgram per deciliter. The complete urine examination revealed +3 sugar in urine. The HBS status of HBS antigen, HIV, the patient was negative for these things, and important for these days, the patient was also COVID antigen negative. There was no organism found in the conjunctival swab cultures. Now the CT orbit and brain show a post-septal periphery enhancing lesion of 2.8 into 1.9 into 1.4 centimeter in the superior middle aspect of the right orbit with erosion of the superior oblique fissure involving the superior rectus muscle and the superior oblique muscle. The mucosal wall thickening of the right frontal sinus was also seen, but there was no evidence of any sinusitis. The globes were symmetrical, normal in size, and the optic nerve was also normal. Similarly, cavernous sinus, both the cavernous sinuses were normal. We proceeded with the right eye orbitotomy of the patient, and we got a mass of 3 into 2.5 into 1.5 centimeter, which was removed and sent for histopathology. The biopsy of the sample showed the presence of intense mixed cell inflammation, granuloma formation with fungal hyphae, which were typically thick, non-septate, showing branching on the acute and right angle suggestive of mucormycosis. We can see in this picture a lid mass being removed. So we approached by the superior aspect of orbitotomy, superior incision orbitotomy. Here we can see the acute angle branching of the fungal hyphae. So mucormycosis is a rare but debilitating disease with mortality as high as 50 to 80%, and due to its rapid spread and angio-invasive nature. In the present case, the patient was immunocompromised with uncontrolled diabetes, diabetic retinopathy, and nephropathy, and unfortunately succumbed to death a week later. Orbital mucormycosis is always associated with sinus involvement, except in some cases where it solely occurs as an ocular presentation, as in this case of mine, where there was no sinus involvement. The fungal hyphae directly invades the blood, producing tissue infraction and massive necrosis with bony destruction. In this case, the most important findings were litosis and ophthalmoplegia, which are due to the fungus invading the superior orbital fissure and the orbital apex, hence affecting the nerves second, third, fourth, the first part of fifth nerve, which is the ophthalmic part, and the sixth nerve, which is the abducens nerve. The involvement of the first part of the fifth nerve, first and the second part of the fifth nerve, they may cause diplopia, ophthalmoplegia, the sensory loss to the corresponding areas of cornea and face. Recently, some cases of mucormycosis have also been reported in the COVID patient presenting as swelling near eyes and cheek with blackish discoloration, and therefore COVID antigen testing is very important in the cases that we suspect of mucormycosis. So hereby I conclude by saying that mucormycosis should always be ruled out while dealing with proptosis, ptosis, orbital apex syndrome, superior orbital fissure syndrome, cavernous sinus thrombosis, especially in immunocompromised patients, since it is a highly aggressive disease and any delay may cost the patient's life. Thank you, everyone. These are the references. And I would like to thank my HOD, Professor A.K. Shukla, and my guide, Smita ma'am, my seniors, Dr. Dhaneshri, and my colleague, Dr. Gaurav. Thank you.
So, Dr. Vinita, how did you manage this case before he died?
Yes, sir. So actually, a week later that we performed the orbitotomy in this patient, we got the histopathology results after a week. Till that time, when we tried to communicate with the patient was no more. But we had actually thought of starting the patient with amphotericin, liposomal amphotericin B.
No, but somebody has to wait for 1 week for histopathology, or should proceed with the radiological diagnosis?
So radiological diagnosis was actually not suggestive of mucormycosis in this case. The mucormycosis was only evident on the histopathological basis. So we could not start the patient on amphotericin B because it has its own systemic side effects.
So still, I think that one should start amphotericin B or antifungal as soon as is such a rapidly progressive disease is diagnosed, and should not wait for the gold standard test. So it takes time for histopathology. So one should start, at least somebody has to do local lavage with diluted amphotericin B, and in such cases where the morbidity of this mucormycosis is very high, so liposomal is a very good option. One should start, and you can use liposomal amphotericin B for orbital lavage or was or injection also. So
yes, sir. This was a flaw in this case, that we could not suspect of mucormycosis because it is a very rare disease. So we did not start the patient on liposomal B. But yes, the purpose of this presentation is only so that we actually take mucormycosis into consideration while dealing with the patients of diabetes.
Okay, I think you should go on literature search and and all the best.
Yes,
next
sir. Thank you, sir.
Dr. Krishna, can you present now?
Yes, ma'am. Just a minute. Yes, ma'am. Ma'am, okay. Just a minute. Is my screen visible, ma'am, now?
No, your screen is not visible.
Ma'am, may I join with Dr. Ruju Unadkat's ID? Because I think there's some issue with the screen sharing in my Zoom. May I?
No problem. You can join with her idea.
Hello? I'm audible now, right?
Yes, you are audible.
Yes, I'll be sharing. Just a second. Is it visible, ma'am?
Yes, your screen is visible now.
Thank you, ma'am. I'll begin now. Good morning, everybody. I will be presenting a study of the ocular trauma profile at the Tertiary Care Center. My name is Dr. Krisha Amin. I belong to the MNG Institute of Ophthalmology, Ahmedabad. The ocular trauma is one of the leading causes of visual disability, which can be prevented if proper precautions and measures are taken, as well as early intervention and treatment is a very important factor. There are two of the classifications which have been taken into account in the state, the Birmingham End Trauma Terminology System and the Ocular Trauma Scope. The aim of the study was to report the profile of the ocular trauma at Tertiary Care Center with repercussions and analysis of the prognosis. The materials and methods used for this study were, it was a prospective study with patients taken from both ophthalmic OPD as well as triage in the Tertiary Care Center. We had the data duration of May 2019 to May 2020 with 100 eyes having mechanical ocular injuries. Data collection was done for age, sex, rural versus urban address of the patient, the site, type, mode of trauma of the injury, the day of trauma versus the day of the presentation of the patient, the visual acuity at presentation versus the visual acuity at multiple follow-ups, and the final till 6 months. We have surgical as well as conservative management present for all the patients over here, and the complications, if any, seen. The results of the study were that in age group, we could see a maximum preponderance in pediatric age group, which was later on compared with the least which was seen in old age. For the site of injury, it was similar to work and home, around 30%. And for sex, we could see about 5 times more preponderance in male, and similar for urban and rural location. The agents were causing injury, which could be classified into multiple types, but maximum of which could be seen by wooden stick, metal rods, as well as patients having RTA injuries. The least and few of which could be mentioned worthy are firecracker as well as animal bites. The type of injury which were used for classification according to the Betz could be seen maximally in penetrating cases. Even though Betz doesn't classify the adnexal, we could see 5% of the patients which were having adnexal injuries and only 3% of patients presented with IOFB. The type of injury, according to the anatomical structures which were involved, could be seen for maximum in a corneal tear, and other worthwhile mentioning were the vitreous hemorrhage, which were seen in only 2%, and globe rupture, which was seen in 9%. The posterior segment involvement, was analyzed by using BCN ultrasonography, showed the IOFB presence in 4.9% cases, as well as distorted globe in globe rupture cases, and few with retrolateral membranes. Visual acuity on presentation for most of the patients couldn't be judged properly because of the peak in pediatric age group, so they were uncooperative for the vision examination. Most of the visual acuity was around the range of 612 to 618, and another peak was seen in hand movement present, PLPR 4+. Visual acuity at the final follow-up of 6 months could be seen that uncooperative still, but increase in the 612 to 618 range was observed, and a significant decrease in the HMPL-PR +4 was observed. According to the ocular trauma score, we could classify most of our patients in the grade 5, which was a very good prognosis, around 30% of patients showing increase in the visual prognosis. The conclusion of the study was that ocular trauma was an important cause of blindness and therefore ocular morbidity. And in our study, we could finally say that young age or decreased awareness regarding safety measures, as well as probably old age, was the factor which was causing increased risk of ocular injury. Also, most of the cases, including intraocular foreign body, were associated with endophthalmitis. The discussion for the study leads me to explain that penetrating injury for our study was the most common type, in which also we saw metal rod and stone, the same preponderance, and 35% of patients were presenting to us after more than 24 hours of the trauma which was caused, and 4% of which had developed a few infections. The comparative study done for this was that for mode of injury, Nirmalan et al. Found blunt trauma. As I already said, penetrating was the common for our study. Endophthalmitis risk factors, according to a study conducted at Imphal, was delayed repair, rural setting, as well as IOFB presence. In our case as well, we could see detailed repair and IOFB. The protective gear, which was used in occupational trauma, was found to be no use in VUTS at all, but in our study, 10% were using, and still they had this trauma. The site of injury was for Buska et al. At work, and for us, it was similar for work and home. Presentations and management at our study was seen to be significant improvement in few cases, which were presenting with limbus to limbus corneal tear with a traumatic cataract. The visual presentation could be seen at HMPL-PR4+, after 6 months of which we could see an improvement of 618. There was a traumatic cataract extraction and IOL implantation done in that. Few of the adnexal as well as globe subluxation injuries which were seen in RTA and lid tear repairs multiple were done for RTA injuries. Thank you.
Okay, thank you, Dr. Krishna. So it's a topic on which you can talk on hours, because your presentation includes all those injuries of cornea and sclera. Actually, we are in a session of oculoplasty, so it would be better if you present on the oculoplasty. But still, it's an interesting topic, and what take-home message you have given is important. So, is there any more presenter left?
One more presenter is there, Dr. Shantanu Das. He will be presenting management of orbital fractures. Dr. Shantanu Das, are you there?
Hello.
Yes, Dr. Shantanu.
Hello.
Please share your presentation.
So number one presenter is
Yes, sir.
Present
He has not joined.
okay. Dr. Santanu, please proceed.
Yeah. Yes, sir. Yeah. 1 second. My screen is visible. Hello.
It is not yet visible. No, it is not visible yet.
My screen. 1 second. I'm starting the.
Now it is visible. Now your screen is visible, Dr. Shantanu.
Now it is visible.
Yes.
Hello?
Yes, your screen is visible.
Yeah. Okay, ma'am. Thank you. Yeah. Good morning to one and all. I'm Dr. Shantanu Das, and I'm a fellow at Department of Orbit and Oculoplasty at Shankara Eye Hospital, Bangalore. I'll be presenting on management of orbital fractures and treatment outcomes study. It has been co-authored by Dr. Raghuraj Hegde. So orbital fractures are common and constitute approximately 18 to 50% of
Miss Sanju, there is some technical problem, I think.
Yes, sir. I think Dr. Shantanu Das has left. Let me check. Dr. Shantanu, are you there? He has left.
Dr. Shantanu, actually this session will end by 12 o'clock. So please connect soon.
Yes, sir. We can wait for 2 more minutes. If he doesn't join, we can end the session.
उससे पहले लगा देते हैं 15 मिनट पहले।
मैम की आवाज आ रही है, वो बोल नहीं रही है कुछ, पेपर पलट रही है ना।
31 तो दूसरा नंबर है, ये आप अभी 90 है आखिर में, ये वाला नंबर।
हेलो
Hello, sir. Welcome, sir. Sir, actually, second session has ended and one presenter has.
क्या थोड़ा सा लेट हो गया क्या?
अपना नाम लिख दीजिए, ठीक है?
Yes, sir. Actually, the session is over now.
Okay, Miss Sanju, so we conclude this session. Okay.
Okay, sir.
Thank you very much.
Thank you, sir. Welcome, sir. Dr. R.C. Gupta, sir. You are in third session, I think. Third session has not started yet. The third session is about interesting cases in oculoplasty and ocular oncology. We will be starting that session soon. Our first presenter is Dr. Ruchi Garg. Is she here? Dr. Ruchi Garg, are you there? Prashant. Second presenter is Prashant Pilania. Dr. Prashant, are you there? He is also not there. Sir, fourth presenter has joined. Can we start with him? Okay, then our fourth presenter is Dr. Ashit Handa. Dr. Ashit will be presenting pseudoriferous cyst of the inner canthus of eye, a case report. Dr. Ashit, please share your presentation.
Ma'am, are my slides visible?
Yes, your slides are visible.
Yeah, thank you. Good evening, everyone. I am Ashit. I am presenting my case on sudoriferous cyst near the inner canthus of the eye. I am from UCMS and GTB Hospital. My guide is Dr. P.K. Sahu. And Dr. Isha and Achal are my co-PGs. So, a 64-year-old man presented with swelling in the left inner canthus of this left eye. It begins as a small painless mass 1 year back, and from past 2 to 3 months, there is gradual, rapidly increase in size, and which is slightly painful. And he was also complaining of blurring of vision when he was doing any near day-to-day task. Clinical feature on inspection, the swelling is 2 into 2 centimeter, globular in shape, and it was cystic in nature. There was no any discharging sinus and fistula, and translumination test was positive. And on palpation, the swelling was non-tender, it was not mobile, and it was not fixed with underlying deeper structure. And there is no history of any previous trauma or any other ocular disorder. And other rest of the ocular examination were normal. And there was no any similar swelling elsewhere in the body. Differential diagnosis, we thought of it as a sebaceous cell cyst or any retention cyst. We did an CT scan to rule out any deeper bony involvement. On surgical management, we under the local anesthesia, we use lignocaine with adrenaline. We incise the mass just above the skin. We took incision here, and then we took the cyst in total, and make sure that cyst didn't rupture during the course of his removal. This allowed us to complete dissection of the cyst and with wall intact. And later, this was closed by 6-0 Weichel suture. Now, on this, we got, it was bilobular mass, and then we sent for histopathological evaluation. On histopath, it was single cyst lying by a single layer of cuboidal epithelium, and which contains serous fluid filled with cells, and it resembled sweat gland. And they also did past stain periodic acid shape, which was positive, which suggestive of it is sweat gland in nature. So by their report, we got to the sudoriferous cyst. Then final diagnosis was sudoriferous cyst, and it was originally it is thought to be an childhood origin benign swelling, but here in case it showed in adult, and also it cysts are most common in the margin of the lid where the apocrine sweat gland are present, but here the location is quite different than the rest of the swelling. Thank you.
Sir, can we move to our next presenter? Sir, do you want to ask any question to Dr. Ashit, or should we move to our next presenter?
You can move next.
Okay, sir. Next presenter available is Dr. Isha Acharya. She will be presenting seborrheic keratosis mimicking basal cell carcinoma. Dr. Isha, please share your presentation. Dr. Isha, can you hear me? Dr. Isha Acharya,
Yes,
please
ma'am.
share your presentation. Okay.
Hello, can you hear me?
Dr. Shantanu, actually second session is...
Yes.
Hello, Dr. Shantanu. Hello, Dr. Shantanu, what are you saying?
लोगों ने सिर्फ एक लिंक भेज दिया कि
Okay, Dr. Isha Acharya, continue with your presentation.
Okay, ma'am.
Dr. Isha, you can start.
Okay. Good morning, everyone. I am Dr. Isha Acharya, resident in University College of Medical Sciences and GTB Hospital. My guide is Dr. Jolly Rodki, and my co-author was Dr. Shachi Srivastava. Is my screen visible?
Yes, your screen is visible.
Ma'am, you have probably not allowed. It's not
No, actually, your screen is visible, Dr. Isha.
The presentation is not moving.
You're not audible.
Yes, sir.
You're not audible.
Okay. Yeah. Am I audible, sir?
Now, yes, yes.
Okay. Yes, sir. So I'm going to present on the topic seborrheic keratosis mimicking basal cell carcinoma. And my guide is Dr. Jolly Rodgi and Dr. Shachi Srivastava is my co-author. There are no financial disclosures. So seborrheic keratosis is a common acquired benign lesion of the eyelids occurring commonly in the middle-aged and elderly people. It is a well-circumscribed pigmented friable growth having a soft consistency with a cobblestone surface. These could be multiple occurring over large areas of face, lids, trunk, and arms. Microscopically, three forms noted: hyperkeratotic, acanthotic, and adenoid. These may be mistaken for basal cell carcinoma or malignant melanoma or a squamous cell carcinoma if at all associated with inflammation. So our case was a 75-year-old male who was farmer by occupation, and the chief complaint he came with was a mass on the right eye, lower lid, since 1.5 years. History of presenting illness was that patient was apparently well when he presented with a painless mass on right eye, lower lid, which started initially as a small mole, but gradually, progressively increased in size. History of occasional bleeding on minor trauma was present, like scratching. There was history of weight loss also present, but there was no history of discharge or no significant past systemic or surgical history. At examination, general physical and systemic examination was not significant. There was no preauricular or submandibular lymphadenopathy noted, and no similar lesions were seen elsewhere. And on the right ocular findings, the eyelids showed a large black lobulated raised, well-defined mass. The size was 15 by 20 by 10 mm. The consistency was firm. It had a frond-like appearance. It was attached by a stalk to skin. There was no ulceration within the mass, and small telangiectated vessels were seen within the mass. Grade 3 ectropion with loss of lashes in the region of the mass was also present, as we can see in this. In the extraocular movements, there were full and free extraocular movements in all gazes, and the conjunctiva also was normal at the area of the mass. What we did was an incisional biopsy for this patient. That incisional biopsy showed profuse bleeding during the procedure. Later on, when the report came out to be a pigmented seborrheic keratosis, we planned the patient for excision. What we noticed during an excision was that there was extensive bleeding occurring during the excision. And what we noticed that lid margin, only the skin of anterior lid margin was inward, and tarsal plate was absolutely free. So the defect that was created was about 12 by 7 mm defect, and for which we took a graft from the redundant skin from the upper lid, and it was sutured at that area. Later on, this excision, the mass that we got, it confirmed the mass to be a seborrheic keratosis. So this was the picture showing this area was the area of the defect that was present, which was not involving the tarsal plate.
and hence we planned for an anterior lamellar grafting from the upper skin. So this is the upper lid redundant skin from where we took the graft. On follow-up, there was some amount of hyperpigmentation of the graft noted, and a mild contraction of the graft was also present. However, there was no signs of active inflammation or infection. Lower lid ectropion results suggesting that there was a mechanical effect by the mask. However, the patient could not be further followed up due to COVID pandemic. The differentials other than this that could have been thought of in benign, it would be has seborrheic keratosis, a melanocytic nevus keratoacanthoma, and for malignant tumors, it could have been a basal cell carcinoma, malignant melanoma, or a squamous cell carcinoma. So basically, hyperkeratotic seborrheic keratosis involves stratum corneum. The squamous cell involves stratum spinosum, and basal cell carcinoma, lentigo-malignant melanoma involves the basal layer of the dermis, and the dermis is involved by the melanocytic nevus. So factors pointing towards malignancy in our case was progressively increasing size, weight loss, loss of lashes with ectropion, telangiectative vessels at the surface with history of bleeding on scratching, and profuse bleeding on incisional and excisional biopsy. Moreover, the location of the tumor in our case was lower lid, which is again the most common site for basal cell carcinoma. The tumor in our case was slow growing, similar to a basal cell carcinoma. However, there was no ulceration present at the surface, unlike the nodular ulcerative form of the basal cell carcinoma. As we have already discussed that it occurs most commonly in middle-aged and elderly. It is commonly found on eyelids. It is well circumscribed, friable growth, and has a stuck-on appearance. It is usually superficially located, and unless accompanied by infection, it doesn't involve the dermis. Microscopically, we had discussed three forms, that hyperkeratotic, acanthotic, and adenoid forms are there. Treatment options would be, if it would have been a smaller lesion, we could have gone for a curettage, but because we had a pedunculated larger lesion, we went for an excision. And another option could have been a carbon dioxide laser vaporization, which also shows good results. Basal cell carcinoma is the most common human malignancy, affecting mostly the older population. And the most important risk factors are fair skin, inability to chronic exposure of sunlight, and fair skin. 90% of cases occurred in head and neck, and about 10% of these involved the eyelids. Basal cell carcinoma is by far the most common malignant eyelid tumor. That's why it was kept as the most closest differentials. Most common site is lower eyelid, followed by medial canthus, upper eyelid, and lateral canthus, and slowly growing and locally invasive. It is a slowly growing and locally invasive mass, but it is not metastasizing. It also has three forms like nodular ulcerative basal cell carcinoma, nodular, and sclerosing form. Here, the nodular ulcerative basal cell carcinoma has rolled edges and also dilated and irregular blood vessels, which was also seen in our case, but there was no ulceration in our case. And it can also be we can also compare it with a pigmented basal cell carcinoma, which is a very rare and clinical histological variant of basal cell carcinoma with increased pigmentation and a frequency of 6% of basal cell carcinomas. Seborrheic keratosis so finally we conclude that seborrheic keratosis might be mistaken for a basal cell carcinoma, malignant melanoma, or can resemble a squamous cell in the presence of a dermal inflammation. However, absence of ulceration inflammation points towards a more benign etiology, and histopathology plays a critical role in the accurate diagnosis of pigmented tumors. Thus, it is very important to rule out malignancy before planning a definitive management. Thank you, everyone. Hello.
Thank you, Isha. Sir, should we move to next presenter, or do you have any questions? R.C. Gupta, sir, are you there? Okay, then we can move to our next presenter, Dr. Aanchal Arora. She will be presenting a case of bilateral internal angular sebaceous cyst. Dr. Aanchal Arora, please share your presentation.
Hello. Good afternoon, sir.
Yes, sir. Should we start next presentation?
Ma'am, I'm unable to share my screen while the other participant is sharing. Yeah.
Yes, sir. Yes, Dr. Isha, please stop sharing.
Okay, no problem. Isha.
Yes, sir.
Dr. Isha.
Yes, sir. Good afternoon, sir.
There were many points like presence of a stock, no?
Yes, sir.
Because bases are holding the base, it is not stuck. See, okay, pedunculae will not be there. Then there was no widening of the lid margin. Huh?
Yes.
So these were points were against carcinoma. So I don't think that there were lot of things which were pointing towards confusion.
Yes.
So, but okay, your point was confused, but actually there are not many points which can confuse your condition with the malignancy. Okay, you have exceeded the time, I think. Hello. Hello.
Yes, sir. Should we start the next presentation?
Yeah, please go ahead.
Okay, Dr. Anchal Arora, please start your presentation.
Is my screen visible, ma'am?
Yes, your screen is visible.
Okay. Good afternoon, everyone. I'm going to be presenting on bilateral internal angular sebaceous cyst. It was a diagnostic dilemma in our case. So an 18-year-old male presented to us in the OPD with a gradually increasing painless mass over the nasal bridge extending to bilateral medial canthus with acneiform lesions all over the face since 6 months. The size of the lesion was about 3 × 4 centimeters. The overlying skin had acneiform lesions. There were no discharging sinuses. The swelling was firm, non-tender, mobile, and the posterior extent could be felt. There was no associated lymphadenopathy, and there was no associated systemic swelling. And we did syringing for the patient since it was a medial canthus mass, and it came out to be patent bilaterally. So this was the patient. He came to us with a bilateral swelling over the medial canthus, and it was extending up to the medial canthus. It was present over the nasal bridge, about 3 × 4 centimeters in size. So looking at the patient, we thought clinically that it could be either a bilateral internal angular dermoid, which is pretty rare because we haven't seen bilateral dermoids so commonly, or it could be a bilateral internal angular sebaceous cyst. And the patient had many acneiform pustules all throughout the face. So we did an FNAC for this patient, and it came out to be epidermoid cyst. Then since it was a bilateral mass, to see whether it was present on the nasal bridge, if it was a continuous mass or not, we went for a CT scan also, and it showed a smooth, marginated, hyperdense, homogeneous lesion. It was over the nose and reached up to bilateral medial canthus. The size was 3.4 × 0.9 × 3 centimeters. And the CT scan report was suggestive of a frontonasal encephalocele. But since the patient did not give any history of the swelling since birth and there was no cough impulse present, we were not very keen on accepting the diagnosis as frontonasal encephalocele, and so we went for a neurosurgical referral, and they ruled out the possibility of encephalocele on the basis of their clinical examination. Then we went for a derma referral because of all the acneiform pustules that he had, and they prescribed oral antibiotics to the patient. We deferred surgery for this patient at that time because of his acneiform pustules and risk of infection post-operatively. Then we asked the patient to follow up after a week, but the patient was lost to follow up. He again came to us after 3 months. When he came to us after 3 months, the internal angular mass on the right side had completely disappeared, while the left side mass was still present, as you can see in the above picture. The right side had completely disappeared. Then we went for an MRI orbit because we thought it is a soft tissue lesion. So we went for an MRI, and a well-defined lesion on the left side was seen. It was 1.5 into 0.5 centimeters in size with post-contrast enhancement. The MRI orbit was also non-conclusive, and they gave a possibility of epidermal cyst or sebaceous cyst. Then we finally underwent for an excisional biopsy under general anesthesia with a prior course of antibiotics. Intraoperatively, a solid non-cystic fleshy looking mass was observed, which was non-encapsulated. So our diagnosis of dermoid was a little dicey because it was a non-encapsulated mass with minimal pultaceous material at 2 to 3 sites. And there was extensive fibrosis of the surrounding tissues. This is a post-operative photograph. There was minimal reaction at the suture site as well post-operatively. Histopathologically, they said that there were non-specific cystic spaces and it was lined by granulation tissue, and the histopathology report was suggestive of a foreign body giant cell reaction. Now, foreign body granuloma as suggested by the histopathologist was not we did not expect this diagnosis because the patient did not give any history of trauma, any foreign body penetration. So I'd like to conclude that the diagnosis was clinched on the basis of histopathology as a foreign body giant cell reaction without any predisposing history of trauma. And it masqueraded as dermoid clinically and sebaceous cyst and epidermoid cyst radiologically. The disappearance on the right side was very strange. And so the importance of histopathological evaluation in any benign looking mass cannot be overlooked. Thank you.
So what is your conclusion?
So we thought maybe it was only a left side mass, the dermoid or any cyst, sebaceous cyst, it was on the right side, only on the left side. And then the acneiform lesion was present bilaterally, which resolved on antibiotics because the left side lesion also decreased in size on the left side. So maybe it was a bilateral acneiform big pustule with a main lesion on the left side only. And probably the...
No, your presentation points that the importance of histopathology, that means everything which is removed from the body should be subjected to histopathology.
So your voice is breaking. So
I think this is your conclusion, is it?
Yes, sir.
Hello.
Sir,
yes, sir.
Hello.
Now it is clear, sir. Yes, sir. Now your voice is clear.
Hello. Hello.
Yes, sir. Can you please repeat the question?
Very evident that you are stressing on the importance of histopathology.
Yes, sir.
So I think your presentation points and concludes that can be. I'm asking, what is the conclusion? Okay, we can go to the next speaker. Hello.
Yes, sir.
Hello.
Yes, sir. You are audible.
Hello. Hello.
Yes, sir. You are audible.
Hello. Okay, now we can go to speaker. Hello. Hello.
Yes, sir. Your voice is breaking in between, sir.
Okay, I think we can go to the next speaker.
Are you there? Sir, are you there? I think sir has left the session. Till then, Dr. Pratibha, you can start sharing your slides. We will start the slides once sir joins again.
Hello. Good morning, ma'am. Am I audible?
Good morning.
Hello.
Yes, you are audible.
Okay. Is my screen visible?
Yes, you are audible. Yes, your slides are visible.
Should I start, ma'am?
We should wait for the sir.
Okay, sir. Okay, ma'am.
We can wait for 1 minute. I think sir will join again, Dr. R.C. Gupta.
Okay, ma'am.
I think you can start your presentation. Anyway, your presentation will be recorded. So sir can evaluate them later also. So you can start your presentation.
Okay. Good afternoon. Today I'll be going through a quick review of random OPD cases. My guide is Dr. G.K. Das and Dr. P.K. Sahu. Dr. Ashit Handa and Dr. Akshita Agarwal are resident PGs along with me. I'm Dr. Pratibha Sheshma from University College of Medical Sciences and GTB Hospital, and there's no financial interest. Starting from introduction, during my first year residency in UCMS and GTB Hospital, I clicked a variety of cases for reviewing and reaching out to a probable diagnosis. And thus, I would like to share a few of the cases the practicing ophthalmologist working in big setups might find it interesting. The first case is of acute facial nerve paralysis after dog bite. This is a case of acute facial nerve paralysis. Patient had a history of dog bite in front of the right ear, following which the patient was not able to close the right eye completely. This is the mark where the dog bit. The other case are facial nerve paralysis of different etiologies. Different cases of facial nerve paralysis are being shown here, and most common the causes are being the idiopathic causes. The other case is of Stevens-Johnson syndrome following after oral intake of ibuprofen with ocular complications, which was managed with topical and systemic cyclosporin and bandage contact lens. This is the initial presenting photo, and this is after the bandage contact lens, and this is after 3 months of the bandage contact lenses. This is the case of iris coloboma, 2 cases showing iris coloboma. 2 patients presented with diminution of vision. And on examination, the male had right eye inferior iris coloboma and the female had bilateral inferior iris coloboma. The other case is of acute Deckroy cystitis. A young female presented with swelling near medial aspect of the left eye. The swelling got ruptured on its own and the overlying skin was repaired after thorough exploration of the lacrimal drainage system. This is the post-op photo of the patient. The other case is of dermoid cyst, in which a young female presented with irritation and foreign body sensation in the right eye. On examination, an elevation with hair follicles in it was seen. The other case is of fornical cyst. A child had a complaint of mass protruding through the inferior aspect of the right eye, and the mass was excised with conjunctival suturing with 10-0 Vicryl sutures. This is a case of orbital implant in which a young boy with history of road traffic accident with an ophthalmic socket was planned for orbital implant. This is the case after orbital implant. And the orbital implant with prosthesis. This is the post-op photo of the patient with orbital implant prosthesis. And the patient had a good cosmetic outcome. The other case is of a Cutler-Beard surgery in which this is the case of Cutler-Beard surgery in which there is central large upper lid mass not involving the canthi, and after tumor excision, a large defect was created sparing the medial canthus, in which the stage 1 Cutler-Beard procedure was performed, in which the full thickness flap of a lower lid tissue was mobilized and flap was sutured in layers at the upper lip, at the site of upper lip defect. So the post-operative picture after stage 1 Cutler-Beard procedure was this. This is the other case of sebaceous cell carcinoma in which Cutler-Beard stage 1 was performed and the second stage was planned, but the patient lost to follow-up due to the ongoing pandemic. This is a huge procedure in which there was a mass involving the lower lid was seen. It was on histopath examination, it came out to be a sebaceous cell carcinoma. So a wide mass excision was done in which a pentagonal shaped wide mass excision was done and more than 50% of the full thickness defect was created, not involving the canthi. Second stage surgery, cutting the bridge flap after 6 weeks. So this is the pre-operative picture and this is the post-operative picture of the patient. These are the steps of the Hughes procedure, and the repair of anterior lamella was done and full thickness skin graft from the upper lid was done. This is the site of the incision marked. This is the graft harvested and the donor site was resutured. This is a case of tensile flap reconstruction. It was a case of sebaceous cell carcinoma of left upper lid and the tensile flap lid reconstruction surgery was done and the patient came out with a good cosmetic outcome. This is a case of a lower lid ectropion, left eye lower lid ectropion with hypertrophy of fornical conjunctiva with keratinization. This is the preoperative photo and this is the postoperative photo of the patient. This is a case of neurofibromatosis with Lisch nodules. On slit lamp examination, Lisch nodules were seen. This is a case of festooned pupil with keratic precipitates. A case of anterior uveitis with characteristic findings. Coarse capes are seen and peripheral anterior synechiae are seen along with festooned pupil. This is a case of Descemet's membrane detachment in which the patient was taken for operation again and venting incision was done. So after the surgery, the corneal edema resolved and the patient gained the visual acuity again. This is a picture of after the repair of the Descemet's membrane detachment. This is a case of intraocular foreign body in which a case of pencil tip injury in a young child following which traumatic cataract developed and the pencil tip extraction with cataractous lens removal along with IOL implantation was done. This picture shows the pencil lead. This is the intraoperative picture of the patient. This is again the showing the pencil tip in the iris. This is the post-op picture along with the IOL implantation. This is a case of congenital lower lid ectropion in which a case of left lower lid ectropion since birth with history of watering from eye. Congenital ectropion are rare cases and occurs due to the incomplete fusion of the anterior and posterior lamella during embryogenesis and simultaneous overriding of the anterior lamella. So in conclusion, keeping photographs always help us to know the efficacy and the results of the surgery. And also the photographic records come handy and helps in scrutinizing the cases at any point of the time. Thank you.
Sivo's Pratibha, is it?
Yes, sir.
Huh?
Yes, sir, Pratibha.
Pratibha. Some more participants have come, joined or not? Some more presenters?
Yes, Akshita Agarwal is also there. So should we
You can go. We can go ahead with that.
She will be. Okay, sir. Dr. Akshita Agarwal, please share your presentation. Dr. Pratibha, please stop sharing your presentation.
Yes.
My slides are visible.
Yes, your slides are visible.
Okay, thank you. Good morning, everyone. I am Dr. Akshita Agarwal from University College of Medical Sciences. I'll be discussing about the management of recurrent mechanical ectropion due to hypertrophic conjunctiva. I have no financial interest. A 26-year-old female presented with spontaneous unilateral mechanical tarsal lower leg ectropion with no history of trauma, past surgery, or any skin disorder. On examination, medial canthal tendon laxity and eyelid laxity was found. For the management, topical steroid eye drops and topical antibiotic and drops were prescribed, but no benefit was observed. Once the inflammation was controlled, we went on for medial canthal plication to relieve the medial canthal tendon laxity and the eyelid laxity. As we can see in this photo, this is a post-op picture after medial canthal plication. The laxity has resolved, but still there is a gap between the eyeball and the eyelid margin with the exposed hypertrophic conjunctiva. 5 months later, there was recurrent mechanical ectropion with hypertrophied and keratinized conjunctiva. As we can see in this photograph, the hypertrophied and keratinized conjunctiva is leading to mechanical ectropion, severe mechanical ectropion. Then initial medical management with topical antibiotic eye drops and topical anti-inflammatory eye drops was done. Later on, surgical management was done. The surgical management with the excision of hypertrophied and keratinized conjunctiva was performed with end-to-end closure of the two conjunctival ends. As we can see in this photograph, the dramatic improvement of the mechanical ectropion after the excision of the conjunctiva and end-to-end conjunctival anastomosis. The mechanical ectropion was relieved with good functional outcome. As we can see in this photograph also, the preoperative photo and postoperative photo can be compared to see how much the ectropion, mechanical ectropion has improved after the excision of the conjunctiva. 3 weeks postoperatively, good functional and cosmesis was obtained. Stage surgery was performed. In stage 1, medial canthal plication surgery was done to reduce the medial canthal and eyelid laxity. In spite of that, there was still a separation between the eyeball and the eyelid due to the hypertrophied conjunctiva. Exposure of the conjunctiva led to the keratinization and further hypertrophy of the exposed conjunctiva. Then stage 2 was planned, in which the hypertrophied conjunctiva was removed with end-to-end closure. With meticulous planning and surgery, we can improve both the functional and the cosmetic outcomes. Thank you.
Dr. Akshita, why previously it was not planned in the same stage that both the procedures can be done together? That means there was a lack in evaluation of the severity of the disease condition.
So the exposed conjunctiva was not keratinized or hypertrophied that much, and there was no epiphora or symptoms of the patient. So we tried with the medical management only, and only with the surgery of the laxity with medial canthal plication. But then with later on, the conjunctiva became more hypertrophied and keratinized, leading to more severe ectropion.
No, there are two different components. One is horizontal laxity.
Yes, sir.
Other is vertical laxity, and third is the presence of ectropion. If both three are there, and depending upon the severity, it is most of the time it is not possible that just by plication it comes. You have to do some conjunctival excision, so that many times it may also be needed that the fornix can also be
reconstruction
depend with the suturing to the periosteum of the lower orbit.
Yes, sir.
So that means 2 stages were actually not needed. But okay, if we have done first stage by means deficiency in evaluation, then of course you have to go for the second stage. So just mind it that it is the 2 stages were not needed. Actually, in 1 stage only, because seeing the severity of the condition, in 1 stage patient could have been managed. Okay.
Yes.
Okay, it is just for your, because you're resident, you're just pursuing occuloplasty, so that's why yes, there is a suggestion. Okay.
Yes. Thank you.
Because going to stage multiple stages, patient goes through all melted trauma. Because for us the doctors, we don't have any problem, because we can always go do a repeat surgery. But you can imagine yourself as a patient, then going through every surgery, patient has to pass through all trauma.
Yes, sir.
Mental trauma which he has.
Yes, sir. So, but earlier there was no symptom like epiphora or any complaint, so we didn't went for that excision.
Okay. Good luck.
Yes, thank you, sir.
The 5 presenters are not there. I will just make a final call. Dr. Ruchi, are you there? Dr. Prashant, Dr. Neha, Dr. Nitish, and Dr. Priyanka. Do we have any presenter here?
In participants, they are not shown.
Dr. Ruchi, Dr. Prashant.
In the
Yes, sir. No
participants, they are not there.
Yes, sir. They
That
are
is
not there.
That is again a problem of the web presentation, that even the presenters are not joining. I think in the live halls there were more participants than in Zoom. Is it?
Yes, sir.
So we can close the session now. Are there any more?
So there are no presenters at present. So I
So
think we can close.
okay, so is there any form in which we can send our marks? How can we send our?
Yes, sir. Yes, sir. An Excel sheet will be sent to you. You have to mail it to Nambata ma'am.
Okay.
Yes, sir.
Okay, thank you.
Thank you, sir.
So you can leave the meeting. So should I leave meeting?
Yes, sir. Yes, sir. We can leave.
Okay,
I think there is no presenters. Okay, sir. Thank you, sir. क्या लास्ट सेशन में कोई आया ही नहीं है छोड़ दिया ना मीटिंग मैंने
यार ये बताओ, ये भी मेरा ऑडियो कनेक्टेड है जूम में? चलेगा ऑडियो? नहीं आप क्यों कर रहे हो उसे? वो अब ऐसे करके बोलना, अभी सुनाई दे रहा होगा जो हम बोल रहे हैं? कैसे होगा?
मेरा नाम क्यों आ रहा है? तो कोई नहीं, देख लेंगे अपना। मान लो यहीं से रीनेम ही करते हैं अगर एक और फॉर टाइम भी। तो ये तो नॉर्मल वो
Hello, anyone from the DOS AV here? Hello, good afternoon. Anyone from the DOS office here?
sir, बोलिए.
Yes. Can you see my slide share? And
sir. Yes, absolutely.
Okay. Okay. I just wanted to check, and there are few videos. Is it running fine?
No issue, sir.
Okay. Thank you. Thank you. I'll just stop it.
Doctor.
Am I visible?
Yes, yes.
Is my slide visible?
Yes, sir.
Is it changing?
Yes, it's changing.
Thank you.
Hello, is someone from DOS office there? I'm trying to screen share my slide. Is it visible?
Yes, sir, it's visible.
Okay. Is it going ahead?
Yeah, it's everything working fine.
Okay. Is my audio fine?
Yes.
Hello?
Sir, it's working fine.
Okay. Thank you so much.
Thank you, sir. Hello, Dr. Akshay.
It can be continued for 4 to 6 weeks. We can always try injection of
Good afternoon, everyone. We'll be starting with our session. If we can have everyone's videos on, please. Welcome, Dr. Urmil Chawla and Dr. Akshay, who've kindly agreed to judge this session for us. I am Dr. Prakhyat, and I'll be moderating this session for all of us. I have a small question for the judges. Have you got your sheets in which you're going to mark the candidates? Okay.
Yeah, the sheet is there, but the instructions are not there. How is the marking? Like how many marks? How out of how much marks?
Just please check your inbox on Zoom chat. I am just sending you the instructions. We are still waiting for Dr. Sahil to join. I think he's the last presenter. Is Dr. Sonali here? Dr. Sonali is not here. So we can start now with the first presentation, and Dr. Urmil, you can just check your inbox. Dr. Harshita, your video will start when your presentation comes on. So we'll be starting now with the first presentation, that is by Dr. Soumya Sharma. Are you ready with your presentation, ma'am? Can we have the timer, please?
Yeah, I'm ready. Wait, let me share the.
At the back end, please, can we have the timer on now?
Wait a second.
Are the judges also ready?
Yes, please.
Okay, Dr. Soumya, you can please start your presentation. We'll be presenting on the melting phase, neurofibromatosis, diagnosing and conquering it. Please start.
So is my screen available?
Yes, we can see it. Please go ahead.
So good afternoon, everybody. I'm from SGT University. I'm a resident third year. I will be presenting my presentation on the melting phase, neurofibromatosis type 1, diagnosis and conquer. So neurofibroma is a rare developmental syndrome caused by the germline mutation in neurofibromin, a gene that is involved in the RAS pathway. The common symptoms of NF1 include benign skin tumor neurofibromas, larger benign tumors of nerves, scoliosis, learning disabilities, vision disorders, mental disabilities, multiple capsular spots, and epilepsy. The CNS manifestation include unidentified bright objects on a T2 weighted MRI on the brain that can be found in cerebral peduncle, pons, midbrain, medulla, globus pallidus, thalamus, and optic radiations. So, what are the manifestation of ocular one? Lysch nodules are the most common ophthalmic manifestation in NF1 cases. Eyelid with neurofibromas typically feel like a bag of worms with indistinct borders. Orbital neurofibroma can be caused strabismus or proptosis, amblyopia due to ptosis or Retinal astrocytoma hematomas are benign tumors of the retinal nerve fiber layer that can involve bilateral optic nerve and posterior pole. The choroidal hematomas and glaucoma are the rare findings in these cases. So this was a case. An 8-year-old prepubertal old male presented in OPD with swelling on right upper lid, brow, and that extended towards the right side of forehead since 2 years. The swelling grew gradually and progressively and was painful and fleshy to touch. No history of trauma, and vision was in right eye it was 636 on after lid elevation, and in left eye it was 6.6. Right eye had amblyopia with 15 degrees of esotropia. The extraocular movements were full and free, and anterior segment fundus findings were normal. So general physical examination revealed that a capsular spot was seen on chest and abdomen. So, and on MRI, T2 weighted MRI image showed soft tissue mass on right forehead, not extending towards brain, hyperintense lesion on caudate lobe on a T2 weighted MRI of the brain. When we did histopathology of this case, as we can see, multiple nerve fiber interlacing neural tissue with spindle cells and a myxoid area in the background was seen. Tumor infiltrates also surrounded fat, muscle, and adnexa. So these were the surgical steps that we performed. For the marking were made on the by taking reference from left eye. Incision was made on the upper eyelid, exposing the areolar fat, taking as a lid piece and as in demarcation line. Then lateral canthotomy along with the debulking of upper lid was done. The concentric shape incision was made on forehead, taking upper margin of eyebrow as reference. And then exploration and excision of plexiform material was done using unipolar cautery. And the extra loose skin was excised, and the suturing was done with the 4 zeros interrupted silk sutures. As we can see, post of 1, 7, 14 day, the swelling reduced and both eye appeared to be relatively symmetrical. Jumping on to discussion, patient was diagnosed with neurofibromatosis type 1 clinically, radiologically, and histologically. Patient had mechanical ptosis due to plexiform lesion on right eye upper lid and right side of forehead, which later led to stimulus deprivation, amblyopia, and esotropia in right eye. No other ocular finding was elicited in the case. So what was the planning that was involved in this case? The step 1 was debulking of neurofibroma from lid forehead. That was done in our case as in step 1. The patient is being planned for frontalis link surgery to correct the residual ptosis. And later on, when the ptosis has been corrected, then we'll move on to squint surgery. If, as we saw in this case, the Bell phenomena was present. The neurofibromatosis is a rare disorder which is slowly progressive, and patient can be asymptomatic initially. It is important to diagnose and treat subcutaneous plexiform lesion, especially when they occur around the eye. If not treated timely, this will lead to complete ptosis and would later lead to ocular insult. Proper screening of patients should be done at regular intervals to diagnose any other ocular manifestation of NF1. There is no specific treatment of NF1, only symptomatic relief can be given using drugs and surgical excision of neurofibromas. Although there are lately newer FDA approved in, or even just in 2020 April, it is selumetinib that has crossed all trials and will be in US market soon. Thank you.
Please go ahead with your discussion. We have a time of 2 minutes to discuss. The judges can ask their questions, and then if we have some remaining time after the end of all talks, then we can use that for a common discussion. So please go ahead, ma'am.
Dr. Akshay, or should I start?
Please,
Good
ma'am.
afternoon,
Please.
Dr. Akshay.
Hello, ma'am. How are you?
Okay. Dr. Soumya, a very nicely presented case, and I would just want to know how it can be. I think we've lost Dr. Soumya's connection.
Yeah, ma'am.
Okay.
I'm here.
Okay. Hello?
Yeah, ma'am.
I just wanted to know how long the patient has. Can you put your video on? I can't see you. And how long has been the patient on follow-up with you right now?
Ma'am, actually, due to COVID, we lost the follow-up. It was operated in March.
Okay.
So patient went off to his native place in Bihar. So we are just waiting for him to.
So do you expect recurrences in such cases?
Yeah, we totally accept that. Ma'am, recurrences are too common, and we need to really tell the patient regarding the prognosis and regarding the recurrences. So it is not very common, as it is very slowly progressive, but it is there.
And which tumor do you think, which optic nerve lesion is commonly associated with NF?
Ma'am, optic nerve
is quite
glioma.
closely associated.
Optic nerve
Optic nerve glioma, and you should also look for bony deficiencies. They may be congenital also, or they may be due to the bony erosion also. So you need to be careful about that. Besides this, you've already covered the leash nodules are very common, and your case was a typical presentation. And also the ptosis which is present, you specifically see an S-shaped contour often with the in these cases, and that is quite diagnostic of NF1. Any systemic investigations you would like to go ahead?
Ma'am, actually, systemically, patient is not very much affected in these cases. So I don't think so. There is a specific systemic.
Okay.
Although there's some kidney and liver involved in these cases, but
yes,
it's not very specific. Ma'am, according to the text, MRI and histology are the main diagnostic modules in these cases, and X-rays, X-rays, and all.
Yeah, you're right. Baseline investigations should be covered once, and the patient should be kept on follow-up.
Yep.
Right. Dr. Soumya, I just had a couple of questions. I missed a bit of the audio because I'm having a bad connection. Did you what was the guideline for excision of the or debulking of the lesion above the brain, above the brow, and in the eyelid? Did you measure? Did you overcorrect? Was there any?
Sir, actually, the problem with neurofibroma is that it really engulfs all the structures around wherever it spreads. So LPS was totally engulfed, and it also engulfs the vessels and nerves. So it's very difficult to demark. But yes, we did demarcation of the lid crease, taking 8 mm from the lid margin, and took the incision from there and started debulking. And taking on the lateral canthotomy was also done, so that because as ma'am said, that S-shaped mass really is a prognostic thing, as we see in these cases, that overhanging S-shaped mass usually covers majorly towards the lateral canthus. So after debulking the total material from the lid, so lateral canthotomy was done, and extending sutures were being applied there. But in cases of forehead, yes, the area above the eyebrow margin was incised.
Okay.
And explored, and as much as loose skin was there, it was excised.
You ought to have a good diathermy actually while you're doing such cases.
Yeah, ma'am.
So a very good diathermy is
So
yes,
nice.
As you rightly said, that because we are really going blind in these cases, so bleeding can really spoil a case.
We're just overshooting with the.
Okay, you can start with the next.
Case,
so you just give us a hint. We'll stop there.
Yes, ma'am. Okay. So next would be Dr. Saurabh Kamal, who will be talking on twice failed dacrocystorhinostomy, opening the Pandora's box.
Yeah, maybe all presenters can be very brief and specific in their answers. That will help us cover more.
Can Dr. Soumya stop sharing his screen so that I can share? Yeah, thank you. Is my screen visible? Slides visible?
Yes, please go. Can we have the timer on?
Yeah, good afternoon, everyone. So my topic is twice failed dacrocystorhinostomy, opening the Pandora's box. So I start this case, 28-year-old female who presented with persistent watering and discharge in left eye. She had underwent 2 lacrimal surgeries, both external DCR, as evident from the 2 external incision. One was 7 years and another one was 3 years back. On examination, there was upper and lower punctum were normal. Regurgitation was negative. On syringing, there was clear fluid regurgitation from the same canaliculi. And on probing, there was soft stop at 10 millimeter in both the canaliculus. Based on these findings, she was advised and left with the option of conjunctival DCR, as was mentioned in the referral. So the next step in such a case, or in any case of acquired nasolacrimal duct obstruction, is the nasal endoscopy, which showed complete cicatricial closure of the ostium, incomplete superior osteotomy as evident from the scar, which is mainly inferior and anterior. And on the video, you can see when the probe was passed, there is a movement occurring in the lateral wall of the nose, suggesting that the probe is reaching till the mucosa. So before I move on to the case, let's see some of the causes of failed DCR. So these can be non-surgical, which result from wrong preoperative evaluation, certain etiologies and patient factors. And of course, the surgical causes include improper sac localization, inadequate sac opening, insufficient osteotomy. The usual findings in failed DCR can be punctal or canaliculus stenosis, cicatricial ostium closure, granulomas, synechiae, incomplete bone removal, and there can also be a functional component. So what would be the next step in such case? So I planned the exploration along with the endoscopic revision DCR with mitomycin and intubation under general anesthesia. So this is a case surgical video. We start with the intubation of the upper canaliculus. We can see the probe which is coming till the nasal mucosa, and you can see the mucosa moving. So we start with the number 15 blade. We give the incision over the nasal mucosa. We lift the nasal flap. We dissect with the number 15 itself because it has a very rigid dissection. So next step is to palpate with the periosteum elevator that whatever the bone and soft tissue is there. And this is a quite diffuse bleeding from the new bone which has occurred just adjacent to the lacrimal sac. So this was being taken care of with the Carrison bone punch. After this, you can see the residual remnant sac which is there, and this thick structure which is actually the very thick lacrimal bone there. So this was then dealt with the diamond burr. Also, there was insufficient superior osteotomy, and this diamond burr was used to extend it. We should be very careful to take these small pieces of bones, especially from the ethmoid mucosa, because these are adjacent to the lacrimal sac. So after this, you can see a nicely opened agar-Nasi cell, which is very large, and ethmoid sinus. And superiorly, there was a very interesting finding, which is actually not a vessel or a nerve. This is actually a retained silicon tube. So this is evident. You see, right, the silicon tube is there right at the common canaliculus, which can be seen after with the probe moving in and out. And next step is to incise, open up the sac with the crescent knife. So you can see the retained silicon stand now very nicely. The knot, basically previously the surgeon has tried to pull the tube from the eye side. So after this, you can see the probe coming nicely into the sac, and the anterior relaxing incisions were made, and a ball probe was opened to make the sac open in book-like fashion. This was then followed by silicone intubation using 23 gauge silicone and circumostial injection of mitomycin C. So this patient did well after the surgery. She had ultimately resolution of epiphora. So to summarize, what the case findings in this case is the improper ostium location, inadequate superior osteotomy with high internal common opening, posterior thick lacrimal bone, ethmoid sinus which was left open, and retained silicon tube. And also if we see the skin incision was inappropriate because it was quite anteriorly, and therefore it resulted in anterior and inferior osteotomy, whereas it should have been like given here. So any case of a failed DCR is like opening a Pandora's box. You will come across some of the unexpected troubles, and you have to identify and manage them. This is another similar case. 25-year-old underwent 2 surgeries, and she also had retained silicone stent which was removed from the lacrimal sac. So one thing I would like to mention is the pseudocanalicular block, which can be caused by the silicon tube, as you saw in the previous case, and also the ostium granuloma. So basically, in such cases, if you pass a probe, you will have a soft obstruction that will give us feeling of a canalicular block when it is not present. So the take-home message from my talk is always there is a cause of failure. You should do complete case evaluation, and nasal endoscopy is must. Do not attribute always soft stop to the canalicular block, because these can be caused by granulomas or some other soft tissue present in the ostium itself. We should approach stepwise anatomically, deal with the nasal mucosa, bone, and the lacrimal sac, and avoid iatrogenic failures. Do the complete silicon tube removal, and always do post-op nasal endoscopy. So that is from the talk. Thank you. I would like to end with this note.
Okay, so straight away to our judges. We have 2 minutes for discussion.
I have just a couple of questions. I noticed that you injected mitomycin C around the ostium, circumostium. You called it circumostial mitomycin C. One, do you use mitomycin C in all cases? And this circumostial, can you tell us something more about this?
So basically, the mitomycin C it's indicated in complex cases, may not be indicated in the primary cases, but any cases of revision failed ECR with small sac flaps, or any nasal pathology where you expect that post-op fibrosis will be there. Also in cases of acute, with a history of there is any acute dacryocystitis. So circumostial mitomycin is an alternative way of, it basically involves injecting the mitomycin C around the ostium into the nasal mucosa. So the purpose of this technique is to achieve very high concentration of mitomycin, which is also very long lasting. And this is specifically has been studied from the by the LVPI by Dr. Javed, where they have described a series of even both the long-term follow-ups that this technique of mitomycin C has a good outcome in maintaining the ultimate successful.
Okay, thank you for that answer, Dr. Saurabh. We'll now start with the next presentation of Dr. Shubha Sharma. But before we begin with that presentation, I'd like to tell everyone that be specific with your answers to the judges, because the more you answer specifically, the more they can ask you and explore your paper better. So with that, I'll hand over the screen to Dr. Shubha Sharma. Please start your presentation.
Am I audible to everyone?
Yes.
Yes, please go ahead.
Okay. So the topic for my presentation is the bilateral proptosis as the sole ocular and systemic presentation, eventually leading to diagnosis of sarcoidosis. So
you can start a slideshow, ma'am.
Yeah, okay.
Yeah, please go ahead.
So sarcoidosis is a systemic disorder that affects multiple organ systems, primarily the lungs, in more than 90% of cases. It is characterized by the non-caseating epithelioids and granuloma pathologically and hilar lymphadenopathy on the CT chest. The ocular sarcoidosis can affect any segment of the eye and its adnexa, producing a wide range of clinical manifestations. Now, starting with the case, a 39-year-old male presented with bilateral bulging of eyes since 4 months in Department of Medicine and referred for ophthalmic evaluation. It not associated with any systemic feature. There was no history of blurring of vision, double vision, pain. So examination findings were his best corrected visual acuity was 6/6 for both eyes. Color vision was 17/17 OU with contrast sensitivity of 1.6% and intraocular pressure of 21 millimeter mercury both eyes. The Shermer's test was done and we found that it was 15 for right eye and 20 millimeter for left eye at 2 minutes.
Extraocular movements were full for both eyes. Lid retraction was present in both eyes. Lateral flare was there. Periorbital puffiness was there. Retrobulbar resistance was within normal limits. Hartel's exophthalmometer shows 24 millimeter for right eye and 26 millimeter for the left eye. So these are the various views. This is the front view. This is the lateral view for the left eye, the lateral view for the right eye, and the Worm's view. So this is a video showing the movements of the patient. The extraocular movements were full.
आवाज आ रही है मेरी? शेयर स्क्रीन। हाँ, अब यार नहीं कर सकते। ठीक है, रुक जाते हैं। हम देखते हैं कि आप कहाँ पे हो। ये मेरा ही बॉक्स है, इसको
Everyone else except the presenter, please mute.
Diagnosis of thyroid orbitopathy.
दूसरे वाले हैं वो वाले?
Idiopathic inflammatory
Just a second, Dr. Shubhra. Dr. Himani, can you please mute? Can I request the backend to please mute everyone else?
देखो मेरा सेमिनार है POAG पे।
Dr. Himani, please mute.
नहीं हो रहा ना यार, रिपोर्ट नहीं हो।
Okay, please continue. Sorry.
We'll consider this time loss, Mr. Shubhra.
Yeah, we'll compensate for that.
Okay. So this brings us to the differential diagnosis of thyroid orbitopathy, Wegener's granulomatosis, idiopathic inflammatory pseudotumor, sarcoidosis, Sjogren syndrome, and lymphoma. So investigations that we did were the anti-TPO antibodies, thyroid receptor antibodies, and thyroid profile. All these were within normal limits. The CECT orbit that we asked for the patient suggests that the distance between the anterior margin of the globe to the line is 24 on the right side and 26 millimeter on the left side. The findings are compatible with ocular proptosis, and there were bilateral inferior rectus appears bulky and shows post-contrast enhancement. So this is the CT scan orbit in the transverse section and in the sagittal section, and the proptosis here is quite obvious in both the sections. The other investigations we did was serum anti-nuclear antibodies, Montauk's test, tuberculosis PCR, all within the normal limits. Though when we asked for the liver enzymes, the SGOT and SGPT were both raised. Serum ACE was raised as well. The CECT chest shows enlarged mediastinal and hilar lymph nodes as shown in this HRCT chest. The hilar lymph nodes were enlarged. This brings this hilar lymph nodes can also be there in tuberculosis. So we have already ruled out with TB PCR and Montauk's, right, as both were negative. The serum IgG4 was within the normal range. The hemogram was within normal limits. The peripheral blood smear shows a normocytic, normochromic blood cells with adequate platelets and normal WBC. So at the last, we asked for endoscopic ultrasound guided FNAC that revealed few epithelioid cell granuloma and giant cell in background of reactive lymphoid cell. So finally, we come to the diagnosis of sarcoidosis, and patient was started on oral steroids, tapering the dose for 4 weeks. So this is a picture of the patient post 4 weeks, and we did the Hertels, which comes out for 22 for right eye and 24 for the left eye. So sarcoidosis is a multi-system granulomatous disease with ocular involvement in 25 to 80% of the cases. Uveitis, though, is the most typical ocular manifestation in almost 30 to 70% cases. In adnexa and orbit, Sarcoidosis can also involve orbital adipose tissue, extraocular muscles, and optic nerve sheath, resembling to great extent the other inflammatory disorder affecting orbits such as Graves or ophthalmopathy. The conclusion is the bilateral axial proptosis with lid retraction as only manifestation is a rare presentation in sarcoidosis, whereas thyroid-associated orbitopathy is the most common cause of exophthalmos, seen in 25 to 50% cases with Graves' disease and hyperthyroidism. So when an ophthalmologist receives referral for exophthalmos, they should be aware of the condition that may mimic thyroid-associated ophthalmopathy, giving way to sarcoidosis as a strong differential. So take-home message is, it is a rare case with bilateral proptosis as sole initial manifestation of biopsy-proven sarcoidosis and negating the thyroid-associated ophthalmopathy as potential differential diagnosis. The ocular involvement as initial presentation in biopsy-proven sarcoidosis warrants long-term follow-up as the active systemic disease can develop months to years later. Thank you.
Okay, thank you. Sir, ma'am, questions for Dr.
Yeah. Although your case did not have any loss of vision, but what do you think is the commonest cause of loss of vision in patients of sarcoidosis?
Ma'am, it is the uveitis, the posterior uveitis that can cause the vision loss in most patients.
So the CME, the cystoid macular edema, can lead to the main visual loss. Okay. Yes, sir, Dr. Akshay, sir.
Yeah, Dr. Subhada, I just have one question. Is it possible that your patient had, based on the clinical findings, had possibly a euthyroid thyroid eye disease and also had a coexisting either a sarcoidosis, which was possibly detected on evaluation? Because we know that even thyroid eye disease, if the disease is in the active phase, it is going to respond to steroid to some extent and the proptosis might go down. So how do you explain that? If the finding is so rare that, you know, it's just an isolated proptosis and sarcoidosis, and if this is a very rare presentation, did you rule out a euthyroid thyroid eye disease? And is it possible there are two coexisting pathologies?
If it had been a euthyroid, though I know that the thyroid, the management of thyroid and sarcoidosis in this case will be the same. The euthyroid condition can coexist, but we can't also think that if it has been euthyroid, then it would not have caused the proptosis.
So not really. I mean, euthyroid thyroid eye disease can present with proptosis and the other eyelid signs of thyroid.
Okay. Great.
Yeah, that's it.
Just one quick question. Any reason why you chose to, one is where did you take the FNAC from? And any reason why you did not do an open biopsy?
Pardon, sir?
So first is where did you take the FNAC from? Which structure? And any reason why an open biopsy was not preferred?
So, sir, there was, we did the FNAC from the subcarinal lymph nodes, and the open biopsy was not done, sir, because there was no palpable. The open biopsy was not done because there is no palpable lesion present. As I have shown in the CT, there was no palpable lesion present. There was just proptosis, and that is the basis of my presentation. The patient came to us with only and only proptosis in this eye. There was no systemic association found. So that's why the diagnosis here is important.
Okay. So, I think we don't have Dr. Sonali with us. Is Dr. Sonali here? Okay, we'll move to Dr. Sunita's presentation. Ma'am, are you ready with your presentation? Dr. Shubda, can you please stop sharing your screen? And Dr. Sunita can start sharing her screen now.
Give me a moment.
Dr. Sunita, can you start your presentation now?
Is my screen visible? Is my
So
screen visible?
I can't see your screen. Sorry. Okay, while we resolve that, we'll have Dr. Agam Bhandari present. Dr. Agam, are you ready with your paper, lower lid
Yes.
aspergillosis?
Yes, I'll be starting.
Okay. So you can start sharing your screen and then we can have Dr. Sunita. Meanwhile, we'll try solving her problem. Dr. Agam, please start sharing your screen.
Hello, is it visible?
Yeah, it's visible. You're audible. Please go ahead.
Okay. Thank you. Good afternoon, everybody, respected judges and my colleagues. I'll be presenting a case of lower lid aspergillosis, which was found in a pregnant female. So our patient was a 34-year-old female with the 28 weeks gestational age, and she came with a main complaint of a mass in the lower lid. So for the past 2 weeks, it was gradually increasing in size, and she gave a history that it used to touch, it used to bleed when touched. There were no other systemic complaints around the same time frame. Her pregnancy was uneventful. Coming to the ocular examination, her unaided visual acuity in the both eyes was 6/6, and the IOP was within normal limits. The lower lid in the left eye showed the hyperpigmented mass, which was associated with a congestion on the surrounding fornix. The rest of the NDS segment was within normal limits. A lens was clear, and the fundus also had no remarkable findings. Coming to the clinical picture, we can clearly see the lower lid mass and the surrounding congestion around it. Rest of the cornea and conjunctiva appears normal. The fellow eye also has no similar lesion. Coming to another view of the same, we can see get an idea of the size of the mass and the hyperpigmented skin over it. Now, we made a provisional diagnosis of pyogenic granuloma considering the hormonal status of the patient and the positive history that she gave, suggesting that it used to bleed when touched. So we went ahead with a local incision under local anesthesia and followed by closure of the wound with a vicryl suture. We obtained this sample, which was around 16 into 11 millimeters in dimensions, and you can appreciate the size here. We sent the histopathology sample as we expected a small vascular tumor, but to our surprise, the pathologist actually told us that there were elements of fungal hyphae in there and no elements of a fungal tumor. I'm sorry, no evidence of a vascular tumor. Here we can see that clearly there are elements of fungal hyphae with the with the acute angle branching and a septate hyphae. Now these findings on a Gomori methenamine silver stain are very typical of a aspergillus infection. This was the final diagnosis that we could make only after a histopath examination was done. So our final diagnosis came to be aspergillosis, but we had also kept a tuberculoma or a verruca vulgaris at the back of our minds, considering the high load of tubercular infections in our population. Post-operative, this is at a 1 month follow-up, we saw that the patient's left eye was very much back to being normal, no congestion noted, and most importantly, no recurrence was noted. Coming to a discussion about this case, we can see that this was caused by aspergillus, which is a transient contaminant of the ocular adnexa. And it can cause a variety of infection, right from fungal ulcer right to endophthalmitis. And as we know from our classical teaching that immunocompromised states are the biggest risk factor for invasive fungal infection. But in our case, the patient had no as such immunocompromised state. All her viral markers were negative. No reason to suggest that she was immunocompromised. But it is important to note that pregnancy itself has a high degree of immunomodulation, even if there is no immunocompromise. Because as it is easy to understand that the fetus needs to be saved from rejection from the mother's body. So there is a good degree of placental immune response that is modulated tightly. And this itself also affects the affinity of the specific pathogens that they can infect the feto-maternal unit or the mother itself. And due to these variety of reasons, we need to understand that there is a specific vulnerability in this group because of the unique immunological condition. As such, this immunomodulation has limited spillover, but in this case, this created a challenge for us so as to how to approach and treat this infectious disease, and if possible, for future to further prevent it. The treatment that we followed after we came to know the histopathology report, that we started the patient on topical fluconazole ointment twice a day for 4 weeks. The main reason for doing this was to prevent any recurrence, and since the mass lesion was taken out. As the patient was pregnant, we tried to avoid any systemic antifungals as there is no proven track record of as such. Although if needed in severe cases, systemic drugs could be done as the patient was in a third trimester and risk of teratogenicity is minimum. We are happy to report that even at 6 monthly follow-up, the patient was doing fine. She has delivered a healthy baby, and there was no recurrence of the fungal mass as such. The most important learning from this that we can take off is to send every mass lesion that you get for histopathology. And it is, as we have been classically taught, this is to check for any malignancy that may be in any lesion. But even importantly, an infection or infestation it can also be looked for. Going in hindsight, if we had got any hint of it being an infection, we could have also sent a bacterial and fungal culture. And the most important, when you get the report, to modify the treatment as per the report that you get. Thank you so much.
We can directly go to the judges. Agam, you can stop sharing your screen.
It was an excellent case. I haven't come across a similar lesion. Just a quick question. Since you sent it for a pathology, what
Yes,
did
sir.
you have? Was there any evidence of a sort of a tumor or a pyogenic granuloma? Because it possibly could have been a large tumor or a pyogenic granuloma or a benign mass that could have had
Yes, sir.
superadded infection.
Yes, sir. Actually, we had a talk with our pathologist, but there were no elements of vascular structures in there. It was a granulomatous lesion, but the most prominent finding in this was a fungal hyphae. So we were also surprised by this finding.
Does the literature tell you regarding the recurrence of such lesions?
As such, a lid fungal infection, I couldn't find a similar study or a article about the same. But we know about the orbital fungal infections that which are very hard to cure by, especially by topical medication itself. So systemic therapy and a close follow-up in those cases is important.
What could have been the etiology in this case? Trauma?
Ma'am, there was no history of trauma as such. The patient, actually the high humidity and temperature of our, although not in the current months, but in the summer months is conducive for fungal infections. So that is a likely possibility, ma'am.
Thank you. Now we'll have our next, the previous speaker, Dr. Sunita. She's been able to share her screen now. So, Dr. Sunita, are you ready?
Yes.
Okay, please go ahead. Can we reset the timer and start the timer? Please start your presentation.
Good afternoon, all. The topic of my presentation is congenital eyelid imbrication syndrome with floppy eyelids. We report a case of a congenital eyelid imbrication syndrome associated with congenital floppy eyelid syndrome that was managed conservatively over 10 days. It is extremely rare, benign, and self-limiting condition. It has a classic triad of bilateral upper eyelid overriding the lower eyelid, bilateral medial and lateral canthal tendon laxity, and tarsal conjunctival hyperemia. A full-term newborn female was born at 42 weeks to a gravida 1 nil parity mother through emergency cesarean section indicated by meconium stained liquor and fetal distress, weighing 2.5 kg and with an APGAR score of 10 on 10. An ophthalmic consultation was requested on the next day of the delivery for inability to open eyes and spontaneous bilateral upper eyelid eversion on crying. Antenatal period was uneventful and there was no history of maternal disease, drug use, or consanguinity. On ocular examination, bulky upper eyelids of both the eyes which overlap the lower eyelids during eye closure were present. Both the upper eyelids had a tendency of spontaneous eversion on crying, revealing the hyperemic tarsal conjunctiva of upper eyelids in both the eyes. The everted eyelids required manual reposition. The median and lateral canthal tendon of both the eyes were lax and round, and the upper eyelids were easily everted by gentle tuck on the skin of the upper eyelid towards forehead. The cornea was clear in both the eyes and was not taking any steam. The ocular motility was full and unrestricted with no lid lag or lag of thalamus. Rest of the anterior and posterior segment were with pupillary dilatation were unremarkable. Okay, this was a video of the child showing the spontaneous lid eversion, but I'm unable to play the video. There is a picture showing the conjunctival hyperemia with the lid eversion in both the eyes. The ocular measurements on examination for both the eyes were horizontal palpebral length of 17 mm and a vertical palpebral aperture of 5 mm. Midpoint vertical lid crease height was 10 mm. On systemic examination, no features of Down syndrome were found on systemic evaluation by the pediatrician. The child was managed conservatively with eye drop tobramycin 6 times a day, iron and lactogel 1% TDS, and nighttime lid taping. Follow-up on day 5 showed improvement with upper eyelids gradually assuming normal position with minimal overriding and little conjunctival hyperemia, which gradually resolved by next visit, that is on day 10. Congenital imbrication syndrome is rare, benign, and self-limiting with unknown etiology and unexplained pathophysiology. The condition was first reported by Romelt et al. In 2004, who also suggested that the longer and less stretched canthal tendons were the attributing factors, and gradually tightening, possibly related to postnatal growth, may have resulted in its resolution. The self-limiting bilateral rare condition is associated with lax eyelids and congenital variety, while the acquired ones need a definitive surgical correction. An association with Down syndrome is suggested. The physical finding of upper eyelid overriding the lower eyelid is pathognomic for the disease. Mechanical rubbing of upper eyelid conjunctiva against the lower lid margin and lashes leads to papillary conjunctivitis of the upper tarsal conjunctiva. The constant irritation makes the orbicularis undergo a neuronal spasm, thus making the eyelid more prone to spontaneous eversion as orbicularis remains in constant state of subclinical spasm. This hypothesized series of events was explained by Chandravanshi et al. And Odat and Hina. Eye ointment lacrygel 1% reduces this chronic irritation and relieves the subclinical neuronal spasm. The antibiotic eye drop like tobramycin prevents the secondary bacterial infection, and the nighttime lid taping prevents exposure of the tarsal conjunctiva and maintains a normal anatomical position of the eyelid. The natural resolution of imbrication could best possibly be explained by the thicker lipid layer and more mucin content of the tear film in infants as compared to an adult. To conclude, although congenital eyelid imbrication syndrome runs a benign course and is self-limiting, but ruling out any associated systemic conditions like Down syndrome is important, and so is the role of an ophthalmologist to keep the child under constant follow-up to detect any possible complications like corneal epithelial defects and corneal ulcer at the earliest and treat them appropriately to prevent any visual comorbidities in the child. The parental counseling is important to relieve the apprehensive parents. Thank you.
Straight away going to the judges for any discussion. Dr. Seema, Dr. Urmil, Dr. Akshay.
A very rare case. literature reports the incidence also very rare. And can you think of any surgical procedure that can lead to a similar condition iatrogenically also?
Ma'am, in congenital conditions, it is very rare, but a forceps delivery might injure the tarsus and can lead to floppy eyelids. But yes, in acquired cases, any tarsal corrective procedures on the upper eyelid may lead to floppy iris in acquired cases.
Lateral tarsal strip is reported to be one case surgery that can sometimes lead to it. And is it always associated with floppy eyelid syndrome?
No, ma'am.
Dr. Sunita, please stop sharing your presentation. Any more questions from the judges?
Yeah, Dr. Sunita, very well managed case. Suppose your patient did not respond to the conservative, what possibly you could have done as a second line treatment? Next treatment.
As a second line treatment, lid shortening procedures can be done, ma'am, to tighten the canthal tendons which are lax. That will help the child.
Okay, I think there is a role of a simple tarsorrhaphy also, since it's a kind of born child. Before you want to plan something more definitive, possibly even a tarsorrhaphy.
People have tried temporary tarsorrhaphies with cyanoacrylate glue, ma'am.
Thank you.
Okay, we'll move to the next speaker. Next case will be discussed by Dr. Swati Agarwal. The title is Water Balloon in the Medial Orbit. Dr. Swati, please start your slideshow and you can start your presentation.
Hello, am I audible now?
Yes, you're audible. Start your slideshow. Great.
Good afternoon to respected judges and one and all present here. I'm a trained and practicing oculoplastic surgeon, and I recently came across a very interesting case I would love to share. And I'm thankful for DAWS to include this session in their program schedule. So the title is Water Balloon in the Medial Orbit. This is a case report of a 35-year-old female who came to our OPD with complaints of progressively increasing swelling at the inner corner of the right eye since birth. She gave no history suggestive of any increased lacrimation, discharge, any redness, or any previous history of trauma or any ocular or lacrimal surgery. On detailed ophthalmic assessment, her vision in both eyes was 6/9. The pupils were normal in size and reacting. The anterior and the posterior segment revealed no abnormality. The extraocular motility was full and free. On inspection and palpation of the mass, there was a medial canthal cystic mass which was extending well above the medial canthal tendon. The regurgitation on pressure of the lacrimal sac was negative. On syringing, it was patent from the lower puncta. However, while syringing the upper puncta, clear fluid regurgitated from the same orifice. A probing was done and a distal soft stop was confirmed on it. We ordered a CT scan orbit in which we can see a clear, well-defined cystic mass in the medial orbit just as adjacent to the lacrimal sac, but the nasolacrimal duct looks normal. So differential diagnosis of a dacryocystocele or a canalicular cyst or a canalicular diverticuli was made. We discussed with the patient and the patient went ahead with right eye medial orbitotomy with exploration of the mass under general anesthesia. So vertical incision was made at the summit of the mass and the wound was retracted by cat's paw and we saw a dense cystic mass. So on further dissection and achieving hemostasis, the dense cystic mass was seen. The contents were aspirated so as to debulk the size of the mass. And on attempting the removal of the mass, the debulked mass, we saw that the stump is connected to the canaliculi. The lacrimal sac and the nasolacrimal duct were normal. So we marsupialized it. We removed the mass. We sent it for histopathological examination and placed a mini Monoka stent and attempted a distal canalicular repair. Post-operatively, the patient remained free from epiphora and on histopathological examination of the excised mass, the cyst was lined with non-keratinized squamous epithelium consistent with the canalicular epithelium. So a diagnosis of canalicular diverticuli was confirmed. So these are the pre and the post-operative pictures of the patient. The patient and the family members are very happy of the cosmetically outcome. And this is at 1.5 years of follow-up. There is no recurrence of the mass and the patient remains asymptomatic. So a thorough evaluation of the medial canthal masses and its significance in relation to the medial canthal tendon cannot be overemphasized. So definitely one should be very much aware of the importance of the applied anatomy and the subsequent management. Like the masses below the medial canthal tendon are likely to be sac masses or nasal duct masses, whereas superior to the medial canthal tendon could be dermoids, could be canalicular masses. Similarly, one should also have a little experience of the radiological findings so that they know how to manage, and also surgically correlated. Like on exploration, if you see that it's a canalicular cyst, you have to attempt a complete excision. Whereas if it is a canalicular diverticuli, marsupialization would be the treatment of choice. So a differential diagnosis of these lacrimal masses should be kept in mind while dealing with them. Thank you for patient listening.
Thank you for that presentation. I'll hand over it to the judges.
Yeah, I think that was a very well documented and presented case. Do you think this would be classified as a canaliculops or a canaliculocele?
Could be, Dr. Akshay, it could be a canaliculops also. But when we saw that the stump is actually attached to the canalicular diverticuli, and this was a 35-year-old female, right? If she would have come at a quite younger age, then yes, it could have been. It could have been a adhesion which would have developed subsequently. So we don't know about that.
Any more questions? If there are no questions, then we'll have Dr. Harshita. No questions. So Dr. Harshita, please start sharing your presentation. Dr. Harshita has lost connection.
No, I can't share my video. It seems the host has stopped it.
Can we have Dr. Harshita allowed to share her screen?
Thank you.
We can see you. We can see your screen. Please start your presentation.
Give me a minute. Good afternoon, everybody. I'm Dr. Harshita Sharma from HV Desai Eye Hospital. We had a 3-year-old girl whose parents noticed squinting of eyes from 15 days and a white reflex in the left eye for 5 days. There was no prior family history of any eye removal, unexplained blindness, and eye cancers in the family. The child is a first issue of a non-consanguineous marriage with younger sibling with no frank visual complaints. On examination, vision in the right eye was 6/9 equivalent of Snellen's, and the left eye did not give conclusive perception of light, but there was resistance to occlusion to the right eye. Anterior segment in the left eye showed detached retina and the right eye was normal. B-scan of the left eye showed diffuse echogenicity in the vitreous cavity without any significant hyperreflectivity. Examination under anesthesia was done the next day, where the left eye showed raised intraocular pressure, conjunctival congestion, neovascularization of iris, and ectropion uvea. The posterior segment of the left eye showed total bullous retinal detachment with thickened yellow-white areas under the detached retina and dilated retinal vessels. Though there was no demarcated mass which was visualized, there were few lesions with overlying vessels which seemed suspicious of subretinal seeds. So after detailed examination, the two possibilities that we were considering was advanced stage retinoblastoma and Coats disease. We went ahead to do a CT scan to gain further information. We were expecting something like this, which has an intraocular mass and calcification, but instead our patient scan shows iso and hypodense diffuse shadows in the vitreous cavity with a single speck of calcification in all the sections. So our dilemma was between advanced retinoblastoma and Coats disease. Considering the nature of closed differential natural evolution and the point that it was a non-seeing eye, the high stakes of urgency of management and decision making was thoroughly discussed with the parents. We went ahead and did enucleation with myoconjunctival technique, ensuring minimal manipulation and a large optic nerve stump, followed by a placement of appropriate size implant with 3-layer wound closure. Sorry, the slide is stuck. Yeah. So on gross examination of the pupillo-optic callet of the enucleated eye showed a gray-white tumor under a detached retina in the vitreous cavity, and the microscopy showed solid sheets of malignant round cells. The pathologist also looked for anterior chamber, uveal scleral, extrascleral involvement, and also involvement of optic nerve head and transected ends of the optic nerve, but there were none. So unilateral presentation with total bullous retinal RD and a single focus of calcification, our diagnosis was confirmed as left eye retinoblastoma, group E with clinical risk factors. Child underwent systemic metastatic evaluation in the form of bone marrow biopsy and cerebrospinal fluid evaluation, which was negative, making her a stage 1. Child currently is alive, healthy, and awaiting cosmetic ocular prosthesis. So to summarize, advanced unilateral retinoblastoma and Coats disease are known to be challenging to differentiate between. Studies have shown calcification on B scan and CT scan is neither pathognomic nor absence is an exclusion of diagnosis of retinoblastoma. In cases of therapeutic dilemma like ours, enucleation is the safest management to prevent mortality with the added benefit of histopathological diagnosis. So this is an evidence-based table which differentiates between advanced retinoblastoma and Coats disease to help in cases such as ours. These are a few of the references which were referred. Thank you all for patient listening.
Thank you, Dr. Harshita. That was a very precise presentation. Over to the judges.
Which implant did you prefer to use, Harshita?
PMMA implant, ma'am.
And you did not give adjuvant chemotherapy to this patient, right?
No, no, sir. The bone marrow and CSF was negative, and there were no histopathological risk factors which were found. So, child is currently under OPD evaluation only.
All right. Very well presented.
What would be the follow-up regime that you would consider?
So for 6 weeks, we are currently following the child 6 weeks, ma'am. Then 3 months till 1 year of age, and then 6 months till 6 years of age.
Very well presented, Dr. Harshita. Just one question. Since the main diagnostic dilemma in your case was the kind of minimal calcification or absence, what are the variants of retinoblastoma which you know which might not present, might not have calcification, can present without calcification?
A diffuse type of retinoblastoma may not have that much of calcification.
So your patient probably fits into it, a diffuse infiltrating RV, which can present without any evident calcification.
Yes, ma'am.
Thank you.
Thank you.
Now we'll have Dr. Sahil Agarwal to present, please. Dr. Sahil Agarwal has to moderate a session from 3 p.m. onwards. So Dr. Sahil Agarwal will present a panorama of orbital foreign bodies, trivial to substantial. Dr. Sahil, please start sharing.
Just a second. देखिए फाइल लॉगिंग to Zoom, you have to select the use of computer audio, then it will be relevant. You can log.
Is my screen visible, Prakyat?
Yeah, we can see your screen. You can start your slide share. Please go
A
ahead.
very good afternoon to all the chairpersons and everyone present. I will be discussing a panorama of orbital foreign bodies, right from the trivial ones to those that were substantial. My slides are stuck. I have no financial interest to disclose. The objective being to report the characteristics of a large series of foreign bodies in terms of diagnostic and treatment of different categories, according to their material and location in the orbit. It was a single center retrospective study done at a tertiary hospital. All cases with retained orbital foreign bodies with documented imaging who underwent surgical removal were included. The number was 20. The following data was documented for all the patients: the clinical demographic profile, material, size and location of the foreign body, clinical features and imaging findings, time from orbital trauma to complete removal, surgical approach, and post-operative status. These are a few of the trivial foreign bodies that we found, like the newspaper foreign body. Amongst the substantial ones, we found that the clutch of a bike handle, the rifle's bullet, a large wooden foreign body measuring around 8 centimeter in size, and the measuring weight of a balance used by vegetable vendors. This was a 14-year-old male with a history of gunshot injury who presented after 2 days on imaging revealing a retained intraorbital foreign body in the middle aspect of the left orbit. The patient was taken under GA and the bullet was removed. Hemostasis was very well achieved and the wound was closed in layers using a 6-0 vicryl and a 6-0 silk. This was a 2.8 centimeter long bullet taken out. The patient in the post-operative period was doing fine. However, vision loss due to choroidinitis, a scleroptera was present. Coming to the results, amongst the various foreign bodies, this was the largest one, a sugarcane foreign body measuring 12.2 centimeter in size. In our series, it was male predominant one with a male to female ratio 19:1, with the mean age group of 24.5 years, mainly including the young and middle-aged population. Most of the traumas had happened at the workplace, accounting to about 35% of the traumas, followed by gunshot injuries, accident, fall, and road traffic accidents. The most common material of foreign body was metallic. Amongst the non-metallic foreign bodies, 3 were wooden, 2 were glass, 1 was paper, and 1 was plastic. The mean size of the foreign body was 3.38 mm. Most of the foreign bodies were located in the extracoronal space. However, the metallic foreign bodies had found their location in the posterior orbital location, while the non-metallic bodies had found their location in the anterior orbital location. The larger foreign bodies were primarily in the larger foreign bodies were primarily located in the posterior orbital location, while the smaller antibodies had their location mainly in the anterior orbit. Coming to the clinical features of all the clinical features are present, the significant association was found between anterior displacement of the eyeball and posterior orbital location, mydriasis and intracornal orbital location of the foreign body, conjunctival hemorrhage, and intracornal location of the foreign body. Also, a significant association was found between anterior displacement of the eyeball and the foreign body being non-metallic, and the non-metallic foreign body with an upper lid ptosis and palpebral edema. The entry wound was mainly present in the eyelid in most of the foreign bodies. However, on the basis of the material of the foreign body, non-metallic foreign bodies were mainly located in the entry wound was mainly located in the lid, while those of the metallic foreign bodies were located in the sclera and the conjunctival fornix. The foreign bodies which were retained in the anterior orbit were mainly had an entry wound in the eyelid, while the posteriorly located foreign bodies had an entry via the sclera. Anterior transpalpebral approach was the most common approach that was helpful in taking out the foreign bodies, which was also useful in some of the posterior easily accessible foreign bodies. However, for 2 of the foreign bodies required a lateral orbitotomy, which were retrobulbar. Coming to our discussion, the male dominance, young age, and working accidents as leading cause of trauma were consistent with other series previously reported. The most common material of the foreign body was metallic. When an intraorbital foreign body is suspected, the first step is to look for the entry wound And according to our findings, eyelid should be searched first, followed by conjunctival fornix. And if at all the foreign body is located in the posterior orbit, the entry could be on the sclera or cornea, and a double perforation of the ocular globe may be present. Foreign bodies of the anterior orbit are mainly associated with local inflammatory signs, while those of the posterior orbit, along with these inflammatory signs, are as well as associated with functional deficits like mydriasis and displacement of the globe. The same tendency was observed in extracorneal compared to intracorneal foreign bodies as well. In our series, non-metallic foreign bodies were mostly wooden were more aggressive than metallic foreign bodies, leading to palpebral edema, upper litosis, and displacement of the eyeball. Metallic foreign bodies reportedly tend to large in the posterior orbit due to high momentum, while the non-metallic foreign bodies with lesser momentum are prone to stop in the anterior orbit. There was also significant association about the size, the small size foreign bodies in the anterior orbit and the larger foreign bodies in the posterior orbit. CT is the most commonly recommended imaging method. The therapeutic strategy is influenced by the material and location of foreign bodies and by the clinical features of the patient, especially the presence of infection. The indications of surgical removal being sharp foreign body, organic material, foreign body toxicity, any mechanical restrictions like ocular motility, neurological deficits, orbital infections, and pain. In contrast, surgical removal is not required for blunt inorganic, asymptomatic, or deeply located foreign bodies. Foreign bodies located in the anterior orbit are usually removed easily using an anterior approach, which can also be used for easily accessible posterior foreign bodies. However, deeply situated posterior foreign bodies should be extracted using a lateral approach. So the takeaway points: intraorbital foreign body management must be tailored according to their type and location, as well as to the clinical characteristics of the patient. The clinical features depend on the material and location of the intraorbital foreign body. Intraorbital foreign body location has a significant association with type and size of the foreign body. And CT is reported to be the best method for detecting a metallic foreign body. These were my references. Thank you.
Thank you so much, Dr. Sahil. If there are any questions.
Sahil, did duration of present from injury to presentation have any correlation with?
So it didn't had much of a correlation significantly, because for us, right from the time the child presented was 3 hours to the last to the latest available was 2 years. So that didn't have more of a significance to us, to our study.
Okay.
But definitely the size and the type of the foreign body determined the clinical features and accordingly prognosis after that.
So great. Dr. Sahil is, thank you for your presentation and taking the question. Now we'll have Dr. Salil Kumar Mandal. He'll present his case, multi-stage correction of blepharophimosis syndrome in a surgical challenge. Sir, please.
Hello, I'm audible?
Yes, sir, you are audible. Please
Actually,
start.
this topic is submitted under the heading of video presentation. I have prepared for that. But this is basically in a case presentation like. So I want to share my video presentation with the screen share, okay?
Sure, you can go ahead with that.
Everything recorded, audio and video, and the sound system.
Okay, great. Thank you. So you can start.
Multi-stage correction of blepharophimosis syndrome is a surgical challenge. Blepharophimosis syndrome consisting of telecanthus, epicanthus, horizontal lead vision shortening, ptosis, lateral entropion of lower limb. Here is 14 years old girl suffering from blepharophimosis syndrome. This is a oculoplastic genital loss. Stage 1 correction of telecanthus and epicanthus surgery. The Masterpiece rectangular flap operation chosen for serious telecanthus. So this double jet plasty is the best procedure for the correction of telecanthus and epicanthus. Here is a rectangular flap is formed and which is repaired in a triangular flap fashion. Thus, vertical stretching of the tissue is possible where the telecanthus and epicanthus is corrected. Epicanthus is marked and skin traction made towards the bridge of the nose. The site of desired medial canthus and the actual site of medial canthus are joined by a horizontal line from the midpoint of the line. Lines at 60-degree angles are made above and below and are slanted towards the eye. These lines are slightly longer than the line joining the desired and actual medial canthus line. Here the similar procedure done in both sides. Expose the insertion site of the medial palpebral ligament of both sides and the anterior lacrimal crest. 3.5 gauge manual orthopedic drill is used to place a hole in the frontal process of the magna at the anterior lacrimal crest. Here the drill speed slowed down when it bore the outer temple of the bone, otherwise it may cause an injury to the opposite eye. Metallic guard often helps in protection opposite eye at the end of drilling. Outer temple puncture of the bone. Here the 1-0 Prolene suture threaded into a right fascia needle and passed through the bony tunnel to bring the two medial palpebral ligaments as close as possible. Right fascia needle is used for entangled 1-0 Prolene suture through the intranasal bony tunnel for the close approximation of the two medial palpebral ligaments. Here the medial palpebral ligaments is just tied. Prolene suture tightening with a surgical knot may cause close approximation of the two medial palpebral ligaments through the bony tunnel, thus daily canthus is corrected. Here the 6 to 7 knots are given to prevent the slipping of ligature of the Prolene suture. Prolene suture needs at least 5 to 6 surgical knots, otherwise it can slip. Here the horizontal limb of the mustard, this rectangular flap is marked now. It marked towards the nose. The flap is made after the drilling completed, otherwise the chance of flap disruption may occur. Mustard, this rectangular flap repair causes medial displacement of the both medial canthus, thus correction of epicanthus and telecanthus slightly. Here the rectangular flap is repaired with a triangular fashion and make a double jet plastic, and thus it helps for stretching of the tissue at the vertical line. Here the angle is first secured at the triangular fashion. The procedure is same, applied to the both sides of the eye. Here the both side lower lid lateral ectropion is corrected by transposition of flap. Here is a transposition flap on the opposite side. You see at incision date. The triangular flap is taken out from the upper lid and it rotated and transposed to the lower lid lateral part of the lower lid. So the base out triangular flap is repaired at the thus ectropion is corrected. Here the telecanthus and epicanthus is corrected in the first stage of operation. After 6 months, we did a second stage operation that consisted of canthoplasty, tarsopontalis leg. After 6 months of first setting of surgery, procedure is repeated on both sides. Then the repaired cut margin of upper. In this procedure, we achieving at least 30 millimeter of slit fissure length. CBA corrected by dorsofrontal sling with silicone rod. The procedure is done in the both sides. Here is pentagon is made and the silicone rod is following the path of pentagon. Apex of the pentagon is tightening with silicone rod, thus correction of the toothed lid.
Will this video be concluding soon because the time is up?
With the silicone rod for severe doses correction and is closed with the mattress. Cross suture applied after the completion. This is the first post-month appearance of the patient.
Okay.
Multi-stage correction of blepharophimosis syndrome is a surgical challenge.
Okay, thank you. I think message well received in that video. If there are any quick comments or one-line questions from the judges, any clarifications that they want. Sir, you can stop sharing your screen and Dr. Namita can start sharing her screen.
Okay, I'm just trying.
I just, in terms of the long-term follow-up, without any transnasal wiring, do you feel that the medial canthoplasty stays on for a longer time?
It is a long-term follow-up because after it is follow-up for more than a year, and even it is after full correction, it is again a little bit regresses, little bit. It's not 100% correct because it's influenced by FOXL2 gene that may cause a try paraoperatively 100% corrected, but up to that, after 6 months, 1 year, it then again comes to a 20% correction. Hello?
Yes,
Am I
sir.
audible?
Yeah, you were
Yes,
audible,
sir.
sir. Stop sharing your screen.
Is the problem in the Zoom due to
So instead of the pentagon, have you ever tried the Crawford technique of double triangle also?
No, I am only doing a most simplest procedure, Fox pentagon procedure. There's a lots of surgical technique is there, the 4-5 surgery in a single setting. That is why I'm not to do any harvesting any fasciculata from anywhere. So nowadays in ptosis surgery, silicone rod is a choice. That is why I am using this silicone rod, not any auricular cartilage. I mean harvesting cartilage.
Okay, Dr. Namita, you can start sharing your screen and start your presentation. Can we have the timer?
Is my slide visible?
Yes, and you are audible. Please go ahead.
Okay. Good afternoon, everyone. I am presenting a clinical case of 33 years old male who presented to us with the chief complaints of the watering and inability to close his right eye for the last 4 months. He had history of road taffy accident 4 months back, and 2 months back he underwent medial canthus repair with jetplasty and suture suspension. Coming to the local examination, there is a right eye showing that the medial canthal dystropia with the secretitial ectropion, and the lag ophthalmos is around 8 mm and base is good. There is also a scar mark visible in the upper eyebrow area and in the upper eyelid. This upper lid notching present medially. The other anterior examination, the visual is a 6/6 and the fundus is normal in the both eyes. This is the CT scan of the patient, which shows there is no fracture of any nasal and lacrimal bone. NLD appears normal. Left nasal mucosa little bit appear thickened. So coming to the diagnosis, there is a right eye cicatricial ectropion lower lid with medial canthal dystopia, with telecanthus with bicanalicular block was made because on syringing there was a proximal 2 mm bicanalicular block. So the patient for that time not concerned for the patient was concerned for the watering. So we have given the option of Botox injection to lacrimal gland and conjunctival DCR with failure rate discussed with patient. So he wanted to underwent for the correction of that medial canthal dystopia. So we went ahead with the medial canthal reconstruction surgery. This is the video showing that medial canthal reconstruction. The Z-plasty marking in the medial canthal area is made. The lower limb of the Z was incorporated into the anterior crush of the medial canthal tendon. The escape incision was given using the 50 number blade. The subcutaneous dissection was done. The perioperatively, the bicanalicular block was confirmed again, proximal 2 mm. The hemostasis was achieved by using the bipolar cautery. Dissecting the subcutaneous tissue and raising the flap, we expose the frontal bone superiorly. With the help of periosteum elevator, we attack the soft tissue and the periorbita from here. The titanium mini plate was fashioned and fixated to the bone with the help of two 4 mm mini screw. It was fixated tightly over the bone. It should be ensured that it should not be loose. And then the 40 proline suture is passed with the hole present in the titanium mini plate. And then it's a cantilever to the medial canthus tissue. And then after anchoring the medial canthal tendon with proline sutures, the flaps we also release the lower lid scar tissue to transpose the flaps with each other, and then the flap sutured after transposing with 60 Vicryl and 60 proline sutures in 2 layers. So the post-operatively, the patient has a very good outcome and the medial canthal dystopia got corrected. And we have achieved the medial canthal in distance within the 2 mm. And the ectropion also got corrected. Cicatricial ectropion also got corrected. We also had the similar, these are the other images of the other patients who underwent the similar procedure. And we have achieved the correction within 2 mm. So this is a patient having the congenital medial canthal dystopia associated with also the cleft lip and parrot that he was operated for this earlier. And he also underwent this procedure and he also achieved a good functional and cosmetic outcome. Medial canthal dystrophy is the displacement of the medial canthus, and it usually happens because of the medial canthal tendon rupture during the trauma following the medial canthal resection in the cases of the cancer, and in also cases of the congenital malposition in the various syndromes. So coming to the anatomy of the medial canthal tendon, it's it's a complex anatomy. It involves the integrated of the various P-tarsal, P-septor orbicularis, septum orbitare, medial hind of Lockhart ligaments, medial horn of levator aponeurosis. So because of this complex medial canthus anatomy and the associated features like lag of thalmos, ptosis, ectropion, and NLV obstruction, the management of medial canthus dystrophy is also poses a unique challenges to us. So the conventionally, there's a techniques that has been described as the fixation of medial canthal tendon to periosteum with suture or proline, fixating the medial canthus by passing sutures with holes made in the bone. And another technique is that bony fixation, that is a transnasal wiring and fixation with cantilever titanium mini plate. The bony fixation has a merit
over. Conclude as soon as possible. Please conclude your slides.
I have 8 minutes. Okay.
The session is 10 minutes and 2 minutes discussion, which is over.
Transnasal wiring is useful for medial canthal dystrophy associated with the nasoorbital fractures. It is useful for the treatment of moderate to severe congenital telecanthus. However, the demerit is that it causes injury to the ocular and periocular of the contralateral sides. So these are some papers that have described the management of the delayed traumatic medial canthus telecanthal deformity using this technique, and they have achieved a successful outcome. So I have to conclude that eyelid is like a hammock, which is supported by the two canthi, and these two canthi behave like a pillar. And when pillar need to be fixed with plate if it's not in the position. So take home message is that any patient of the medial canthal dystrophy with history of trauma should undergo CT orbit, lacrimal system injury to be ruled out, and its bony fixation is must to restore the anatomy and correct telecanthus in the long term. And the patient associated with ptosis in ophthalmic socket should be consulted regarding need for multiple stages of surgery. Thank you.
Thank you so much. I thank all the judges for attending this session and judging it so meticulously, listening to every speaker and asking those interesting questions. Thank you so much, everyone. Please, Dr. Akshay, Dr. Urmil, and Dr. Seema, please mail your mark sheets to the secretary DOS email address. Thank you. Thank you all. I think we are already 3 minutes past our time and we are on a tight schedule. So I'll take your leave. Thank you so much once again.
Thank you.
Thank you.
Mr. Prakyat, we had 10 speakers. One was missing now out of 11 talks.
Yes, ma'am.
One was not.
Yes. Dr. Sonali, the fourth speaker, was missing.
Yeah, thank you.
You're allowed.
Hello. Good afternoon, everyone. I don't think we have all our speakers joined yet. Welcome, Dr. Arvind. We'll just wait a couple of minutes for the rest of the speakers to join. We have Dr.
Mr. Prakyat, can I ask you one question?
Yeah.
The mark sheet that I had already mailed, that has already been marked by, I think, my other judges. So I do need to mark it adjacent to it or a new mark sheet?
Ma'am, you can mark it adjacent to it, or you can download the copy that was sent to you in the email and write your
Okay.
marks on it and send it back.
Okay.
And do it on your computer on, say, Adobe, or maybe in your phone as a photograph, and you can edit it.
Okay. Thank you.
Hi, Prakyat. Actually, I have a talk in Hall G also. So possibly, can you do my talk first in this session?
We'll begin with you. There's no problem, sir.
Okay, ready.
Just wait for the others to join.
Sure.
We can wait for 3 more minutes. We have Dr. Pratham, Dr. Anita, Dr. Himani, and yourself. So 4 of the speakers are already here. Still missing a couple of them. And if few of our judges have other commitments and they cannot make it to the session, then we'll have these sessions recorded so that they can judge it afterwards. So there's no worries about that.
That's really great. It's a good thing.
Okay, we'll take 2 more minutes and then I think we'll start. So we'll start with you, sir. Please be ready with your presentation.
Yeah, I'm ready. It's there on my screen.
Can anyone from the back end confirm that we are starting the recording for this session? You can stop the timer for now and start recording the session. Okay, so I have a confirmation that the session is being recorded and we can start now. So you can start your presentation now.
Yeah.
I'll mute myself.
Good afternoon, everyone. I will be speaking on effectiveness of using dexmedetomidine as an adjunct to local anesthesia in peribulbar block in the ocular surgeries. So on the advent of the small self-sealing cataract incision has allowed the anesthetic practice for many ophthalmic surgeons to use of the topical and the local techniques like the peribulbar, retrobulbar, and subtenon blocks. And the commonly used agents are 2% lignocaine, 0.5% bupivacaine, and mepivacaine and ropivacaine. And the adjuncts used are the hyaluronidase, bicarbonate, epinephrine, muscle relaxants, opiates, and clonidine. Now, this dexmedetomidine, a centrally acting alpha-2 adrenergic agonist, as an adjunct along with the peribulbar block, has been proposed to shorten the onset time. It prolongs the block duration, and it significantly decreases the intraocular pressure with minimal side effects. So we did a study to establishment of effect of adding dexmedetomidine as an adjunct to local anesthetics in peribulbar block in different ocular surgeries. So it was a double-blind, randomized controlled clinical trial. Inclusion criteria: patients undergoing cataract, vitreoretinal surgeries, squint surgery, and glaucoma surgery under local anesthesia. Exclusion criteria: structural or functional disease of the cardiac problems, renal impairment, hypersensitivity to any drug, patient with mental illness, and history of sleep apnea. So in the group A, there were 80 patients, and in the group B also, there were 80 patients. So they received, along with the 3 ml lignocaine, 2 ml bupropion, and 150 international unit of hyaluronidase, they received 0.25 ml of normal saline. And in the group B, they received 0.25 microgram of dexmedetomidine. And detailed history was taken. BP, heart rate, ECG, and oxygen saturation were all recorded. IOP was recorded using a rebound Perkins tonometer, and drug sensitivity test was also done. So the parameters assessed were the onset of globe akinesia, onset from the time of introduction of the needle to complete absence of all ocular movement, and the duration of block, recording the heart rate, mean arterial pressure, oxygen saturation at 5-minute intervals, and IOP at 1, 5, and 10 minutes post the peribulbar block. And the sedation levels were assessed by the Ramsay sedation level marker every 10 minutes during surgery. So response: awake and anxious, agitated or restless. The level 1 Ramsay was given, and asleep, no response to light, glabellar tap, or loud noise. Level 6 on the Ramsay grading was given. And also the patient satisfaction was assessed using the numeric pain distress scale from 0 to 10 scale. 0 means no pain, 5 moderate pain, and 10 unbearable pain. And the surgeon satisfaction score was also at the Likert rating scale of 1 to 5, 1 very unsatisfied, and to 5 very satisfied. So we come to the results now. As regards the time of onset of globe akinesia, it was significantly shorter in group B of using dexmedetomidine as compared to group A, with a significant p-value of less than 0.05. So here we come. The onset was 3.78 minutes in the group B, whereas it takes longer time in the group A. And also it lasts longer with a very significant p-value, 317 minutes. The pain score was also significantly lower in group B with a significant p-value. Mean arterial pressure and the heart rate, it was significantly lesser in group B than group A at 30, 35, 40 and 45 minutes after injection of LA. And also the IOP decreased throughout the first 10 minutes after the administration of the local anesthesia in the group B. In the first group, it rises to 2 millimeter of Hg average after 10 minutes of giving peribulbar block, whereas it decreased to 4 millimeter of Hg in the group B. And regarding the conscious level, there was highly significant variation between the two groups with a significant p-value. So the sedation score was high as expected in the group B as compared to group A. So in discussion, dexmedetomidine as an adjunct reduces the onset of globe akinesia and increases the duration of block. It is safer as an alternative to the available adjuncts, but require monitoring to take care of bradycardia and hypotension. The IOP reduction is better with addition of dexmedetomidine to the local anesthesia. And the patients were cooperative after obtaining this drug. And also there was one study by Channa Basappa. They compared 25 microgram as well as 50 microgram. But the patient receiving 50 microgram developed higher sedation. So we preferred only 25 microgram in our study. So in conclusion, dexmed proves to be a good adjunct for the new surgeons who are learning ocular surgeries because they require more time. It maintains excellent akinesia and IOP control with long duration surgeries like the combined phaco with trabeculectomy and long VR procedures. Also good during the squint surgery, simple limbal epithelial transplant and pterygium surgeries. but anesthetist must be present, as sometimes sudden bradycardia was observed in 2% of the cases. Thank you.
That was a good presentation, a good addition to our clinical knowledge, sir. I'm sure that this is going to be explored further.
Yeah.
We'll now have Dr. Neil Shah. Arvind, sir, can you stop sharing your presentation? Dr. Neil Shah, are you there? Yeah, please switch on your video and start sharing your presentation. Can we reset the timer?
Sir, just a minute.
Please reset the timer. Yeah. Are you able to share your presentation?
So no, sir, just a minute. Sir, I could not able to have shared just a
while. Can we help Dr. Shah share his presentation at the back end, please?
Yeah, already explained to Mr. Dr. is having some technical issue.
Okay,
sir, can I,
so in the meanwhile, yeah, sure. You take your time.
Yes.
We'll switch to Dr. Himani's presentation now. Dr. Himani, are you there? If Dr. Himani is not there, then Dr. Pratham.
Yeah,
Dr.
hi.
Pratham Sarkar.
Dr. Prathama.
Yeah. Yeah, sorry. Dr. Prathama, please, can you switch on your video and are you ready with your presentation?
Yeah, I'm ready with my presentation. Shall I start sharing my screen?
Yeah, you can start sharing your screen and after that we can have Dr. Himani.
Okay, so I'll just start with it then. Is my screen visible? Hello? Hello?
Yeah, I can see your screen.
Yeah, shall I start? Hello?
Yes, please.
Yeah, very good afternoon to all. I, Dr. Prathama Sarkar, would like to present my case on hide and seek in lump, case reports on spontaneously migrated glass foreign body in the eyelid. So in 40% of the cases with ocular trauma, an intraocular foreign body is usually found. The response and the reaction to the foreign body depends upon the chemical nature of the retained object. If not explored and removed in time, the foreign body may migrate or cause continuous inflammation and irritation to the tissue and even cause infections. Coming to the case 1, a 40-year-old male presented to the OPD with complaints of feeling of a mobile mass in the left upper lid just below the eyebrow. He had the history of injury by a road traffic accident 11 years back. That was a dashboard injury. He had sustained a linear laceration just below the medial aspect of the eyebrow. The post-laceration repair, he did not have any kind of pain, inflammation, or granulation formation in the surrounding area in the subsequent period. On ocular examination, a scar mark on the left eyebrow on the medial side was there with no visible lump. On palpation of the upper lid, a mobile, well-defined hard mass was felt, which was approximately 7.5 mm below the eyebrow and 6.5 mm lateral to the scar mark. This photograph shows the scar mark and the palpable mass where it was present. On ocular examination, both eyes were within normal limits and extraocular movement were free and full in all the gazes. The investigation showed that the ultrasound showed anoic images and X-ray orbit shows no evidence of any kind of foreign bodies. Under local anesthesia, the patient was taken up and the presumed lid was explored. On dissection, a glistening object was seen lying above the levator palpebral superioris muscle. What was thought as a lump was actually a retained glass particle, which was quadrangular in shape and approximately 7.5 into 8 mm in the size, with no surrounding fibrosis of the tissues. The foreign body was then carefully removed and examined under the microscope. The post-op result, the patient was happy with it. Coming to case 2, a 23-year-old male presented to the OPD with the complaints of feeling something hard just below the right eye for 3 months. He was injured in a road traffic accident 1.5 years back. He had sustained injury just lateral to the lateral canthus of the right eye. Post laceration repair, he did not have any pain. No scar mark was visible to us on examination. However, a small lump was present below the lower lid. On palpation, it was quite mobile and slipping. Well-defined hard mass was felt below it. No apparent posterior extension of the mass could be seen. Here also, no foreign body was evident on the X-ray. So we took up the patient, we applied some lignocaine jelly on the surface, on the skin surface, and after that, a 23 gauge needle was just passed beneath the foreign body in the muscle pain, and after that, the lignocaine was infiltrated. Post that, another 23 gauge needle was passed just opposite to the first needle, and a stab incision was then given with the help of a 15 gauge blade, and the dissection was done and the foreign body was removed. And after that, the sutured part was done. So coming to the discussion part, the glass is an inert inorganic substance which does not elicit any kind of inflammation. Encapsulation of fibrous capsule formation around the glass has not been yet reported. There may be asymptomatic and may remain undetected for months or even years. So how does it migrate? There may be tissue restitution, there may be effect of gravity, the rotation or movement of the retained particle due to the intrinsic property or sharpness. Several cases of foreign body of glass has been reported not only in the eyelid but in the other parts of the body as well. But in all reports, it has been said that the migration can vary from months to years. The rate and the pattern of the movement are not predictable. So how to detect and localize it? The various modalities of choices are plain X-ray, USG, and CT scan. Glass of all types are opaque on the radiograph. The studies have shown that around 46% glass foreign objects can be easily picked up by X-rays. However, in both of our cases, no glass foreign body could be detected even on the X-ray. Other investigations are CT scan that could be done. The MRI as an initial investigation of choice can be used in many cases. The USG-B scan can easily detect foreign bodies in the superficial plane, but not in the deep-seated cases. And this was the case in both of our scenarios. So why to examine the foreign body? Examination of the isolated particle and the high magnification helps in detecting the texture and the type of the glass that is present. This has a medical legal importance in the case of RTA. The modern windshield is generally made up of laminated safety glass, and it provides a high strength and prevents even shattering on high impact. However, the automotive mirrors, vanity mirrors, window glasses, or spectacles are made up of laminated glasses, and hence they splinter and add to the damage due to their sharp edges. Such foreign bodies are likely to migrate as well. So hence identifying the potential source of glass in any kind of injury will help in tailoring the investigation of choice. Moreover, examining the glass particles removed during the primary repair may also help in predicting the chance of migration in some cases. The injured person can be sensitized to the possibility in the future, which can prevent litigations. To conclude, spontaneous migration of periocular foreign bodies can result in surprises for the patient as well as the treating ophthalmologist. High index of suspicion and detailed evaluation of the removed specimen in any case of open injuries can help to sensitize the injured person about such possibilities. Examination of the glass splinters under high power magnification may help in the medical legal implications. Thank you.
Thank you so much, Dr. Prathama. Dr. Himani, we'll move on to your presentation if you are ready.
Hello.
Yeah, can you switch on your video? Yeah. So will you start your presentation? Are you able to share your screen?
No, I'm not able to share it.
I can't hear you very clearly.
I'm not able to share it.
Okay. we'll ask the backend to help you. In the meanwhile, Dr. Anita ma'am, do you have your presentation ready?
Yes, my presentation is ready.
Then we'll first go to your presentation, and
Okay,
in the
done.
meanwhile we'll try solving Dr. Himani.
Okay. Very good evening to
Sharing your
everyone, and very nice to see you here, Dr. Prakhya, after a long time. Yes, I'll start sharing my screen.
Please go ahead.
Is it visible?
Yes, ma'am, it's visible. You can go in the slideshow mode and you can start.
Yes.
Yeah, I can see full screen.
So today I would be presenting my study on the evaluation of macular and GCL thickness changes after the inferior oblique weakening procedures. So I don't have any financial interest to disclose. So as we know, the distance between the fovea and the posterior inferior and interior inferior border of the inferior oblique are 2.5 plus minus 0.8 and 11 plus minus 1 mm. So due to its proximity to the macula, the manipulation of muscle during the surgical procedure can lead to changes in the macula itself. So inferior oblique muscle overaction occur either as a primary condition or it can happen secondary to the other abnormalities, infantile esotropia, esopalses, IDS, etc. So inferior oblique muscle recession surgery is the most effective and long-lasting IO weakening procedure. So there is paucity of literature about this study findings. There were very few studies like Irsan et al. Study which have concluded that IO overaction by itself doesn't lead to any change in the macular thickness. Whereas there were other conflicting results as well, like Turan-Vural study, where they found the statistical significant changes in the macular thickness after the IO recession surgery, while Kasim and Sabri study didn't find any significant change after the IO myectomy. So what were the existing lacunae? There was a paucity of literature about the effect of inferior oblique weakening surgery on the macula. And those were the studies which have been already done had the conflicting results. So to the best of our knowledge, the effect of IO weakening procedure on the ganglion cell layer thickness has not been studied so far. And there is unavailability of Indian data on this subject. So methods, we took 20 patients with concomitant squint having inferior oblique overaction from +1 to +4. And this study was done at Sir Gangaram Hospital. And it was a prospective observational study. So different type of IO weakening procedures were performed depending upon the grade of IO overaction. So average macular and ganglion cell layer thickness was measured preoperatively as well as after the surgery day 1, 7 and 30 postoperatively using the Cirrus HD OCT machine. So eyes of the squint patients were further divided into operative and non-operative group depending upon the presence of IO overaction or not in a same patient. So we did the OCT in all these patients and saw the central macular thickness and as well as the ganglion cell layer thickness, which is GCL plus IPL complex. So these are the few pictures of pre and post surgery images. So what were the results? The mean age of the patient was 11 plus minus 4.78 years. IO overaction was most commonly seen in infantile esotropia in 45% of our patients. No association was found between the type of the squint and the laterality of IO overaction. IO overaction was found to be the most commonly seen degree of overaction in our patient, 30%. Mean visual acuity was significantly lower in the operative group as compared to the non-operative. This can be due to the IO overaction. The eye which have the IO overaction may be that is more hypertropic and chances of amblyopia are there. This is just a hypothesis for this. So no significant difference in CMT or GCL thickness was observed preoperatively in the eyes with and without IO overaction. As I have written the p-values, no significant difference in central macular thickness and GCL thickness was observed in the operated eyes as compared to their baseline preoperative values. So here comes the conclusion, like IO overaction is the most common degree of overaction, +2 overaction is the most common. And IO overaction itself does not cause any effect on the CMT and GCL thickness values. And additionally, IO recession surgeries has no effect on CMT or GCL thickness. Thank you for the kind attention. Thank you.
Thank you so much, ma'am. That was a very brief and precise presentation.
Yeah, I wanted to keep it crisp. Yeah.
Thank you so much. That always helps. We'll have Dr. Neil Shah now. Can
Yes,
you
sir.
share your screen now, Dr. Neil?
Yes, sir. Yes, sir. I'm sharing my screen.
Yeah.
So is it able to see?
Yeah.
Okay,
I
sir.
can see it on the full screen. You can
Yes, sir.
start
Okay, sir.
presenting.
Okay. So good afternoon, faculties. I'm going to present today on the topic of study of pattern of ocular trauma in Delhi NCR region. WHO has reported 55 million eye injuries causing restriction of daily activities, of which 1.6 million go blind every day. Welch et al. Have reported the prevalence of ocular trauma to be 2.4% of population in an urban city in India. 11.4% of these are blind. In our daily practice, patient with ocular trauma has variety of presentation, ranging from a small foreign body on the cornea to a ruptured globe, from a patient presenting 6x6 vision to a patient presenting with no perception of light. Now, the second is the slide showing the general classification of ocular trauma, where general ocular trauma is divided into broad categories. One is local, which include mechanical and non-mechanical trauma. Other is association, where the head trauma associated with head injuries, facial injuries, and multiple injuries. The polytrauma patient is included. Other is environmental factor. So in the mechanical, there is a global classification divided into two parts. One is structural classification, other is pathological classification. So the classification which is highlighted in the yellowish area, it shows the present classification according to the Bates Birmingham Eye Trauma Terminology Classification. So the present classification include open globe injury and closed globe injury as a two broad classification. Where in open globe injury, there is a full thickness defect in outermost layer of the eyeball. So corneal scleral coat is degraded in open globe injury, and the closed globe injury, there is a partial thickness injury to the outermost layer of the eyeball. Open globe injury is again divided in two parts, laceration and rupture, where the basic mechanism in the rupture is inside out pressure. So there is an inside out pressure in the most commonly followed by blood trauma. And the laceration, there is outside to inside mechanism of injury, where it divided into three parts. One is penetrating injury, other is perforating injury, and third is intraocular foreign body. In the penetrating injury, there is a single wound of injury, and there is the same only object done by one object. In the perforating injury, there is basically entry of the wound, entry is present, and exit of wound of exit also there. In the closed globe injury, it again divided into two parts. One is contusion and other is lamellar laceration. So in our study, basically we aimed to find out the various pattern of the ocular injuries. It was carried out under following objective. The first was to find out various modes of injury, and the second to study the demographic feature in association with eye trauma. Third one was assess the clinical features of the ocular trauma patient. And the fourth was to evaluate the visual outcome in the patient with ocular trauma. So the study was carried out in the OPD of the ophthalmology department at Santosh Medical College. It was a prospective kind of study when in a period of 1 year duration, the cases of the ocular trauma which brought to our OPD were evaluated, and all patients were taken except there is a critical ill patient which with ocular trauma was excluded from the study. So detailed history was taken, and special emphasis was given on the age of the patient, occupation, timing of the injury, type of the object causing injury, followed by the external examination with the torchlight and the visual acuity by the Snellen chart whenever possible, and the anterior segment examination with slit lamp was done. Intraocular pressure was measured by applanation torometry whenever possible, and the further examination with 90D and indirect ophthalmoscope with scleral depression after full dilatation was done. So in our study, we found that as per chart, there is a majority of the case belonging to the middle age group, and there is a younger age, 10 onwards, 10 to 50 years of the age, contributing the major study group. Second slide shows there is a trauma is more common in the male population, contributing 65%. There is a third slide showing there is a more that there is a foreign body object and the sharp foreign body and the sharp blunt trauma, and as well as a sharp object and vegetative matter are among the major causes of the ocular trauma as per our study. Closed globe injury was the most common type of distribution which we found, then the open globe injury. And the majority of the patient presented to us within 72 hours of the injury. So it contributes to approx 60% of the patient. Then there's another slide shown that there is 70% patient comes with the diminution of the visual signal impairment of the vision with vision less than 6/60. 70% patients contribute to the anterior segment trauma. And there is a place of the majority of the patient contributes to road traffic accident, followed by workplace injury, industrial, as many industrial workers also came to the person work who also came. So in the summary, the mean age of our population was 35 years, with 48% are less than 30 years, 65% population was belonging to from male community, and the 31% presented within 24 hours of the trauma. Out of that, 61% within 3 days and 75% presented after 7 days. 95% patient had a unilateral trauma and 5% had bilateral injuries. 62% patient had suffered from the road traffic accident, while 25% had work-related trauma, while in 30 cases the trauma was at home. So blunt objects, foreign bodies and sharp objects were the top 3 common cause of trauma according to our study, which contributes to 26%, 23%, 55% of the cases respectively. Anterior segment involved in 74% cases, while posterior segment in 4% cases, and combined injury was in 22% of the cases. As per our study, the longer delay in the presentation was significantly associated with complications. Thank you.
Thank you, Dr. Neil Shah. You can stop sharing your screen now. Unfortunately, we don't have judges with us because they are already busy in other sessions. But we have our recorded videos. These sessions are also going on YouTube. So they'll be judged afterwards, and we'll have a presentation of certificates and awards in person, most likely after a month or so in Delhi. So I hope that you can keep with us, and we'll keep you posted about the results.
Sure, sir. Thank you, sir.
Anyone in the back end can tell me if Dr. Himani is going to join back. So should we remain here or we can log out? We don't have any more speakers. If the backend people can contact Dr. Himani and let me know if she's going to join back. We'll be waiting to complete her presentation because since the session is going to be recorded, we don't want that her presentation is.
Yeah, she will join.
Okay. if Dr. Himani joins back, can you ask her to make her presentation? Okay, she's back. Hi. Yeah, we can hear you slightly. It's slightly muffled. I can't really clearly hear you. Can you like bring your device closer to the mic, or maybe have earphones on? Yeah, you can plug in your earphones.
Hello?
Yeah, now I can hear you loud and
Okay,
clear.
now I'm visible, audible.
Yeah, you're audible, you're visible. You can start sharing your screen. We're waiting for your
Okay, share
presentation.
screen.
Yeah,
Asta. Just 1 minute.
sure.
Okay, is it visible now? The screen?
Yes, it is visible. You can start from the beginning and you can present your slides. Yeah,
Okay.
great. Go
Okay.
ahead.
Yeah. So I'm giving a presentation on prevalence of color blindness in the various schools of Haldwani from class 9 to class 12. I'm third year resident of GMC Haldwani, Uttarakhand. I would like to introduce my topic as color vision being an ability to discriminate a light stimulus as a function of its wavelength. The description and appreciation of colors. The description and appreciation of colors depends upon the ability of receptors of the retina, that are the rods and the cones. Rods are mainly responsible for the black and white vision, whereas cones are responsible for the color vision. Color blindness is the commonly used term for deficiency of color vision, that is an inability to perceive differences between the certain colors that are the primary colors. David Brewster introduced the term color blindness, which was formerly known as Daltonism, after John Dalton, who was himself a Deuteronope, who described in detail his own inability to distinguish red. Color blindness is a common explained genetic disorder. However, most of the color blinds remain undetected in general population due to absence of proper screening at an appropriate age. The Ishihara color plate is a test to determine if a patient has color blindness. It was named after Dr. Shinobu Ishihara, who was a doctor in the military. It is the most commonly used screening test for red-green color deficiency. To know about the impact of color blindness on our society, many people are affected by color blindness, but many of them remain undetected due to the lack of proper screening at an early age. Colorblind individuals have difficulty in comprehension because of the increased reaction time they have. They will experience only a few hundred shades of color versus those with normal vision that experience millions of shades. Learning disability, unfit for certain jobs like traffic policemen, defense personnel, electrician, electronic engineers, etc. Artists have require perception of colors, which may lead to lesser efficiency in work as well as may cause accidents. So it is important to look at the prevalence of color blindness in children and identify the problems associated with it at an early age. Keeping the above aspects in mind, the following study was conducted by me to find out the prevalence of color blindness in school children and to make parents and their teachers aware of this disease so that they can modify their teaching methods. The subjects included in this prospective studies consist of 3,345 students from 10 schools of Haldwani. Approval and permission from the schools and the teachers was taken along with the parents of the children. Students were called and clinical examination of both eyes was done. Sex and age of the student was noted. The students were tested for color vision deficiency using the Ishihara test types for color blindness. 38 plate addition. The color vision testing plates were held at a distance of 75 centimeters from the student and tilted at a right angle to the line of vision. The test was done in adequate lighted room resembling the natural daylight. Students were asked to read the numbers seen on the test plates and answers were noted down. The time given for telling the number on a plate was less than 5 seconds. Assessment of the reading of the plate determines the normality or defectiveness of the color vision. It was interpreted as per the instructions given on the booklet provided with Ishihara test types. The data collected was compiled and analyzed to evaluate the prevalence of color blindness gender-wise distribution. So the study that I conducted had a total of 3,345 students from 10 different schools of Haldwani. And what I saw was 1,921 of them were males and the remaining were females, and color blindness was seen in 80 students, of which 74 were males and 6 were females. So this was the class-wise distribution of color blindness, which was done keeping in mind class 9, 10, 11, and 12. So gender-wise distribution, we saw that we found 74 males to be colorblind and 6 females to be colorblind. Conclusion which I drew from this study was males were far ahead in this race of color blindness than females, and there is a need for early school screening at a younger age. Color blindness affects many people, and most of them are unaware of this trait, which is a biggest drawback. Colorblind children have certain learning difficulties only when they appear for some interview that they undergo ophthalmic checkup and come to know that they are suffering from this trait. Specific jobs rely on normal color perception, and hence they get rejected. At that point, the person goes through an emotional turmoil. Even day-to-day life gets affected due to different color perceptions, like comprehending the traffic signals. Color blindness is a congenital disease. Thank you.
Thank you, Dr. Himani. I think yours was the last presentation for this session.
Yeah.
So thank you so much.
Thank you.
And we have recorded your session. It will be judged and the results will be announced later, and a certificate distribution or whatever the award ceremony for the free papers will be conducted in person. And you'll be intimated about that in your email. So keep checking your email for that. Thank you so much.
Thank you. Thank you.
Okay. I think our session is over. We can stop this now.
Okay. Thank you.
ड्राइव का सर हार्दिक वाला मेल आईडी में जो ड्राइव है हमारा
Hello. Hello. Hello.
Hi. Yeah.
Yeah. Hall M is this?
Sorry, yeah, this is Hall M. You can just wait for some time. I think all the other judges and participants will just join in. Let me also rename myself. So we'll start sharp at 4:30.
Okay. Yeah, just a doubt. Which session? This is the session at 3 to 4:30 or 4 to the 4:30 to 6 session for Allied.
This is the 4:30 to 6 o'clock session.
Okay, okay.
This is interesting cases allied ophthalmic sciences.
Okay.
Yeah. You're the last presenter.
Yeah. No, actually, it was written in the agenda 3 to 4:30. That's why I had a doubt.
I think that's a misprint because I just talked to the judges. They'll be joining in a couple of minutes.
Oh, no issues. Thank you.
Excuse me, good evening. I had a doubt.
Yeah, please tell me.
Yeah, can I know my sequence number, like my presentation sequence number?
Sorry, what's your name?
Dr. Ashna.
What's your topic?
A unique case of IC
Can you
syndrome.
change your screen? Yeah, it's third in the sequence, but can you please change your name? It's coming as something else. You can rename yourself. Just go to the settings and or you can just click on your own. You can click on your own dialog box like the small icon that has you in the top or the side of the window. Click on the options and rename. Yeah, it's okay. It's done. They did in the back end, I think.
It's done.
Yeah.
Thank you.
Okay. So we have, I think half of the participants have joined, and I think a couple are still to go, and we already have Dr. Pranita Sahai, one of our judges, who's joined. We're waiting for the other two. So we'll start sharp at 4:30.
Hi, Prakyat.
Hi, ma'am.
Hi.
Ma'am, have you got the email for the marking and the
Kaushik,
Google
yeah,
Sheet?
I got a Google Doc, and the scoring is to be done out of 10. It's not mentioned how many marks out of what is the scoring to be done.
So the scoring is on an overall marks of 10, and there's no subdivision as to what special aspects have you assessed. So you have to give marks on 10, and you have to email to the DOS secretary email.
Okay. Okay.
Good morning, Prakyat. Good afternoon, sorry.
Hi, sir. How are you?
I'm fine. What about you?
I'm good. I think we are almost ready. Almost everyone has joined.
And
We'll
Dr.
start.
Rajat also
Yes,
joining?
he's not joined yet. That's what we're waiting for. We still have 4-5 minutes. So we'll wait for him.
गुंजन शालूजा ओके गुंजन गुप्ती राजा तो मैडम मैं आपको फॉरवर्ड कर
Alert from your disk is almost full.
Dr. Ashna, are you ready with your presentation? Because we don't have the starting 2 speakers and we are on a tight schedule. So we'll start our session now. If Dr. Rajat joins us, then he'll score from then onwards and he can view the recorded session to score the other participants. So Dr. Ashna, are you there?
Yes, sir.
Please keep your presentation ready. We start with your case. We'll just wait a couple of minutes more. I think 2 minutes more we can spare. Otherwise, we'll start. And if other participants join later, we'll take them in the last. Okay, so Ekta has joined. Okay. Dr. Devesh and Dr. Pranita, ma'am, sir, are you ready? Shall we start?
Yes, yes.
Yes, we can start.
Okay. So, Dr. Ashna, you can unmute yourself, switch on your video and start sharing your screen. Can we allow Dr. Ashna to share her screen at the back end? Please note that you have 6 minutes to present and 2 minutes to discuss and answer the question of the judges. So be precise in your answering the question so that you can have a lucid discussion with the judges and they can understand your cases better. If you go on telling details that are not precise, then you might lose on the discussion time. So you can share your screen now.
Okay, sir.
And start your presentation. You can't share it?
Yes, sir, actually.
Okay, so we'll go on to Dr. Prathama. Dr. Prathama, are you ready with your presentations?
Yeah, I'm ready.
Ma'am, you start your presentation. The first case, which is idiopathic familial facial nerve palsy, an interesting case report with review of literature. You can please start your presentation.
Yeah, is my screen visible?
Yes, please go ahead.
Good afternoon, everyone. Today I'll be talking about idiopathic familial facial nerve palsy, an interesting case report with the review of literature. It's not changing. The Bell's palsy or the idiopathic facial paralysis nearly accounts for 60 to 80% of the lower neuronal facial palsies. An incidence of 20 to 30 cases per 1 lakh people per year is reported. The patient most commonly presents with an acute weakness of facial muscles or alteration in taste or both. Though it is self-limited and non-progressive in nature, but minority of patients may have spontaneous remission with residual neurological dysfunction. Having said this, we present the case of a 21-year-old male who presented to the OPD with complaints of diminution of the vision. The patient further gave the history of inability to completely close both the eyes since childhood. There was no history of fever, pain, infection, or trauma associated with the incidents, no history of any intolerance to the loud sound, no history of tearing while chewing, or no difficulty in chewing food. He has no history of any vascular or neurological disorder. On local examination, he had loss of wrinkling of the forehead on looking up. He had inability to blow the air and close the lips together. Other neurological examinations were normal. On ocular examination, he had the inability to exert force against the force exerted by the examiner. He had lag ophthalmos and lid lag. The corneal sensations were intact, and he had good Bell's phenomena in both the eyes. Both eye ocular examination were normal. However, the cornea had mild decreased luster, and the conjunctiva was mildly dry. In the past, he had presented to a local practitioner at the age of 12 years due to sudden onset of peripheral bilateral facial weakness without any pain, and was given oral steroids. Though remission was there, still residual weakness was present. The relevant investigations were carried out. The audiometric testing, the MRI and CSF investigations were normal. All the biochemical and hematological analysis were normal as well. On reviewing the family history, he gave the history of his father, who had suffered a bilateral facial palsy when he was 15 years old. He had consulted a physician, but no elucidation was performed, and he did not receive any kind of treatment. Today, at 56 years of age, he too has inability of blowing the air and closing the lips together. He too has lag ophthalmos and inability to close the eyes against the exerted force by the examiner. The other family members were involved as well: one paternal aunt, one paternal male cousin, and the grandfather. So when we plotted the pedigree chart, as we can see that the grandfather was affected, his own daughter and son was affected. The daughter's son was also affected, and the son's son, that is our index case, was affected. So coming to the discussion part, this case series present a 3-generation family in which 5 individuals were affected with the facial palsy. No triggering cause was identified in any of these patients. This points towards a strong genetic basis for IFP, which still remains to be discovered in the literature as well. Though there are various causes of facial nerve palsies being known, the idiopathic Bell's palsy is one of the commonest cause. As we can see, overall, 71% of the Bell's palsy recover completely, including 61% of the complete palsies and 94% of the partial palsies as presentation. 84% complete or near complete recovery happens. However, there are 29% of residual deficit, which is moderate to severe in 16% of cases. So mode of inheritance, most of the case studies have shown that it is the autosomal mode of inheritance which is most commonly found in these patients. There has been found genetic association as well in DR2 gene, DR4, DRW6, DRW7, as well as decreased levels of CD3 and CD4 T cells has been seen. There are some cases which show that there may be anatomical variation as well. There may be relevant asymmetry in the diameter of the facial canal in the meatal foramen and in the labyrinthine segment. No studies have been performed till date which can explain this anatomical difference in the familial cases. There have been studies which have shown that there is some discrepancy in the development of the embryonic facial canals as well. So how to handle these cases? In chronic cases, it is better that we involve the plastic surgeons or the ENT specialists with us, who can let the patient undergo temporizing measures, static symmetrization, or dynamic reanimation. So from the ophthalmological point of view, the patient can be told some facial exercises, tarsorrhaphy may be done, antibiotic eye drops may be prescribed, or the lubricating gels, nighttime patching and humidifiers may be prescribed to them. To conclude, based on the inheritance pattern, we propose autosomal dominant inheritance with low penetrance in these patients. Though we could not detect any cause for this IFP in this case series, further studies should be done, and a chromosomal microarray analysis of these patients should be done. An integrated approach from the ophthalmologist and ENT specialist may be helpful for the approach and management of these cases. Thank you.
Judges can now take the questions and discuss if they have any questions.
Dr. Pratma, it was an interesting case that you presented. I have a few questions. You said that the patient had a mild dry eye. So were there any objective assessment of the ocular surface that was done?
Yes, ma'am, we had done a Schirmer's test and a non-invasive TBUT. However, both were above 10 millimeter in assessment. So that's why we just gave the patient lubricating eye drops and suggested nighttime patching. And the patient also had a good Bell's phenomena. So there was no dryness as such of the cornea present.
Okay. Any ocular surface staining was done?
Yes, ma'am. Corneal staining was done, but no epithelial defect or no kind of punctate keratopathy was found in both of these patients.
Okay, Dr. Pratima, you have mentioned that the CNS imaging was reported normal, but then again in the literature you mentioned that there are subtle abnormalities noted in the facial nerve path. So did you get it evaluated?
Yes, sir, we did get it evaluated, but in our case, we did not find any kind of abnormalities, neither in the bony structures or in any facial nerve. That's why what we intended is the genetic analysis of the whole family if possible.
Any nerve conduction test that was done for the patient?
Yes, ma'am. In the ENT, the patient was referred and audiometric testing was done. It was also found to be fine.
No, for the facial nerve, was there any nerve conduction test done?
No, ma'am, that was not done. That has to be done. That should be ideally done in this case.
Okay. Dr. Pratima, you also have another presentation, another case, double trouble, quite something, right? Okay, double trouble, quite a struggle. Nice title. You can go ahead with presenting that.
Hello.
If you would like to.
Hello.
Yeah. Do you want
Am
to
I
present
audible?
your other case also right away?
Yeah, I will do that.
Please do.
Hello. Yeah.
Yeah, the title.
Shall I start?
Yeah, please do. Please start sharing your screen.
Yeah. Is it visible? My screen is?
Not yet.
Hello.
No, I can't see your screen.
1 second. Is
Yes,
it now
now I
visible?
can see it. You can start it. You can start your slideshow.
Okay. Good afternoon, everyone. Again, my next presentation's topic is double trouble, quite a struggle. So a 54-year-old female presented to the OPD with the complaints of severe dry eye in the right eye for past 4 to 5 years. She had no history of difficulty in swallowing food, no history of trauma, any ocular surgery or any radiation history. She has no history of any kind of allergy or foreign body. She was a diagnosed case of rheumatoid arthritis for past 11 years and was on tab methotrexate, tab folic acid, tab HCQ 200 mg BD, and tab Visalon 10 mg OD among the other drugs. She was also a diagnosed case of open angle glaucoma, both eyes, for past 7 years and was being treated for the same. She was putting brimonidine tartrate 0.2%, timolol maleate 0.5%, HPMC eye drops, and topical cyclosporin 0.05%. Both on the examination, her lid, there was thickening of the lid. The cornea showed decreased luster and conjunctiva had episcleritis. However, other anterior segment findings were within normal limit. We can see the slit lamp images. There is thickening of lid and along with episcleritis, which has been present. And there is a decrease in the corneal luster as well. The TBUT test was done and it was around 6 seconds. In the fundus photograph, we can see the nasalization of the vessel with a CDR ratio of 0.8:1 and NRR paling. In the other eye also, there was nasalization of vessels along with the CDR ratio of 0.6:1. The OCT RNFL showed the temporal, inferonasal, and temporal quadrants. In the left eye, there was thinning in the superonasal and temporal, inferonasal, and the central quadrant. The visual field analysis showed depressed visual fields in both the eye. The patient was then added autologous serum eye drops for 7 days and sodium hyaluronate 0.1 drops along with the previously used drugs. Her anti-glaucoma drug was changed into a preservative-free brimonidine 0.2% eye drops. She was kept on a regular follow-up for IOP monitoring and any ocular discomfort. Post 1 month of change in the medication, the patient was symptomatically better and more compliant with the medications. As we know that in the rheumatoid arthritis, the eye is most commonly affected organ, with the dry eye being present in 15 to 25% of the cases, mostly diagnosed as secondary Sjogren's syndrome. 40 to 50% of the glaucoma patients also have dry eye, and women are more likely to be affected. The DMRDs may be used in these cases. However, they are found to be much costlier. So in this case, we had a vicious cycle. The patient was a case of rheumatoid arthritis, which caused severe dry eye. She also had glaucoma and was on anti-glaucoma drugs, which also caused severe dry eye. She was a case of rheumatoid arthritis on steroid treatment, which can exacerbate the glaucoma. Again, the addition of anti-glaucoma drugs, which finally also leads to dry eye. So what were the challenges for the patient? The patient was concerned about the decreasing visual prognosis. She was finding it difficulty in compliance because there were too many topical drugs. She was unhappy with the addition of the topical treatment and hence the cost. She was unhappy being called for frequent follow-up in the COVID times and was very much concerned about her cosmesis. The challenges for the doctor in this case was treating the dry eye syndrome, which was very much important for the patient's comfort and long-term health of the surface of the eye. But the glaucoma, which causes the vision loss, is usually treated first. Addressing the glaucoma treatment almost always takes precedence over the treatment of the dry eye. In how to treat the dry eye in these cases, we can add artificial tears, eyelid cleansing and warm compressors, humidifiers, punctal plugs, doxycycline treatment, cyclosporin and liftigrast, or mild steroids can be added to suppress the inflammation. But patients with glaucoma are all the more at the risk of steroid-induced rise in the IOP. So how to modify the treatment in glaucoma patients? We can switch to the preservative-free glaucoma medications, as the BAK which is present in these drugs cause goblet cell loss, conjunctival squamous metaplasia, and ocular surface disorders. But the only problem with bug-free drugs are that they are quite costlier in comparison to the other drugs. Then the second we can do is try the combination of the eye drops to reduce the amount of preservatives instilled on the ocular surface. So how to follow up a rheumatoid arthritis patient in these cases? Proper counseling of the patient is to be done. Ophthalmological assessment and regular interval should be done. Proper fundus examination should be done, because it's said that if the hydroxychloroquine is used for more than 7 years, or the dosage is more than 6.5 milligram per kg per dose with cumulative dose of more than 100 gram, it can lead to quite complications in the fundus as well. Thank you.
Any questions?
Dr. Pratima, you had presented that there was episcleritis at presentation to you.
Yes, sir.
So was it episcleritis, or was it the presentation due to ocular surface irritation due to brimonidine, or dry eye due to the underlying rheumatoid arthritis, or episcleritis due to rheumatoid arthritis?
Sir, more towards it was pointing towards episcleritis due to rheumatoid arthritis, because when we check the rheumatoid factors in this patient, it was quite raised as well. And secondly, obviously, since the patient was using brimonidine eye drop, this can also lead to the dryness and the findings which were present in the patient.
Okay, but the patient was already on steroids and DMARDs, then it is unlikely that it would be episcleritis due to rheumatoid arthritis. Will be more likely will be due to dryness because of the underlying rheumatoid arthritis, and that was compounded due to side effects of brimonidine maybe.
Maybe so. That's why we later changed into a preservative-free drop as well. But since patient was from a lower strata, so she cannot.
The patient improved only with the bag-free preparation, and the symptoms improved. And you had added sodium hyaluronate also.
Sodium hyaluronate also.
Due to the ocular surface problem and not the underlying episcleritis.
Yes, sir.
So one more question, Dr. Pratima, did you avert the lid, and were there any changes in the palpebral conjunctiva?
Ma'am, the palpebral conjunctiva, there was no such changes. However, some hyperplasia could be, not hyperplasia, inflammation was present on palpation as well.
Any follicular reaction or a papillary reaction which can happen secondary to these anti-glaucoma drugs?
Ma'am, no such folliculitis could be seen in this patient when we averted the lid.
Okay, even I agree with the fact that the picture that you showed and the inflammation of the ocular surface mostly looked like a severe dry eye leading to ocular surface inflammation, because without giving steroids and just with lubricants and shifting to bag-free anti-glaucoma drugs, if the patient has improved, it is unlikely that it would be an episcleritis.
Yes, ma'am. Mm-hmm.
Okay. And what other treatment options did you offer for the patient for long-term treatment? Other than
Ma'am,
cyclosporin?
Since the patient was coming from a lower strata, we started her on autologous serum eye drops because she was not able to afford more costlier drugs. Because one of the treatment which we shifted to was a back-free that is the preservative-free eye drop, which was in any ways costlier. So
Was
to handle
was the option of punctal plug or punctal cautery given to the patient?
Ma'am, the punctal cautery was asked to the patient, but the patient denied for it. And punctal plug was not told to her because obviously we do not have that facility over here. So the plugs was not available with us at that time. Okay. So we just asked for the punctal cautery, for which she denied. And apart from that, obviously we started with the autologous serum eye drops for the patient.
Okay, thank you.
Okay. Thank you so much, Dr. Pratima. Now we have Dr. Ekta Singla presenting her case, hyaluronidase allergy mimicking as orbital cellulitis.
Good afternoon, everybody. I'll just share my screen.
Yes, please.
Is my screen visible?
Yes, I can see your screen. You can start your slide share and...
Okay, I'll just start. I'm presenting a case of 47-year-old male who presented 1 week post-right pterygium excision with conjunctival autograph with the chief complaints of swelling around the right eye, which was
visible to everyone. It's not visible to me.
Sorry.
No, it's visible.
Yeah, I can see.
Okay, so maybe there is a problem at my end.
Should I continue?
Yeah, please continue.
Thank you. He presented to us with the chief complaint of swelling around the right eye associated with redness of the overlying skin.
Dr. Devesh has got disconnected. Can we stop the timer for a minute? Let him join back, or else the scoring will get skewed.
Yes, we can stop the timer for now. We can reset it and we can have a presentation. We can wait for
Just wait for a minute or so, and then otherwise you can review it later. You can just wait for a minute.
We can wait for some time because we also have a few missing participants, so we'll have time.
Okay.
In the session. Also, Dr. Ashna, has your issue with the screen sharing been resolved?
Yes, sir.
Okay. Devesh sir has come back. Devesh sir, can you hear us? I think there's still an unstable connection.
Okay. If we are running short of time, we can continue and he can later review it.
Sure, we can go ahead. There's no problem with that. We'll have this video readily available on YouTube as well.
Yes.
Okay.
So Dr. Ekta, you can start from the beginning. We can reset the timer at the back end, please.
Okay, fine.
Yeah, please go ahead.
Okay, thank you. I'm presenting a case of 47-year-old male who presented 1 week post-right eye pterygium excision with conjunctival autograph with the chief complaints of swelling around the same eye associated with redness of the overlying skin for the past 4 days. The swelling was diffuse, progressive, associated with pain and restricted eye movements. However, the patient had no history of fever, cough, cold. Neither he had any history of insect or animal bite on eyelids. There was no history of any dental pain or infection, no history of discharge, and no history of burning micturition. The patient had gone pterygium surgery of the same eye 6 months back from a private hospital. The patient was taken in our institution for the pterygium surgery 15 days back and peribulbar anesthesia was given, but the surgery was deferred due to high intraocular blood pressure, hence the surgery could not be done. The family history was unremarkable. The patient had a history of allergy to diclofenac. He was non-diabetic, non-hypertensive, non-smoker and non-alcoholic. The systemic examination was grossly within the normal limit. On ocular examination, the patient had a diffuse progressive periorbital swelling. The overlying skin was red and warm to touch. The uncorrected visual acuity in the right eye was 6/18 with conjunctival chemosis. However, the conjunctival graph was in place. Whereas in left eye, the uncorrected visual acuity was 6/6 and the patient had pterygium in left eye. Rest of the ocular examination, both the anterior as well as the posterior segment was within normal limit. The extraocular movements was restricted in all the cardinal cases in right eye, whereas in left eye they were free and full. Based on the clinical examination, a provisional diagnosis of right eye orbital cellulitis was made. The routine investigations were sent and the patient was started on IV antibiotics with topical eye drops. In the meanwhile, contrast enhanced CT was done, which showed proptosis of right eye with diffuse soft tissue thickening on enhancement anterior to the right orbital septum, which was suggestive of right eye orbital cellulitis. However, there was no improvement after the 7 days. Keeping in view the possibility of allergic reaction to hyaluronidase was considered, following which a skin patch test was done, which was positive and which are confirmed our diagnosis of hyaluronidase hypersensitivity. Post that, the patient was given 8 mg dexamethasone IV and was started on oral steroid 60 mg. The patient responded well to the steroids with rapid resolution of lid edema, chemosis, and improvement in the extraocular movements within 24 hours. These are the post-steroid pictures of the patient 2 weeks and 4 weeks post-steroid. Coming on to the discussion part, orbital inflammation following ocular surgery can be both infective as well as allergic in nature. The allergic reaction can be due to either lignocaine, bupivacaine, or hyaluronidase. The incidence of hyaluronidase is estimated to be 1 in every 2,000 cases. It can present both as early, that is type 1 hypersensitivity, or delayed, that is type 4 hypersensitivity reaction. The timing of the presentation can vary from immediate, that is preoperative to intraoperative, to early postoperative, to intermediate or late postoperative period within weeks. The hyaluronidase sensitivity can mimic retrovalvular hemorrhage initially and later as orbital cellulitis. Basically, it is a diagnosis of exclusion in the absence of pain, any septic foci of infection, fever, and altered blood count. The intradermal test can confirm the diagnosis. The bovine-derived preparation of hyaluronidase generally accounts for the allergic component. The treatment includes the intravenous or oral steroids, antihistaminics, and prompt responses seen with steroids. A case series showing hyaluronidase allergy cases mimicking orbital cellulitis showed that the symptom period initially appeared from as early as to the injection site to as late as 6 days after the surgery and responded prompt to the oral steroids as well as antihistaminics. Going back to the literature, many cases have been reported of the hyaluronidase allergy in different case series as well as single cases. So the take-home message from our case is that hyaluronidase sensitivity is a diagnosis of exclusion after ruling out any infective loci. Skin patch test may aid in the diagnosis. Such patients should be informed about their allergy and precautions need to be taken in the future to prevent any further complications. Thank you.
Any questions from the judges?
Yeah, Dr. Ekta, nicely presented case. Okay, I have a few questions. First of all, when you confirm the diagnosis of hyaluronidase allergy with the skin test, you started the patient on systemic steroids, right?
Yes, no ma'am. Steroids were started post the diagnosis.
Yes, post the diagnosis of hyaluronidase allergy, you started the patient on systemic.
Yes, ma'am.
Any other drug that you gave to the patient?
No, ma'am. He was just given IV antibiotics prior to that.
So did you not consider giving him oral anti-allergics and topical steroids as well, as the eye and ocular surface was also very inflamed as you showed in the pictures?
Ma'am, he was on eye drops of fluoromethalone and tablet fexofenadine was started.
Okay, I think
I had mentioned
that it was not mentioned there.
No, it was mentioned, ma'am. I hope my slides are visible.
Yes. So you started fluoromethalone when you were suspecting orbital cellulitis.
No, ma'am. Actually, the patient was taking fluoromethalone because he had undergone pterygium excision. So he was continuing that fluoromethalone from that only.
Okay.
And fexofenadine we did add, just keeping in mind the allergic thing.
Okay. Okay. Thank you.
Dr. Ekta, if suppose you don't have imaging facility available at your center, then how will you differentiate between an infectious cause and an allergic cause for orbital cellulitis?
So we had sent routine investigations also, and the patient was on IV antibiotics for 7 to 10 days, but there was no response. So since had it been an infection, there would have been some response to the treatment.
No, I mean to ask that why did you think in terms of infectious cause for orbital cellulitis, and why didn't you consider other causes of proptosis in the post-operative period, such as delayed orbital hemorrhage? And were there any features that suggested that, okay, it's more likely to be an infectious cause for orbital cellulitis?
So the patient only had chemosis and restricted eye movements.
So with only chemosis and restricted eye movements, I think it can also be a retroorbital hemorrhage that could have occurred. A delayed hemorrhage can also occur. So I think an ultrasound orbit would have helped in those situations. Obviously, you went ahead and thought it to be an infectious cause, but I just wanted to know whether there were any signs of infection per se.
Any discharge on any watering?
No, sir. There was no discharge. However, the patient did had some watering, which we thought might be due to since the patient had gone pterygium excision. So, due to the betadine, we have povidone, iodine we had used during the surgery.
Okay.
So now we can, Dr. Ekta, you can stop sharing your screen. We can have Dr. Ashna Gupta presenting now a unique case of bilateral iridocorneal endothelial syndrome, eye syndrome, and its management. Dr. Ashna, you can start sharing.
Yes, sir. I'm sharing my screen now. Are my slides visible?
Yes, please start your slideshow.
Sure. Good afternoon, all. Today I'll be presenting a unique case of bilateral iridocorneal endothelial syndrome and its management. So starting with the brief introduction to the syndrome, it is a rare ocular disorder which comprises a group of conditions characterized by structural and proliferative disorder of the corneal endothelium, anterior chamber angle, and the iris and pupil abnormalities are also seen. So this syndrome has basically 3 clinical variants with overlapping features, that is Chandler syndrome with more of corneal features. Secondly, essential or progressive iris atrophy, mainly presenting with correctopia, polychoria, and other iris atrophy features. The third one, iris nevus or Cogan-Rees syndrome with the multiple pigmented iris nodules. So, a 35-year-old female presented to us from Medinapur, West Bengal, with the chief complaints of chronic progressive decreased vision in her right eye for the past 1 year. Then she suddenly developed right eye ocular pain associated with redness and burning sensation for the past 1 month. Then these features were also associated with photophobia, colored halos, and watering. There was no history of any ocular trauma, no history of any other systemic comorbidities in the patient, and there was no similar history in the family. On ocular examination, the vision in her right eye was counting fingers 1 meter and left eye was 6 parts. Intraocular pressure was measured to be 50 millimeters of mercury in the right eye and 10 millimeter mercury in left eye by non-contact tonometry. In conjunctiva, circumcorneal congestion was seen. Cornea was hazy with bullous keratopathy associated with DM folds in the right eye. Iris details were not visible because of hazy cornea. So was the fundus was not visible due to hazy cornea. Gonioscopy even could not be performed due to bullous keratopathy. In left eye, features in the cornea we could see, since the cornea was clear, but there was beaten metal appearance. In the iris, there was features of correctopia, iris atrophy, along with the iris nevus. Fundus was seen to be absolutely normal with no disc cupping or any other fundus abnormalities. On gonioscopy, a high iris insertion was seen with non-visualization of trabecular meshwork, and there was associated peripheral anterior synechiae. So this was the right eye. Hazy cornea was seen, and bullous keratopathy was seen in the center. And other anterior segment findings were very hazy along with the posterior findings. In left eye, though the cornea was clear, but beaten metal appearance was seen, and correctopia with iris atrophy and pigmented iris nevus was seen. This is the gonioscopy we did in the left eye. As we can see, there was no trabecular meshwork was not seen, and there were peripheral anterior synechiae. In the specular microscopy of right eye, hexagonal cells have increased. There was pleomorphism, and corneal endothelial cells were decreased. During the course in the hospital stay, we diagnosed the patient to be bilateral ICE syndrome, which is quite rare. Most of the cases since present with unilateral ICE syndrome. So we had bilateral ICE syndrome with right eye secondary glaucoma with corneal decompensation. Immediately IV mannitol was started along with topical anti-glaucoma medications, mainly echosuppressants, which resolved epithelial bulla along with decrease in the IOP, but surgery was further planned in view of secondary glaucoma. So right eye trabeculotomy was done, augmented with MMC. Post-operatively, right eye IOP reduced to 50 millimeters of mercury, and after 7 days, visual acuity also improved little bit to counting fingers 2 meters from 1 meter with the functional filtering bleb. Corneal edema decreased, but surgery couldn't clear the corneal haziness because of long-term corneal decompensation. But what happened post-operatively, 2 months after, bleb was observed to start getting vascularized, and IOP was also increasing slowly to, it was seen to be 25 millimeters of mercury, and therefore bleb needling was done again with the MMC, mitomycin C. Post-operatively, this was the right eye. As we could see, the bullous keratopathy had resolved and corneal haziness was also less. And this was the bleb, well-functioning filtering bleb. But after 2 months, as in these cases, the bleb started to get vascularized. Coming to the discussion part, trabeculectomy with antifibrotic agents is the surgery of choice for ICE syndrome patients. According to previous studies, 69% of the success rate have been seen, while in another study by Yanov and Duker, they reported a 64% of success rate post-operatively after 1 year, and 36% success rate after 3 years. So these surgeries have strong initial success rates, but unfortunately failure occur more rapidly than with most other types of glaucoma for a variety of reasons, like the main reason being robust subconjunctival fibrosis in these patients. Another important cause of ICs related failure of these surgeries is endothelial membrane, which is growing over the angle and occluding the filtering ostium. Also pars formation that can obstruct a drainage pathway. So aqueous shunt surgeries have also been considered by a few people as the common first-line surgical approach for these patients. Given the intractable nature of this disease, success rates have been reported to be slightly better than just trabeculotomy with antifibrotic agents. So concluding, diagnosis of this relatively rare ocular disorder can be sometimes challenging, but with the detailed examination of all the segments of eye and properly investigating, the diagnosis of ICE syndrome can be made and managed accordingly. Thank you.
Thank you, Dr. Ashna, for the case. I have a few questions. So, Dr. Ashna, that you said that the bleb had failed and the corneal edema failed to subside after the surgery. So, what do you think? What is your next plan of action for this patient?
Ma'am, since these patients' surgeries have very high chances to fail, we were planning to get shunt surgery done. But the patient was, since she was poor and was coming from a far off place, she could not follow up with us.
Okay. And for suppose you did a shunt surgery for her and IOP gets controlled for the cornea, what could you have done?
Even after doing the shunt surgery, since of long-term corneal endothelial decompensation, we would have thought of ahead with the keratoplasty.
What was the other eye status? Other eye cupping, fundus?
The other eye fundus was normal, ma'am. No much cupping because IOP was also normal. It was just the more of iris atrophy features, like it was starting. Beaten metal appearance in the cornea was there.
Visual field or OCT RNFL was done for the other eye?
OCT RNFL, yes, ma'am, done. It was normal. Cupping was not there, and RNFL OCT was done. Fields, they were also normal.
Because that you have features of eye syndrome in the other eye, you're gonna expect that almost 50 to 75% of these patients will eventually develop glaucoma. So it's now the other eye which needs to be closely monitored for IOP control.
Yes, ma'am. Since the right eye presented in an acute condition, so our main concern at that time was to control the acute condition in the right eye first. Then we would have followed up the patient, but the patient was not compliant with the treatment.
Okay. Any other questions? If not, then we can move to Dr. Prashant Girish.
We can move to the next one.
Okay. So Dr. Prashant Girish will present 3D printing of the eye, a novel innovation in surgical training.
Yeah, very good evening. So shall I share the screen?
Yes, please.
Yeah. The screen visible?
I can see a white screen. Your screen has started sharing, but I can see just a white screen.
Now is it okay?
Not yet.
Is it there?
No. I think you can go back, stop sharing and share again with your screen option of sharing the desktop.
Oh yeah, got it. It's coming whiteboard and Microsoft DOS print.
No, you can open your desktop, like the first option that comes in the screen sharing. You can use that.
Okay, the thing is there are only two options coming. One is the whiteboard and the other is the Microsoft DOS 3D print.
You can open your presentation in the computer and then click on the option to share screen, and then I think you'll see the PowerPoint window as another option. Are you able to?
Yeah, can you just see now if it's coming?
Yeah, please start your slideshow. And
it's okay now?
Start your presentation, yes.
Yeah. A very good evening, and I thank DOS for giving me the opportunity to present here. The topic is 3D printing of the eyeball, a novel innovation in surgical training. And my name is Dr. Prashant Girish. And as we know, 3D printing was first invented by Charles Hull in the 1980s, and it is described as a stereolithography on the printing of successive layers of material on top of each other to create a 3D object.
Sorry to interrupt you, Dr. Prashant, your slides are not moving.
Slides are not running.
It's moving for me.
I think then there's some problem in your connection.
It's not on full screen also. First convert it to full screen and then move the slides.
I think you can.
I think you can stop sharing and then restart sharing.
Okay, is it possible now? Is it moving now?
No.
Okay, awesome.
Can somebody from the back end help us, please?
No, because before I checked it, it came for sharing. Can I just disconnect and come back in a minute, if it is okay? Or
okay, you can try that, but I don't think
sharing
that
again.
will help.
Once try sharing.
yeah, I'll try sharing.
Put it on slideshow.
Is it okay?
Okay, it's not coming to the slideshow. You're just able to see. Or
can you please
go in the tab of the slideshow and then start from there, maybe?
Yeah. On the top that you see the slideshow button.
Yeah. Is it coming now?
No.
Go from the top slideshow button that you see on the taskbar on the top.
Actually, I think you have to select in the screen share option. Yeah, now it is. Now it's coming. Okay.
Is it moving?
Yeah.
Yeah.
Please start.
So sorry. So yeah, I'll just start again. It's on the 3D printing of the eye model, a novel innovation in surgical training. As we know, 3D printing was first invented by Charles Hull and is described as the stereolithography, or the printing of these successive layers of material on top of each other to create a 3D object. And we have three types of 3D printing, the 3D printing in stereolithography, digital light projector 3D printing, and multi-jet 3D modeling in inkjet 3D printing. So today, mostly the case we modeled and designed is based on the stereolithography, which is based with ultraviolet sensitive photopolymer, and which solidifies into the beam and gets object by object layering. So before I going into the case, I just wanted to give a brief about the process of 3D printing. Initially, if you see, the process starts with CAD software that we designed the model, and then we converted into the stereolithography or the .stl file, which is then transmitted from the USB into the 3D machine. Now, then what happens is it goes into the fused deposition modeling, which is also known as the fused filament fabrication takes place. And the materials used are polylactic acid, which is a PLA, or the polyvinyl alcohol acrylonitrile butadiene is more biocompatible. And then you can see here, this is the injection, which is having a molten, and there is a heated extrusion nozzle, which takes layer by layer in your two-dimensional slices. And it also depends on the size and complexity and the resolution, where it can take from 20 minutes to 20 hours. And 3D printing has always been evolving in the medical applications for more of customized modeling, resolutions, accuracy, cost effectiveness, and also creating anatomical and structural with also patients' actual disease process to replicate. So in ophthalmology, we have 3D models which have been stimulated for bone templates in planning for surgeries, 3D printed pupil expanding devices by the Canabrav's pupil expanding device. We have Fittle's innovative braille for the blind, 3D printed acrylic lens for the smartphones, Dr. Coulter's blepharoplasty forceps, and 3D printed lens spectacles. It has also been used in orbital surgeries for anatomy training for ophthalmologists. Our 3D eye model case, as we know, we first designed in a CAD software, as you can see, and trying to convert into a .stl file. So initially we had dimensions of the eyeball, and then we also try to see on different segments of the eye, from cornea to the extraocular muscles, a posterior chamber, to keep the nucleus. And then we also came to a conclusion to get a model which is having eyeball in shape. And then after converting it into with the pen drive, we printed out in the Markabout replicator printer using the ABS material. As you can see, the extrusion, which is the heated extrusion, going layer by layer. And this print usually took around for us of around 1 hour to 1 hour and 30 minutes. So once we print the 3D printed eye model, we got something like this eye model. Then we made a bit of painting to look more aesthetic, to get some glow reflex and iris printing. And finally, we ended up getting this eyeball and mounted with the acrylic mold. So the cornea was kind of looking like an acrylic mold, because printing a cornea with a transparency kind of a mold will be with a laser printer. So this was mostly of an acrylic mold, and it was 3D printed in an ABS, and we made 2 holes for putting up the phaco probe as well as the Sinskey. And it is used for the young surgeons and also all learning phaco surgeons as dry labs. And we kept the phaco acrylic clay, which could be kept here for the dry lab, as well as the cataracts, which came from the manual small incisional surgeries. And you can always practice your trenching, your foot pedal controls, your chopping techniques. And this is very cost effective, and the acrylic corneal part is detachable, where you can always reuse it, and that way it will become very cost effective also. And of course, the materials of this 3D printing can be in more softer materials, so more surgical techniques can also be practiced, such as the scleral fixated, IOL, and iris fixated. So to summarize, this will be the model where the wax model is also created for molding of the acrylic, and you have the 3D printed, which is by printing by the polymerase resin, and the simulation transfer and packing into the acrylic, and then the final polishing will take place. So in conclusion, why in this case situation being presented, the 3D printed eye model helps in the surgical training, and the learning point is many innovations like the 3D printed eye model is possible with emerging and newer technologies will help in the enhancing the learning curve of the surgical training. And thank you. And these are the various 3D printers available, which are commercially available in the market, as well as there are different types of materials that we can get depending upon the type of surgeries that we want to practice and train. Thank you.
Dr. Prashant,
Yeah.
it was a nice presentation.
Yeah.
Could you let us know what is the approximate price of these 3D printers?
So
what is
we
the
have
cost that comes out of printing an eye for surgical training? So what will be the total cost that will come?
So 3D printing models, we can range from around 50 to 80,000 to it can go up to 2 lakhs or 3 lakhs or even 5 lakhs. And the thing is that it doesn't require that we need to have a 3D printer by ourselves to print one. Even if we have it in a common platform or a place, we can always get the design there, send it to the printing places, and they would print and give it back as the model. So, and the cost will always depend on the type of model that we are going to do, with the number of, extrusion layers that we want to do, or the size of the product we can design on the cost. On an average, this will be very cost effective because it will be fairly around 2,000 or 3,000 rupees, which could be able to be done. And it's flexible, because different printers have different rates which they can come up with, and it is reusable also.
And how do you suggest that it can be used for cataract surgery training? Because you told that the clay has to be used, or human nucleus has to be inserted in it, and then it has to be
exactly used. You can use acrylic clay, or the manual incision, small incisional cataracts which we get out can also be used to get the real-time feel of the human lens.
I think,
or we have, yeah.
For that purpose, I think goat's eye will work better because it will have a natural lens in it, which will be supported by the zonules. Because in this, you are saying that clay will be inserted or a human nucleus will be inserted, then it won't be supported, and then the basics of capsular and those cannot be performed on this, I think.
Yeah, very good. So what happens, what happens is that we have a capsular bag in which you can keep the nucleus. And if you also want materials like the capsular rhexis to practice, that could also be printed by a thin sheet. It could be printed by 3D printing, but you can also practice the capsular rhexis.
That will be more useful for
definitely. So this is the complete box of practicing, with the 3D printed eye models. And this will also be useful in places where, the goat's eyes are not available. In some part of the districts where you find the goat's eyes are not available in national or international areas, also the 3D printed could be a substitute for the dry wet lab, especially in times of, difficult situations. We will find that, training tools like this will come in handy for sure.
Dr. Prashant, it was a nice presentation. Now that we've seen so much of interest in 3D printing, is any experience in trying this out for development of orbital implants or shells, the external shells?
Yeah, the prosthetic implants is also one of the areas of 3D printing which is being coming. But the only thing is there is a little bit more of the cost involved in that and getting the sizes and shapes. So it's going to be more customized kind of a model which can be happen. But there are places which is being happening now with 3D printed processes.
I think that brings us to the end of our session. I hope that our judges have already made their markings and they can email the mark sheets directly to the DOS secretary. I thank all the participants for joining us and keeping their presentations to the time. Thank you, Dr.
We need
Devesh.
we need to email it, or it's on a Google Sheet. We just share it.
You can share it with her on the email namrata.sharma@gmail.com, and they'll compile the results.
Okay.
Also, the final results for these free paper presentations, the winners, etc., will be announced later, and probably we'll have a session of the certificate and award giving in physical form after a few weeks, I think. So I think that will be intimated by emails.
Okay, it was a nice session with a lot of good presentations. I think, Prakhya, then we can conclude the session.
Yes, sir. Sure. Thank you so much. Thank you everyone for joining us.
Thank you.
Thank you, Docs. Thank you, judges.